तेरा लेजर किधर है? So very good morning to all of you. नमस्कार. मेरा पहला नमस्कार माँ सरस्वती, प्रभु गणेश जी को, माँ लक्ष्मी और सभी देवताओं को. और I am thankful to all of you for coming in this 10th edition of Cardiocon, and it is a special occasion for all of us. Most of us has been associated for this journey for 10 years. I am seeing the people who were here around 10 years back also. So to be on the time, we will start the proceedings, and we will start the academic sessions. We will do the inauguration oration, then we will realize we will discuss something about this journey. But we will start with the academic session, and Gurukul हम शुरू कर रहे हैं पहले. And the first session will be taken up by Dr. Sunandan Sikdar sir. Sir is one of my teacher. He is said to be the one of the finest student the Delhi or Indian cardiology has ever produced. The current HOD, आप वो लगा दीजिए सर. The current head of the department of GB Pant says that now this type of students rarely come in last 20 years. Sir is always, remain always a topper. And Dr. Sunandan Sikdar is based in Calcutta now. He is alumni of GB Pant Hospital. Now he is working with Narayana Hospital and Calcutta. He has published books. He has so many publications in international journals, and he is editor of a very rare book, the Handbook of Cardiac Critical Care and Anesthesia. So I think this is the only book, and that was published by Taylor and Francis. So he is one of the academic person that you can rely on. And in one word I can say कि जो हम पास होते थे तो सर 40 पेज लिखते थे कार्डियोलॉजी के, और डीएम कार्डियोलॉजी इतनी आसान, उस टाइम पर सारे इंडिया से ब्रिलियंट स्टूडेंट आते थे तो सर के वो 40 पेज पढ़ के और सब पास होते थे. इट वॉज लाइक दैट. And so I will start with Dr. Sunandan Sikdar. Sir will teach us on pulmonary embolism, case presentation and newer treatment options. Pulmonary embolism is a very common phenomena now. Pulmonary layman term में बोलें तो जो क्लॉट बनते हैं वो अगर हार्ट की तरफ चले जाएं, क्लॉट आजकल बड़े कॉमन हो गए बिकॉज ऑफ इमोबिलिटी. पहले हम सोचते थे कि ओल्ड जनरेशन्स में है, ये हर जनरेशन में हर एज ग्रुप में पॉसिबल है. एंड दिस इज मोर डेडली देन दी हार्ट अटैक, और मॉर्टेलिटी काफ़ी ज़्यादा है. एंड आई विल इन्वाइट टू चेयर दिस सेशन वन ऑफ द डॉक्टर राम शर्मा सर. Sir is one of my teacher also. Sir is head of the department Hindu Rao Hospital Delhi in cardiology. Then Dr. D.D. Arora sir, please come on the stage. And sir please आइए sir, आइए. आइए sir please. Dr. Satyesh Pandey sir, sir please. And sir Gaurav Agrawal sir. So are we live?
So I'm able to, Pawan, are you able to hear me?
Yes, sir, you are quite loudly audible.
Okay. My camera has some problem. I do not know why it is not going on, but we'll start the program. So we will be just going about the pulmonary embolism. And so all the, there is a good morning for all the delegates, all my chairpersons and moderators. And we start this session with a very important topic which cuts across the entire spectrum of cardiology and also critical care and also partly medicine, because pulmonary embolism is ubiquitous, and with rising survival rates from cancers, with rising age of all of our patients, this disease is likely to go up, just like we have atrial fibrillation, which is going up. So unlike coronary artery disease, which will go down with preventive measures, pulmonary embolism and atrial fibrillation, these are the two conditions which may go up in future. as we have an aging population with increasing cancer survivors. So first, we will go about discussing this entity in a specific way. So we have a pulmonary embolism, which we fear may cause sudden loss of life, and that is a hemodynamically significant pulmonary embolism, that is severe pulmonary embolism. And how do we define it? We will be discussing about this aspect, not the entire aspect of pulmonary embolism, which stretches from mild to severe and also preventive aspects. We are discussing only the very severe pulmonary embolisms, which can lead to loss of life. So what is the pathophysiology of pulmonary embolism? So to summarize it in a one slide, here it is written, and here we can see also the diagram. Pulmonary embolism actually takes our life because there is an increased RV afterload which causes obstructive shock. So when there is an RV afterload which goes on rising, the right ventricle dilates, it leads to tricuspid valve insufficiency, that is an increasing amount of tricuspid regurgitation, and there is rising right ventricular wall tension, and it leads to neurohormonal activation, and also it all leads to RV ischemia. So right ventricle becomes ischemic, right ventricle becomes dilated, and there is a loss of preload to the left ventricle. So the left ventricle cannot pump because there is less amount of blood flow coming in the inlet of the left ventricle, and it is also pushed by the left interventricular septum, and along with it there is coronary ischemia because of falling blood pressure, and also because the right ventricle becomes dilated and presses on the left ventricle. So coronary perfusion, particularly RCA perfusion, will fall, and as a result of this there is a shock which is just not obstructive, but also it becomes caused by ischemia from the falling blood pressures. So increased pulmonary vascular resistance lead to right ventricular dilatation, hypokinesia, and interventricular septal deviation. It leads to lack of preload in the left ventricle, and it leads to reduced cardiac output and systemic arterial hypotension and RV ischemia, infarction, and failure. So there are a lot of neurohormonal mediators included inside this pathophysiology. Important are thromboxane, endothelins, serotonins, all of them. And also there is, as we know, like in a coronary artery disease or coronary tree, fibrin, platelets, and RBCs get entangled, and the clot goes on increasing. So there is actually a revised Geneva prediction rule for pulmonary embolism. This is in the ESC guidelines, and this can be used for prediction of pulmonary embolism. So if there is a score of more than 5 in simplified version, then we say it is pulmonary embolism. Suffice to say that if you have a heart rate of more than 100 and blood pressure of less than 100, and if you have a patient who has a DVT or has a risk factors for DVT like cancer, or if the patient has one limb which is swollen, or a history of surgery or an orthopedic surgery, so these are the risk factors. If these are present, then likely the diagnosis will be a pulmonary embolism. One important point about pulmonary embolism is this, that it is often missed. It is missed because we do not keep the diagnosis in our mind when we are seeing the patient. But many a times, a patient who is having sudden hypoxia or a patient who is sudden hypotension, we must keep this diagnosis in mind, particularly if there are risk factors. Though it may take place without risk factors, there are often patients who comes in without a risk factor, and suddenly we find that this is a case of pulmonary embolism. But most of the times, pulmonary embolism has some risk factors, and if they are present and the BP is less than 100, pulse more than 100, and there is a risk factor, we always should think of pulmonary embolism. So what is the presentation of pulmonary embolism? there are actually, if we go through this, 4 types of presentation. The first and the most important presentation, which may change the outcome of a patient, is the diagnosis of a massive pulmonary embolism. The second group is submassive, which is divided into 2 groups, high risk and low risk. And third is small to moderate pulmonary embolism. Nowadays, we actually divide it into 3 groups. One is severe pulmonary embolism, one is intermediate risk pulmonary embolism, and another is low risk. So submassive is a term which is gradually being going to the background, and the term that we are more using is intermediate risk pulmonary embolism, and this is actually divided into 2 groups, that is high risk and low risk. Among the intermediate, there is also high and low, that is made by presence of troponin T positive or troponin T negative. So in a massive pulmonary embolism, how do you define a massive pulmonary embolism? So massive pulmonary embolism is defined as a systolic blood pressure which is less than 90, plus there should be an organ hypoperfusion, plus either a saddle emboli, that is in the bifurcation of right and left pulmonary arteries, or a LPA or RPA thrombus. And this massive pulmonary embolism, which we have actually a low BP with a organ hypoperfusion with a thrombus in the bifurcation of the pulmonary artery, this can present in 3 ways. One is the cardiac arrest, another is an obstructive shock, and third is persistent hypotension. So cardiac arrest, obstructive shock, and persistent hypotension, these are the 3 presentations of massive pulmonary embolism. They can present with cardiac arrest, which is usually a pulseless electrical activity, PEA, or it can have an obstructive shock where you have a BP of less than 90 or using a vasopressor to make it more than 90. Or you can have persistent hypotension where systolic BP is less than 90 or a BP drop of more than 40 millimeter mercury. So there is also a criteria, that is pulmonary embolism severity index, or PESI. So what we do with PESI is to triage. It is to triage. So you triage for high risk. Same thing, SBP less than 100, heart rate more than 110, and a very elderly patient, a patient of cancer, history of heart failure and lung disease. So this is what we were saying. So classification of pulmonary embolism severity as per ESC is now high, intermediate, and low risk of death. And intermediate is again divided into 2 groups, high, intermediate, low. So if there is low BP, there is shock, then the patient straight away goes into high risk. If there is no shock, then the next step is given by echocardiography, whether there is right ventricular dysfunction or not. If there is dysfunction, then we definitely think it is an intermediate group. And then you go to troponin. If troponin is positive, it is intermediate high. If troponin is negative, it is intermediate low. So if RV dysfunction is not there, troponin is negative, and BP is normal, then it is actually a low risk of death. So high, intermediate, and low. Our discussion will be predominantly with the high risk and the intermediate high risk. So this is an algorithm, and to summarize this, just go in a very short way how to remember them. First, a patient of pulmonary embolism comes, look whether there is a shock or not, which is defined by a systolic blood pressure of less than 90. So if there is shock and systolic blood pressure is less than 90, or you have to give vasopressors to maintain it, then it goes straight away to the high risk group. If their BP is normal, you have to rule out other causes of shock, definitely, like hypovolemia and sepsis. If sepsis is not there, hypovolemia is not there, and the patient is in shock, So it is likely that it is a high risk pulmonary embolism. If the patient does not have shock, then the diagnosis is intermediate risk or a low risk pulmonary embolism. So you look for echocardiography. If there is RV dysfunction, it is high risk. If it is troponin positive, then it is very high. It is high risk. And if there is troponin negative, then it is intermediate low risk. But if all are negative, that is BP is normal, RV dysfunction is not there, troponin is normal, then it is low risk. So what is the usual prevalence of this? So the most common is low risk pulmonary embolism. Nearly 60% will be low risk pulmonary embolism. High risk with mechanical or hemodynamic instability will occur only in 5%. So what is our task? Our task is to establish perfusion, ensure hemodynamics is okay, and enable tissue oxygenation and avoid the disease to recur. These are the goals of treatment. Actually, there is a mortality, very, very high mortality in case of high risk pulmonary embolism, which is nearly 50%. So 50% is mortality of pulmonary embolism, which is much more than MI. So if you have a MI with cardiogenic shock, it is equivalent to a pulmonary embolism. Both of their mortality nears 50%. Only 1/3 of high-risk patients are thrombolyzed because of various reasons. Sometimes physician ignorance. Sometimes it may be due to very serious nature of the patients or the bleeding risk. 1/3 of the patients are thrombolyzed. Majority are not thrombolyzed. So you should thrombolyze a patient who has hemodynamic instability. And the agent for thrombolysis is RTPA, and that should be used if there is hemodynamic instability. But we will present a case where you cannot thrombolyze a patient. And herein, we are coming to such a paradigm that this has been changing for some time, that thrombolysis, just like in case of an MI, we had thrombolysis coming in first, then primary angioplasty coming in. So in case of pulmonary embolism, probably we are moving away from the thrombolysis age to the age where we will be doing mechanical aspiration of the pulmonary embolism, and the results are much better and faster than thrombolysis. So here we come to important thing. There is a contraindication to systemic thrombolysis, just like in an MI. So if there is a high bleeding risk, like a patient of head trauma or spinal injury or active bleeding, or a history of recent surgical or invasive procedure, which is very common, because pulmonary embolism will take place after an invasive procedure or surgical procedure, so the bleeding risk is very high. Here we present a man, a 78-year-old man who presented with dyspnea of acute onset. So patient with dyspnea of acute onset and history of operation for subdural hemorrhage 1 week back. So this man with dyspnea of acute onset presents with the ECG that we have shown. Now, what is there in the ECG? We know that some telltale signs of pulmonary embolism are there. One of these most telltale signs of pulmonary embolism is that there is usually tachycardia and T-wave inversion in the anterior leads. Sometimes there is S1Q3T3. This phenomenon is, though rare, is more specific. But here in this ECG, we neither have any tachycardia, neither have we any T-wave inversion, very small T-wave inversion in the anterior leads. So when he came to ER, he was initially diagnosed as a patient of heart failure and some sepsis. So he was given diuretics and he was started on antibiotics. But this patient didn't improve. A 78-year-old man with subdural hemorrhage history 1 week back. So as we see in the ECG, there is nothing to suggest that there is pulmonary embolism. And you can see here the T-wave inversion is there in V3, V4, V5. So T-wave inversions are there. S1Q3T3 pattern is there. These are the things that we should look. but in this ECG, we do not have any. However, that this patient was desaturating and this patient had a history of subdural hemorrhage prompted us immediately to look for an echo. And what we saw in the echo will come here. So once we look at this echo, we can see that this patient has a dilated right ventricle. So dilated right ventricle, which is compressing on the left ventricle. And if we look closely, this right ventricle has dysfunction predominantly in the base, but not in the apex. This is called McConnell sign. So the apex is contracting, but the base is not contracting. This is one of the very specific features of pulmonary embolism. We can see here the TR that has taken place. So we can see the tricuspid regurgitation jet, which is seen in blue and yellow, and a dysfunctional right ventricle with preserved apical function. So this is one of the telltale signs of pulmonary embolism, and we go back to the echo findings. So these are the echo findings of pulmonary embolism. Enlarged right ventricle, which is pressing on the left ventricle, we can see in the figure B, and the RV and LV ratio at base, how you measure it is being shown there, is more than 1, that is RV more than LV. There is flattened interventricular septum, a distended IVC, and a 60-60 sign. That is the pulmonary artery pressure should be less than 60 and acceleration time should be less than 60. And you may also see a thrombus sitting in the right ventricle or right atrium. Or you can see right ventricular dysfunction, that is TAPC less than 16, and decreased peak systolic velocity in tricuspid annulus, which is less than 9.5. So these are the echo features. In our patient, you can see here very beautifully seen, right ventricular apex is paired, right ventricle is enlarged, and the base has little contraction. So this is what we call the McConnell sign. And there is a tricuspid regurgitation jet, which is quite big. So this is the TAPC. Our patient's TAPC is approximately around 16, which is just the cutoff. And we can see the right ventricle is enlarged. So there is a prognostic value of echocardiography in patients with acute pulmonary embolism. And what we see is that if the TAPC is less, if it is less than 20, the mortality is somewhere near the normal. But if it is less than 16, there is a huge difference in mortality, and the mortality goes up rapidly. This is the CT scan of the patient. And as you see, in the CT scan, you can see the black areas. So the black areas are the thrombus that has been lodged in the both pulmonary arteries. It is not a saddle thrombus, but simultaneous thrombus is present in both right and left pulmonary arteries. You can see the thrombus sitting there. You can see also in the right sided image the hugely dilated right ventricle. So right ventricle is almost at the base more than twice the left ventricle. So this is another telltale sign of pulmonary embolism. And CT signs of right ventricular dysfunction, one of the most important is this right ventricle to left ventricle ratio more than 1. And this also has been shown to be prognostically important. So what options do we here have? So we cannot thrombolize him because this patient has a history of subdural hemorrhage just 1 week back, and this patient hemodynamics are poor and he has a lower blood pressure. So he straight away goes to high risk. We have to do something, and that is something is what we can do is mechanical thrombectomy. So catheter directed mechanical fragmentation of the clot and aspiration. These are the things that we can do, and that system is now available in India, and that we call indigo aspiration system. So this indigo aspiration system or the penumbra system is actually a catheter which goes into the right ventricle from the IVC to the right atrium to the right ventricle and to the pulmonary arteries. from the pulmonary artery which suck out the clot, and there is a motor which sucks out this clot, and as a result, the clot burden of the pulmonary arteries goes down. So this is the picture of, you can see here the clot sitting in the right pulmonary artery. So you can see the clot and the catheter also. And here on the left, we have the tracings, and we can see the right ventricular pressure is raised. So these are the clots that you can see here. There is a aspiration system, and it sucks out just like a sucker, a clot which is sitting there. It has been shown also in the Gauge piece, the clot lying there. And once you have this taken out, you give a pigtail shot and see whether the clot has disappeared. So catheter-directed mechanical aspiration thrombectomy has a real-world experience on a number of registries. Most of these have shown that it is quite a safe procedure, and approximately time required is less than an hour and sometimes something around 40 minutes. And what you can do is that there is a rapid improvement in the RV-LV ratio, and the RV-LV ratio, which is more than 1, usually comes down. So the hemodynamics and the vitals after catheter-directed mechanical thrombectomy, you have seen that. And as we can see, the RV-LV ratio comes down from 1.4, which is the mean, and to 0.94. So we can also see that there is a reduction in pulmonary artery pressures, hemodynamics improves, and that occurs quite rapidly and with less bleeding risk. So bleeding risk is quite reduced with this pulmonary aspiration. So this is a trial that was done on this indigo aspiration system, that is extract-P trial, and which showed that there was a near 27% reduction in the RV-LV ratio. And it has a very short procedure time and makes the hospital stay much shorter. So to summarize, massive, submassive, and high-risk patients of pulmonary embolism, that is those with RV dysfunction, plus troponin rise, or those with low BP, should have either thrombolysis or thrombectomy. Those who have history of high bleeding risk, or those with history of recent surgery, they can be candidates for removal of the clot that we call mechanical aspiration system. Thank you.
A very good beginning, I should say, of the conclave. And Professor Siddhar, he has been teacher of Dr. Pawan Sharma. So a very good beginning you have done, sir. Congrats. And we had a very good beginning for the conclave. Thank you, sir.
So, Pawan, can you transmit the question? I am not able to hear the question.
Yes, Dr. Sunandan, thanks a lot for a beautiful presentation. So mostly all of us are basically OPD physicians also. And so, sir, what are the 2-3 signs or symptoms initially we should see for the pulmonary embolism patient? The early signs and the prevention of pulmonary embolism. We want to discussion on that, please.
So, in case of subacute pulmonary embolism, for acute pulmonary embolism will present to emergency mostly, not to OPDs. But those with pulmonary embolism, which is not an acute hemodynamically collapsing embolism, you can find a history of cough, because low risk pulmonary embolism will present with cough with hemoptysis. This is because of the infarct that takes place in the peripheral pulmonary arterial tree, and cough with hemoptysis is one of the presentation, but more ominous presentation is a gradually increasing dyspnea. So a patient who has a history of surgery has a gradually increasing dyspnea over, say, 1 week, 2 weeks, you must exclude pulmonary embolism as important cause, because these patients can be treated very well and they can recover. But if you cannot diagnose this, there are other problems that can take place in the long term. That is, RV dysfunction can take place, and you can have a swelling of the feet, and in long term you can have pulmonary thrombus which will organize in the long term and cause pulmonary hypertension. So smaller pulmonary embolism may not make the patient collapse on the floor, but may cause pulmonary hypertension in the long term.
So
Dr. Arora, sir.
Before reaching to the hospital, what measure to be taken? Before reaching to the hospital. What
Can
to
you
be done?
transmit the question, Pawan?
Sir, sir is asking, Dr. D.D. Arora, that on a basic note, if somebody suspects a pulmonary embolism, what they can do before reaching to the hospital in OPD? It is difficult. For example, we have discussed about ACS or cardiac symptoms or cardiac heart attack, where we can use Disprin. Sir wants something, is anything can be given on the OPD base or on the OPD chamber to a suspected case of pulmonary embolism?
Pawan, the answer actually is very important. He is asked a very basic question. What is the preliminary treatment? So we have to understand the basic problem of pulmonary embolism is right ventricle which is not able to pump. So first thing that you can give to this patient, we give two things. One is start the patient on oxygen and start the patient on saline, because you have to maintain the BP till this patient goes to the hospital. If you don't have any vasopressor, you start the patient on normal saline and also on oxygen, and then you put the patient on ambulance.
Yes,
So that will work like your aspirin. You cannot give the loading dose and what we give in ACS. But here the main thing is to start on oxygen and put in saline. So you take care of hypoxia in one step of oxygen, and also you can take care of the hypotension.
Yes, very, very good, sir. So oxygen and yes, sir, Arvind. Sir, is chest X-ray helpful in diagnosing pulmonary embolism?
Yeah. So the chest X-ray is very helpful in diagnosing pulmonary embolism in the opposite way. So there is not much telltale signs. There are some signs like Palas sign, but these are very rare and these are mostly written in textbooks, not seen in real life. So the main thing is, if the patient of a post-operative patient is hypoxic and the chest X-ray is normal, so the likelihood of pulmonary embolism is higher. So normal chest X-ray which does not show collapse, which does not show pleural effusion, which does not show consolidation, is likely that you more think of pulmonary embolism and do an echocardiography as early as possible.
So a normal chest X-ray, sir is saying, basically it is to with tachycardia, we can say the tachypnea, progressively increasing shortness of breath, but with normal chest X-ray, sir. So, Dr. Ram Sharma, sir. Yes.
Thanks, Dr. Sikdar. There is one important question just related to your thrombectomy. How many patients in clinical practice actually require thrombectomy? Number two is, what are the limitations of thrombectomy? Third is, what are the likely complications of thrombectomy?
Dr. Ram Sharma, sir, is head of the department in Hindu Rao Hospital. One of the friend of Dr. Sunandan is also a very good friend of Dr. Jamal, sir. So, sir, question is towards intervention cardiology. Beyond that, sir is asking how many patients will be with aspiration will require this aspiration thrombectomy or the penumbra, and what are the contraindication, and is it, although the trials are showing helpful, so sir wants some tips on this penumbra or the aspiration catheters.
Yeah. So those patients who are post-surgical and thrombolysis is a little bit difficult or risky, those very elderly, like this patient was 78 years old, his body weight was something around say 50 kgs, you give heparin and if you give thrombolytics, there is a high chance of bleeding. These patients can be taken up for this procedure. The advantage of this procedure is it makes the clot burden low within very short time. So if this patient, if the affordability is there or the machine is available, so these are the patients who can be taken. And I think with increasing awareness, this procedure will become more widespread, and that will help in reducing the morbidity and mortality of pulmonary embolism. As far as the technical part goes, the catheter is not that wide bore. Most of this can be done with 8 French, and the risk of pulmonary artery perforation, which is one of the only what I can say serious complication of this procedure, is quite less if you can handle the catheter well. So it is mostly a very safe procedure, but it has to be done in a short time. And only one thing that I would like to say here, because this machine aspirates the clot, it aspirates the blood also. And if it aspirates the blood, there is a requirement of blood transfusion post procedure. This patient had to be given 1 unit of blood. So blood loss is a thing that we can do, that we can manage well, because it is much less risky than having a bleed.
Sir.
So now this is for the general practitioners, not for this. What is the advantage, or what is the now usage of Novax versus conventional anticoagulants we are using in the practice? So which one is better, and which one is not good, or what are the limitations of using all these?
Sir wants to ask about between the Novak or the conventional basically warfarin and acetrom for long-term treatment of pulmonary embolism.
So nowadays we always prefer NOACs, because this has a what I would say less monitoring, less intensive monitoring than warfarin. But NOACs, there are 3 actually agents which you can use: NOACs, warfarin, and low molecular weight heparin. If we go for the relative efficacy, all pulmonary embolism which are not caused by antiphospholipid syndrome, NOACs is one of the very important choice. Those with autoimmune diseases and antiphospholipid syndrome, particularly antiphospholipid syndrome, NOACs is not the first choice. Here warfarin is the first choice. For cancers, if we have pulmonary embolism, small trials have shown low molecular weight heparin like enoxaparin once daily, that is better than NOACs or warfarin. So for cancers, subcutaneous heparin may be better. For antiphospholipid syndrome, warfarin still is the most important, or NOACs are contraindicated. And for most of the pulmonary embolism like post-orthopedics and all this, NOACs can be given.
So, in interest of time, just the because
Especially
sir,
in pregnancy, what do you advise?
Sir is asking about for pregnancy, if a patient is having pulmonary embolism and with pregnancy, so long-term treatment, sir, long-term treatment.
So during pregnancy, you have to use low molecular weight heparin.
Yes, the best choice is always injection. This we can say enoxaparin. The LMWX is the best choice with pregnancy. So thanks a lot, sir. Thanks again, Sunandan sir, for a elusive talk and also a elaborated discussion. You are so crystal clear that it is very difficult and we can have the whole day on your session. So thanks a lot, sir, again. And now I will, for the collecting memento, I can say to Dr. Sachin sir, sir, please, chairpersons, please proceed to that side so that we can pursue with the next session. Thanks a lot, Sunandan sir.
Thank you, Pawan. Thank you. Thanks.
We can answer that with also. So for the next session, Dr. Gyan. So for the next session, we will introduce Dr. Gyanti Singh. Dr. Gyanti Singh is Director and Head of Cardiology in Sarvodaya Hospital, Greater Noida, a very gentle, thorough, patient-caring doctor, and she has over around 20 years of experience, renowned intervention cardiologist with MBBS, MD, DNB cardiology from the leading hospitals of Delhi. And now she is working with the Sarvodaya Hospital, and she will enlighten us on a topic which is from home to, and everybody is interested in that topic, the hypertension. and we will discuss on hypertension starting from the home, what we can do, and then the basics of the hypertension. And for this, so Dr. Gyanti, please. And as chairpersons, I will invite Dr. Prahlad Chawla, sir. Sir is one of my senior and my teacher. Dr. N.K. Gupta, sir. Dr. Shekhar Varsne, sir. Please. And yes, ma'am, koi bula dein. Dr. Gyanti, ma'am. And Dr. Gyanti, ma'am, can also answer the last ma'am was asking about. Please, Dr. Gyanti.
Hello, ma'am. I'm Dr.
Good morning.
Smita this side. Ma'am, I wanted to know what are the preventive steps that we can take so that the embolism does not occur in a patient who are susceptible to one when we say.
When in any surgery, like like GI surgery or after long bone fracture, basically DVT prophylaxis is very important during hospital stay. After 24 hours, you can start enoxaparin, LMWX, and DVT pump also helps in those patients who are immobilized for longer duration. But in pregnancy also, we have seen in some cases, post-delivery some develop DVT, or if anyone complains about, in one leg, if complains about pain and swelling, then you should look for DVT. To rule out, you should do venous Doppler. If DVT, then you should start with oral anticoagulants. And in few cases, we have seen that thrombophilia profile is very important. We should look for what was the cause. Because if there is no, patient is mobilized, there is no immobility, there is no history of surgery, still they develop DVT. In those cases, evaluation is very important, and thrombophilia profile is very, very important. If there is any lupin positive or antiphospholipid antigen positive, then you should start with acetylene or warfarin in those cases. Okay. Good morning and regards to my senior and my colleagues. Today I will discuss about guidelines of hypertension, how to manage and how to monitor blood pressure at home also. We all know hypertension is a major cardiovascular risk factor, and around 1.39 billion people are affected by it, and out of which 10.4 million get premature deaths annually.
So a very prevalent situation, and it is ever increasing. So, अच्छा कोई बात नहीं हटा देंगे.
हाँ ये फिर भी ठीक है गिरने का डर है. अच्छा. So hypertension is one of the most major risk factor for cardiovascular diseases. Early diagnosis and treatment can reduce premature deaths, and we know there are many undiagnosed cases and poorly controlled hypertension cases. So what the ACC and European guidelines said. By ACC or American Heart Association, in office or clinic blood pressure, it should be, when we call definition of hypertension, in office or clinic blood pressure, when blood pressure is more than or equal to 130/80, daytime mean blood pressure is more than or equal to 130/80, at night time mean blood pressure is more than 110/65, 24 hours mean is more than 125/75, So these the findings, if these the parameters comes, it comes under hypertension. Blood pressure target for treatment is to reduce blood pressure less than 130/80. According to European Society, it is slightly on the higher side. When the office or clinic blood pressure is more than or equal to 140/90, it is more than ACC AHA guidelines. Nighttime mean is more than, daytime is 130/85, nighttime mean is more than 120/70, and 24 hours mean is more than 130/80. Home blood pressure mean is 135/85. Here the target is systolic blood pressure, it should be less than 140 or close to 130. Then treatment part. According to ACC-HA, initial single pill combination therapy in patient whose blood pressure is more than 20/10 millimeter above blood pressure goal. Means our goal is it should be less than 130/80. According to European Society, the initial single pill combination therapy in patient whose blood pressure is more than or equal to 140/90. Hypertensive requiring interventions, according to ACC, more than 130/80, and by European Society when it is more than 140/90. Then you start with medications. Importance of home blood pressure monitoring. Take blood pressure at home twice in the morning and twice in the evening, before visiting to clinic. If there is a new onset of hypertension, in those cases, start at least 1 week monitor blood pressure morning and evening. Then therapy is beta blockers is given only in those patients who have comorbidities or other indications like heart failure or coronary artery disease. Not it is used to control blood pressure. Initial single pill combination as initial therapy. In follow-up, detect poor adherence and focus on improvement. It will help by doing home monitoring. Blood pressure telemonitoring and digital health solution are recommended to those patients. Who have new onset hypertension, regular home monitoring is very important. Emphasis on accuracy of blood pressure measurement. Both recommended office blood pressure measurement on repeated visits and ambulatory blood pressure or home monitoring to confirm the diagnosis of hypertension. It's a class 1 recommendation. Ambulatory blood pressure monitoring device worn on the arm, blood pressure is recorded at every 30 minutes interval for 24 to 48 hours. Home blood pressure monitoring, it's a self-monitoring tool, like a digital monitor, battery operated. It is commercially available instrument. Ambulatory blood pressure and home monitoring provide a great number of measurements, which is not done by hospital visit or office visit monitoring. More representative of daily life. Useful for diagnosis of white coat hypertension and masked hypertension. So how to measure blood pressure? The key step for proper blood pressure measurement is properly prepare the patient. Area should be quiet, seated in chair, back firmly supported, and feet flat on the ground, arms supported with appropriate size cuff placed. Wait for 5 minutes, then check blood pressure 3 times, 1 minute apart. Eliminate the first reading, and average of the 2 readings should be taken. About the cuff size, the width should be at least 40% of the arm circumference, and length should be 80 to 100% of the arm circumference. So selection of proper blood pressure cuff is very important. When the blood in obese patient, when the blood pressure cuff is smaller size, the blood pressure recorded is normally higher, 10 to 30 millimeter Hg more it will be. And the one cuff in small adult, when the cuff size is large, the blood pressure will come low. Then the actual blood pressure. So selection of arm circumference is very important. If the arm circumference is around 22 to 26 centimeter, then small adult cuff should be used. When circumference is 27 to 34 centimeter, then adult normal cuff should be used. When circumference is 35 to 44, large cuff should be used in a large adult. And in morbid obese patient, if circumference is 45 to 52, then adult thigh cuff should be used. So selection of adequate size blood pressure cuff is also very important. Cardiovascular risk calculate to determine treatment thresholds. So both guidelines recommend aligning blood pressure threshold with cardiovascular risk. According to ESC score system, systematic coronary risk evaluation prior to initiation of the therapy, score risk estimate 10 years risk of a first fatal atherosclerotic cardiovascular events in relation to age, sex, smoking habit, total cholesterol level, and systolic blood pressure level. By ACC-AHA, atherosclerotic cardiovascular disease risk score is also calculates using the pooled cohort equations for determination of blood pressure targets. It also gives 10-year risk for developing significant cardiovascular death, morbidity and mortality. If the cardiovascular risk is low, in score study, if it is less than 1, or by atherosclerotic cardiovascular risk, it is less than 5%, both recommended initial emphasis on lifestyle modification prior to initiation of pharmacotherapy. ESC identifies hyperuricemia and elevated heart rate as cardiovascular disease risk factors. ACC does not. Blood pressure treatment targets. According to ACC-AHA guidelines, normal blood pressure should be less than 120 by 80 millimeter of Hg. Elevated when blood pressure is 120 to 129 systolic blood pressure, and diastolic is 80 millimeter of Hg. In stage 1 hypertension, when blood pressure is 130 to 139, and diastolic blood pressure is 80 to 89. The recommended blood pressure target is, it should be less than 130 by 80. According to ESC guidelines, optimal blood pressure is 120 by 80 millimeter of Hg, normal blood pressure 120 to 129, and diastolic should be 80 to 84. High normal is 130 to 139, and diastolic blood pressure 85 to 89. So both have different goal. According to ACC, it should be less than 130 by 80. But according to ESC guidelines, it should be less than 140 by 90. But similar targets. Target with both ACC and European Society, it should be less than 130 by 80 for coexisting coronary disease, chronic kidney disease, diabetic patient, and who had stroke or TIA history. The comparisons already have discussed. Comparison of ACC-AHA and ESC and ESH blood pressure threshold. Definition, according to ACC-AHA, it should be less than or equal to 130 by 80. According to European, it should be less than, it should be definition, and hypertension is, it should, when the blood pressure is more than equal to 130 by 80, or according to European, when the blood pressure is more than 140 by 90, it is considered hypertension. Normal blood pressure range should be less than 120 by 80, elevated when it is 120 to 129, and diastolic blood pressure is more. According to ESC, optimal it should be 120 by 80, normal 120 to 129, diastolic should be 80 to 84, high normal is 130 to 139, and diastolic blood pressure is 85 to 89. Stages according to ACC-AHA, stage 1, 130 to 139, and diastolic blood pressure 80 to 89, stage 2, more than or equal to 140 by 90. According to ESC guidelines, grade 1 is similar to stage 2 according to ACC-AHA, 140 to 159, and blood pressure diastolic is more than 90 to 99. Grade 2, 160 to 179, diastolic 100 to 109, and grade 3 is more than 180 by 110. The ESC office blood pressure target is according to age, what it should be. According to age, in the age group of 18 to 65 years, in all cases hypertension, diabetic, CKD, CAD, stroke or TIA, the target systolic blood pressure should be less than 130, not less than 120. In age group 65 to 79, the target is 130 to 139 in all hypertension, diabetic, CAD and stroke. In CKD, it is considered 130 to 139. In age group 65 to 79, target it should be between 130 to 139, and more than 80 years of age group. The target is same as the age group of 65 to 79, 130 to 139 systolic blood pressure. Only in 18 to 65 years age group, target is it should be less than 130, not less than 120. It should be between 120 to 130. And 65 to 80 years, systolic should be between 130 to 140. Diastolic blood pressure in all age group, it should be between 70 to 79. The main conclusion it showed that the blood pressure should be at least less than 140 by 80. The blood pressure goal according to comorbidities. In age group more than 65 years, it should be 130 to 140, and diastole should be 70 to 79. By ESC guideline, it should be less than, basically in all age groups, more than 65, diabetic, coronary disease, CKD patient, the blood pressure should be not more than 130 to 140, and diastolic should be between 70 to 80. In post-stroke patient, close to 130 or lower if tolerated, and diastolic should be between 70 to 79. So overall, it indicates blood pressure should be remain less than 130 by 80, at least less than 140 by 90. Lifestyle modifications. In all new onset hypertensive patients may be sufficient to delay or prevent basically in stage 1 hypertension and the blood pressure is high normal. When it comes 130 by 80 or 140 by 90, in those cases, start with lifestyle modification, emphasis on weight optimization, heart healthy diet, DASH diet. DASH diet is basically, it includes sodium restriction. In DASH diet, basically it includes low salt, low saturated fat diet and low sugar diet, and more rich in fruits, vegetables and grains. There should be sodium restriction, structured exercise program, aerobic exercises, abstinence or moderation from alcohol consumption, quit smoking. It's a class 1, level of evidence is A. In stage 1 high normal, lifestyle modification should be at least for 3 months we should do it, and regular home monitoring is also important along with lifestyle modification. In stage 2 and grade 1, pharmacotherapy initiated without delay, lifestyle and behavioral intervention is important. Weight reduction, the normal BMI is 19 to 25 kg per meter body square area. Avoid obesity. Your weight BMI should be less than 30. Balanced diet, vegetables, legumes, fresh fruits, low-fat dairy products, whole grains, fish and poultry, and unsaturated fatty acids, especially olive oil, while minimizing red meat and saturated fat. Moderate intensity dynamic aerobic exercises such as walking, jogging, cycling, or swimming at least for 30 minutes daily or 5 times a week. The non-pharmacological interventions for prevention and treatment of hypertension: physical activity, aerobic exercise, how much it's a relation with reduction in hypertension. When you do aerobic exercises, 90 to 150 minutes per week, then the blood pressure reduction is seen 5 by 8 millimeter of Hg, and in normotensive 2 by 4 millimeter of Hg. In hypertensive, reduction is more than normotensive people. Dynamic resistance. When we do exercise like dumbbell or weight bearing exercises, in those, if it is done 90 to 150 minutes per week and 50% to 80% one repetition maximum, 6 exercises, 3 sets exercise, and 10 repetitions per set. This has shown reduction in systolic blood pressure around 4 millimeter of Hg. In normal intensive, it's shown 2 millimeter of Hg. In isometric resistance exercise, when we do push-ups and in those, there is only muscle strengthening exercise. When it is done 4 into 2 minute, hard grip, 1 minute rest between exercise, 30 to 40% maximum voluntary contraction, 3 sessions per week, 8 to 10 weeks, it has shown that there is reduction in 5 millimeter Hg in systolic blood pressure, in normal intensive 4 millimeter Hg. After physical activity comes healthy diet, dietary pattern. Diet should be rich in fruits, vegetables, whole grains, low-fat dairy products with reduced contents of saturated fats and low-fat diet. It has shown there is significant reduction in systolic blood pressure, 11 millimeter of Hg. Weight loss, ideal body weight is best goal. More than 1 kg reduction in body weight for most adults who are overweight. After 1 kg reduction is shown, there is 5 millimeter Hg reduction in blood pressure, reduced intake of dietary sodium. Ideal it should be 1.5 gram per day, but optimal goal is at least reduce 1 gram per day reduction in most adults. It has shown that there is significant reduction in blood, both systolic and diastolic blood pressure. Enhanced intake of dietary potassium, 3.5 gram to 5 gram per day, preferably by consuming a diet rich in potassium like fruits, vegetables. It has shown there is improvement in blood pressure. There is reduction in 4 by 5, both diastolic and systolic blood pressure. So basically salt and sodium and potassium balance is shown there is significant reduction in both systolic and diastolic blood pressure. Moderation in alcohol consumption, and individuals who drink alcohol reduce alcohol intake in men less than 2 drinks per day, and in women it should be less than 1 drink per day. It has shown significant reduction in systolic blood pressure,
Hello.
both in hypertensive
Madam,
and
please
normotensive
summarize
people.
your talk so that we can have interaction with the audience.
Okay. There is just a few slides. The 4 major classes, antihypertensive drugs. We have discussed non-pharmacotherapy, then comes pharmacotherapy treatment. AC inhibitors, ARBs, calcium channel blocker, thiazide and thiazide-like diuretics. Beta blockers should be given only in heart failure reduced ejection fraction or MI patient. Combination therapy for stage 2 hypertension, average systolic blood pressure or diastolic blood pressure, when it is more than 20/10 above the blood pressure target. For hypertensive, blacks or ESC class 1 recommendation, diuretic calcium channel blockers plus RAS blockers are preferred. The blood pressure target we have discussed already should be less than 130/80. Drug treatment strategy recommendations for specific disease including CAD, CKD and heart failure reduced are nearly identical. It should be less than 130/80. ESC included beta blockers as first line therapy, but ACC included beta blockers only for patients with MI or heart failure reduced ejection fraction. Blood pressure target in specific populations, it is uniform, less than 130/80. SCORE risk uses correction factors to reflect cardiovascular risk differences in first generation immigrants to Europe. For diabetic, ESC recommended blood pressure should not be more than 140/90. If in diabetic patient, when blood pressure is 140/90, though an initial therapy with is important. According to ACC, when 130/80 in diabetic patient, treatment should be started. There is different definitions according to ACC and HA. There is 10 millimeter difference. According to ACC, it is 130/80 target, and according to ESC, blood pressure should be, the higher range is taken 140/90. Two different normal goals. Goal in older people, it should be less than 130/80. And in advanced age, 139/79 we can take. Single pill combination in those whose blood pressure is more than, systolic is more than 20, diastolic is more than 10, then you start initiation therapy with pharmacological therapy. According to this atherosclerotic cardiovascular risk score or versus score, when the risk score is more, when the score system risk is more than 5% or atherosclerotic cardiovascular risk score is more than 10%, we should start with treatment. ESG limit blood pressure reduction not less than 120/70. Thank you, sir. So basically, the take-home message is early diagnosis and early treatment can prevent many premature deaths and many complications due to hypertension.
Thank you, madam.
And home monitoring is very important.
Yeah, madam, you talk about the ESC and ACC. What about the Indian guidelines? Is there any Indian guidelines from CSI, or are they different from Europeans or American guidelines?
No, it is same. Basically, now the goal is it should be normal range. It should be 120/. Normally, we take blood pressure. Normal range is 120/80. When it is more around 130/80, then also lifestyle modification and regular home monitoring is very important. And in those who have other risk factors like coronary artery disease, CKD, in those cases, history of CVA or stroke, in those cases, aggressive blood pressure management is very important.
Almost guidelines are same. American
Guidelines
and
are
Indian
same.
guidelines are same. There is no significant difference as per Europe.
Not much difference.
Thank you. Is there any questions from audience?
Hello. Which arm to be preferred, left or right? Left 100%, right-handed, both. And if the gap is too much, you will exclude the cervical rib or not, one. And any role of AB index?
Any rule of?
AB index.
Okay. So basically, in new onset hypertension, blood pressure should be measured in both arms. And the higher one is taken. And it had seen that who are right-handed person, the blood pressure is, there will be 5 to 10 millimeter Hg difference in systolic blood pressure. And the higher one is always taken. And in new onset, the pressure should be measured in both hands. And lower limb pulse should be also checked.
In younger patients, if you find a high blood pressure, you must feel the femorals and also put a stethoscope if you can hear some bruit in the renal artery. So to find out any renal artery stenosis or any coarctation of aorta if the femorals are not felt properly.
You are quite right, sir. Basically, for secondary cause of hypertensions also, these are the secondary causes. Yes, yes. It was an elaborated discussion and very difficult. Basically, hypertension is such a big topic. To say in 50-20 minutes, it is very difficult. So, ma'am has made it beautiful and a smaller one also.
One point I want
Yes.
to stress here
Yeah.
is that meditation is very, very important. That is the first instructions to be given to a person according to his belief. He should meditate, and that meditation brings the blood pressure down in addition to the other things which you have told already.
Yoga and meditation is important nowadays, and good sleep is also, sound sleep is also very important. Sound sleep also reduces your mental stress and many negative hormones also. It reduces your blood pressure.
But after 4 p.m. ma'am, for today, sound sleep, because we want everybody to be alert. So, any other questions if anybody wants to? Yes, yes, sir.
JNC also, the blood pressure goal is same. There is not much difference. Not much difference.
So there was a term which was called hypertension, some confusion or galore or like that. The reason was कि दुनिया में जितनी NIC, JNC हमने 8-9 देखी, nobody knows what the ideal blood pressure is. Sometime it comes to be 120/80, everybody knows. One JNC 7 I think told 150 should be above the age of 60. As sir was right in saying, is there any Indian guidelines? So guidelines are very difficult, although all are almost the same. To risk stratify first in everything. पहले ये देख लो भैया रिस्क है. अगर किसी को SDS या मैम बताएंगे ब्लीड का अगर है कि भाई आईसी ब्लीड है, तो भैया फिर तो 130 से कम 120 से कम ही रखो. ठीक है. अगर कोई पेशेंट लेकिन अगर 70 ईयर एज है और अगर 144 एक बार आ रहा है तो लगातार बीपी एकदम से दवाई नहीं देनी है. सो यू हैव टू बी चैनलाइज टू ए पर्टिकुलर पर्सन ऑल्सो. 30 साल की एज में 75 की एज में सेम नहीं हो सकती. ऑलमोस्ट द गाइडलाइंस आर देयर, बट दे से इन द लास्ट कि दिस इज नॉट टू बी इंडिविजुअलाइज. सो यू हैव टू इंडिविजुअलाइज एज पर रिस्क फैक्टर ऑल्सो. हाइपरटेंशन के साथ में कोमॉर्बिड कंडीशंस क्या हैं, फैमिली हिस्ट्री कैसी है, कितना बीपी का टॉलरेंस है, पेशेंट को डिजीनेस तो नहीं होती. जो हम डिस्कस कर रहे थे 150 वाज आई थिंक मैम इन 7 or 8.
In advanced age, na aggressive blood pressure control, many patients develop postural hypotension. So in those at more than 75 years age group, then it should not be very aggressive. 131 up to 150 systolic blood pressure is acceptable.
Acceptable, yes, quite right. Basically postural hypotension, as some of the physicians we all are staying here are also. So the patient will say कि जैसे ही खड़ा होता हूँ जी चक्कर आ जाते हैं. मैंने तो दवाई सारी बंद कर दी इसी वजह से. So you have to, मैम ने बिल्कुल ठीक कहा कि एग्रेसिव जो है वो 75 की एज पर होना, कि नहीं हम 120 130s में लाएंगे. दैट इज वी हैव टू इंडिविजुअलाइज एज पर.
और अगर किसी को भी ऐसा लगता है कि उनको डिजीनेस हो रही है, ही इज ऑन एंटी हाइपरटेंसिव मेडिकेशंस, द ब्लड प्रेशर शुड बी मेजर्ड इन lying down, sitting and standing position. If their systolic blood pressure fall is more than 20, then we have to reduce the medications also, and morely diuretic medications. This causes more postural hypotension. Diuretics and alpha blockers like Minipress, Prazopressexil.
They will.
They
Dr.
do
Naresh
more
Gupta
postural
sir
hypotension.
want to say something. Yes.
Madam,
Sir,
the
yes.
method of taking the blood pressure is as important as the blood pressure reading. You said, and very well said, that and most of us use the method of sitting position for measuring the blood pressure. What I remember is that the machine and the arm should be at the same level for measuring the blood pressure. So why shouldn't a lying down blood pressure be more appropriate for measuring the blood pressure? My second question, it's a question regarding walk, which may be related only to blood pressure or a little beyond. Some people say that too much of walk is also harmful. Is it true? And I want to ask, how much is the resistance exercise and the aerobic exercise proportion which should be there for a healthy living, whether a patient is suffering from hypertension or not? My last question is, by reducing the HbA1c to less than 6 or 6 as a target, and also in our study, which was a tight control diabetes mellitus, it was revealed that we had lots of patients who had hypoglycemia, which was harmful. Don't you think 130/80 will also lead to something like that?
Basically, blood pressure measurement mainly in clinics at home is done in sitting position. In lying down position, in admitted patient in very few cases, but majority in clinics or office visit. So basically, a person should sit on chair, and the hand and the BP machine should be lying on the table. So the hand and the BP machine and the heart is at that same level. And blood pressure should be measured mainly in majority are right-handed person. So basically, in most of the cases, blood pressure is measured in the right arm. Only during initial, it is taken in both arms. But the higher one is always taken. You have told this HbA1c level. Basically, HbA1c diabetes is related with other basically, in long-standing diabetes, there is stiffness of the blood vessel. As we age, there is atherosclerotic process, or with aging, our blood vessels become stiffer. The systolic blood pressure will rise and diastolic blood pressure will fall. In advanced age, mainly we see systolic hypertension. In younger population, we see diastolic hypertension. Systolic blood pressure is in the normal range, 120, 130, but diastolic blood pressure is around 90 to 100 in younger, 20 to 40 years age group. In advanced people, we see there is systolic hypertension, systolic blood pressure is high, 150, 160, but diastolic blood pressure is low. In some people, we record 50 also, 50, 60, 70. So as we age, there is changes in our blood vessels also. Elasticity reduces, blood vessels become more stiffer.
That's all.
So, yes, ma'am, please.
They also require treatment.
So, in the interest of time, we will discuss several of these factors. The faculty is with all of us, so we will move on. And first, I will facilitate, I will ask Dr. Sachin, Dr. Namit, for the speaker, Dr. Gyanti Kesing. Ma'am, please come on that side. You can come from this side also. हाँ, वो आंसर देते रहेंगे साथ में. Ma'am, just a minute. And also the faculty to come on the dais for, and thanks a lot, and a big hand to all of them. So we will start the next session, and this will be basically Dr. Rajiv Agrawal sir ka Doctor, I will introduce Dr. Rajiv. Everybody knows in this area, and we can say he is a pioneer in one of the, now the bullet train has come, but the bullet was started, I think, in 92 by sir. 90s, I think sir will answer that. Sir was saying that in Meerut area, there was even no TMT was available, and he has taken the intervention to a high level, up to a level of, you can say, the Boston. Basically, sir do a lot of services. Sir has academic credentials. He was in GB Pant Hospital, a very senior member of GB Pant Hospital. This department is the biggest referral base in India for Boston Cardiac Foundation, which implants free pacemakers for needy people. This is a great service and holds the Limca Book of Records for implanting maximum number of free pacemakers in India. So a big hands to sir. We will start with that, because pacemaker is a life-saving thing, and also the Paul Dudley White International Scholar Award recognizing excellence in science from around the world by the American Heart Association. It has been given to sir. So sir is from Meerut to US. Sir is doing services, and sir will mesmerize us with his talk. And in the last, we will discuss the other points. Sir is associated with us in this conference for 10 years straight forward. So thanks a lot for just joining this conference. I will move on to Dr. Rajiv Agrawal sir. Sir will start with his talk. So for this session, I will ask Dr. Gijesh Rastogi sir. Sir, please. Dr. Pankaj Chaudhary sir. Dr. Devinder sir. Dr. Devinder sir is my senior. Dr. Pankaj Ranjan sir. I am seeing him and I am very glad to see him. One of the best persons, one of the best cardiologists I have ever met in Delhi NCR area or anywhere, I can say. Dr. Pankaj Ranjan sir was so helpful for me in initial days when I used to stuck up in intervention in anything. Dr. Pankaj Ranjan sir will come out. So, sir, are we audible, Dr. Rajiv sir?
Yes.
Yes.
I hope I am also audible.
Yes, you are audible, sir. We have discussed about this free services of the pacemaker, and we will summarize with that. First, thanks to you, sir, for accepting our invitation for around 10 years now, and I am obliged and privileged also. So, always.
Thank you, Dr. Pawan, and let let me congratulate you for such a wonderful, sustained effort in upgrading ourselves and community, which ultimately affects the community. I'm so thrilled that despite being a very busy practitioner, you continue to take out time for all these activities, which are very time consuming. I'm going to talk on a very simple issue, which is very close to my heart for last 20 years or so, diabetes and vascular disease. This is a Greek god called Janus. It has got two faces, one which looks for today and another face which looks for tomorrow. And I think that is the essence of diabetic vascular disease today. We have to look for glycemic control from today's perspective, and we will be defeated if we don't look at the vascular perspective in future. And that is why I feel that the total management of diabetes today is glycemic plus vascular. Today's talk is in reference to acute coronary syndrome in diabetics. So let me make you aware that 1 in 2 ACS patients in India have comorbidities. Diabetes being the commonest, the incidence of prevalence of diabetes may vary in different population, but all of us agree that obesity and diabetes are two common morbidities in acute coronary syndrome. 1% elevation of HbA1c is linked to 13% increase in cardiovascular events. Whatever way you want to look at the vascular injury, there is sustained continuous increase incidence of coronary artery disease in diabetic patients, both vascular as well as heart failure. Diabetes worsens the ACS outcomes. MACE is 33% higher. All-cause death is 40% higher. Heart failure is 53% higher. In any form, diabetes deletes 6 years of life. If you have diabetes plus 1 vascular pad, you lose 12 years. And if you have 2 vascular pads and diabetes, you almost lose 2 decades. So it's a very, very strong association with short, long-term survival. 1 vascular pad with diabetes, 12 years. 2 vascular pad with diabetes, it is almost 2 decades. Yet another way to look at non-STEMI patient population. The black ones are the prevalent non-diabetic mortality rate, and the red ones are the mortality rate in diabetic population. And this is just 2 days old. This is my favorite slide, which I am showing it for almost 2 decades. Many of us believe that diabetes, because of newer advances, have lost its diabetic vascular injury touch. No. Whichever era you are, diabetic patient continue to fare bad than non-diabetics. Whatever technology you use, whatever medical therapy you use, we are still not able to make diabetics non-diabetics as far as the vascular injury and outcomes are concerned. So that is a very, very strong message. The moment you see a diabetic ACS, you should be alarmed for poorer outcomes, prognostication, and more aggressive approach. A word about what are the mechanistic pathways. I am clinician, so I'll talk very simple. Hyperinsulinemia, which is a reflection of high sugar feeding, causes epigenetic expression of PCSK9. I was surprised when my daughter told me that in US, we don't give sugar to our children. And probably one of the mechanisms is they do not do epigenetics and induce these parallel genetics, or what we call epigenetic, to express more of PCSK9, which destroys LDL receptor, and ultimately you have high LDL. In Japan, I am being told that no sugar is being given up to 2 years. Children, newborn. So that is one mechanism, that hyperinsulinemia per se can epigenetically express more PCSK9, which is deleterious to lipid metabolism. Same way, insulin resistance can result in more expression of pi, which is again more thrombogenic. Excess sugar consumption, you will be surprised to know India consumes highest free sugar in the world. दही में चीनी डालना, दूध में चीनी डालना, हर चीज में हम लोगों को चीनी डालने का एक कल्चरल हैबिट है. Probably it was a cheap calories, that's why we got imbibed with it. More frequent eatings, they cause insulin resistance, more insulin release, and that is also very important. Insulin receptors in insulin sensitive state regulate plaque stability. Insulin resistant does the reverse of it. That is mechanistic pathway. So going through that insulin resistance per se, which is a part of diabetic syndrome, is very notorious in precipitating acute coronary syndrome. We treat with so many things, the corner store being aspirin, ticagrelor, or high dose statin. What is my interest to show you is that both in conservative as well as in invasive treatment, ticagrelor is given 1B recommendation. So in patients who are medically managed by you, they are also candidates of ticagrelor therapy, which is very poorly practiced in the community. Why it is so? Because ticagrelor is the drug which has shown mortality advantage. Clopidogrel and prasugrel has not shown mortality advantage. Prasugrel has not even shown the CV death reduction, only the MI reduction is there. So there is a case for putting every patient on ticagrelor. Only caveat is that patient, if you are put on ticagrelor, they won't be able to go surgery for next 7 to 10 days. And you are all aware that in our country, acute CABG is not a rampant pattern of practice. Ticagrelor, when extended to Pegasus, that means another 3 years, there is reduction in CV death. And this is a very, very important thing. But when he extended to another 3 years, there is 34% relative risk reduction of CV death. There is no reduction in total mortality. So Pegasus shows us 60 milligram of ticagrelor can be extended to another 3 years after first year of 90 milligram twice a day. Original ticagrelor has demonstrated that there is 100% risk reduction in stent thrombosis. Many of us have seen this, so we are biased more for ticagrelor. High dose statin, when combined with ticagrelor, in this study it was showed rosuvastatin, again there is 71% reduction in MACE. So every patient whom you see in ACS deserves ticagrelor and high dose statin. Managing diabetes by reducing glucose, you know, the 24% patients have diagnosed type 2 diabetes followed by ACS. So if there is no history of diabetes, do not forget to check their diabetes. At least 1/5 of patients will be screened for diabetes and you will be able to help them better. If the HbA1c is more, dapagliflozin reduces more HbA1c. If the HbA1c is low, dapagliflozin reduces less HbA1c. Higher the baseline HbA1c, higher is the reduction of it by dapagliflozin. and it is sustained over a period of time. This is 4 years or so. ADA recommends in all patients of ACS, CVD, and high CV risk patient as SGLT2 inhibitors to be the drug used in step 1 rather than as a sequential. So that is another fundamental change which cardiologists have to learn, that SGLT2 inhibitors are now a step 1 drug, more so in the setting of ACS or CCS. It recommends first-line drug, and if the patient can afford and it is an appropriate, both the drugs should be given in these situations, that in GLP-1 and SGLT2. We know SGLT2 dapagliflozin is easier to use, is cost-effective in comparison to GLP-1, which if the patient can afford, should also be part of it. Reduction of recurrent MI after a coronary event has to be a priority, and outcomes, dapagliflozin reduces MI and MACE. This is the statistics. So this drug not only reduces sugars, but it is vascular protective also. The timing of these drugs is very, very important. This is acute heart failure study, and many of our patients have heart failure. And what is shown is, if you start within 3 days, then the outcomes are best than if you start late. And I'll say I start in my patient if his sugars are high on day 1. So I don't wait even for 3 days. And that is what you see, that if you start within 3 days, if you follow up these patients for a year, their CV mortality and readmission for heart failure reduced. This is another study which is done after 8 weeks or more than 8 weeks. In both, the mortality is reduced of heart failure. So it should not be delayed, but even if you delay it, the mortality is reduced in both. This, if you use in less than 8 weeks, 47% reduction in all-cause mortality. If you use it after 8 weeks, it is again 54, more or less the same. So drug is very effective, and time frame should be as early as possible. I won't advise that you wait for 8 weeks. So it is important to start this drug as early as possible. Post-discharge, if you use it, if you use it in hospital and the patient is on post-discharge, again, you get it on so many fronts. Reduction of heart failure hospitalization and CV death. Dapagliflozin leads to 50% reduction in heart failure rehospitalization. So when you say worsening of heart failure, you should not be in a hurry to start Versigwat. Versigwat should be started when you have exhausted 4 pillars. Versigwat is not a replacement for dapagliflozin. So that point is to be kept in mind, that you have to display all the 4 pillars or whatever you can display. When there is no space in 4 pillars, then the Versigwat comes, and it should not substitute dapagliflozin. This is a very good slide. Recently, I came across just a couple of days back that if you combine with loop diuretics, dapagliflozin, the effective as good as metolazone. So because there is a sequential block, you block in proximal convoluted tubule, then you block a loop on Halle, then the drug is very effective in acute setting. And DAPA-RESIST trial showed that dapagliflozin resulted in similar weight loss as metolazone at 96 hours and was associated with less metabolic disturbances. That is another way to use this drug. Sequencing usually is a chronic issue, but we talk in acute setting also. I say it is a numero uno. Uno is an Italian word for number 1. So it is number 1 drug. Earlier we used to start 4 pillars sequentially. Now we say they can be used depending upon the phenotype. And there was a concept of conventional 4 pillars which extended up to 1 year. Then we came with rapid initiation of 4 pillars, that comes up to 6 months you have to display. Now we are talking of accelerated and personalized therapy. That means you have to display all these drugs to the maximum possible dose, which is tolerable up to 6 weeks. That is called accelerated 4 pillars therapy. And when you do this, event probability is reduced 47%. And again, this is all-cause death by 13%. And this is in comparison to conventional 4-pillar therapy, which happens over 1 year. So if you do rapid, accelerated, personalized therapy, you gain in 4 pillars additionally. And now there is no sequence. This is all bunkum. Whatever is the phenotype, whatever is the sequence, the issue is whatever you can use as early as possible. Permit me to talk little bit off track. जैसे आप चाय बनाते हैं, कोई आदमी पत्ती पहले डालेगा, कोई चीनी पहले डालेगा, कोई दूध डालेगा, कोई सारे एक साथ डालेगा. So it's like that phenotype that decides the sequencing and dosing, but do the best possible titration within 6 weeks. And when you combine comprehensive therapy, you gain another 6 years of life. This is not dapagliflozin, this is all therapies. In ACS, acute decompensated heart failure, as I had been talking, that these drugs are very effective in short term as a diuretic also. In long term, they use their diuretic effects because there is a compensatory mechanism, distal convoluted tubule. But in short term, as I told you, with loop diuretics, dapagliflozin causes as effective diuresis as metalazone. So ladies and gentlemen, hospitalized patient, discharge and chronic heart failure. And this is a drug which can be used from the ACS perspective, from the heart failure perspective, from the metabolic perspective, all along the continuum of vascular syndrome. It reduces ventricular arrhythmia. And the last thing is it accelerates cardiac remodeling, which is the main aim of any therapy. This is post-ACS reduces MACE, death, and improves cardiac remodeling. You can see EF is a little bit increased, and diastolic diameter and terminal proBNP, they're all skewed along with fasting blood sugar and HbA1c. Dapagliflozin reduces N-terminal proBNP by 10%, left ventricular mass index by 11%, justifying that it has got a very cardiac soothing effect and positive remodeling. This is in chronic. DAPA-MODI study again shows the same thing, that this is a chronic study, again shows that it has got a positive remodeling effect. And simplest thing to understand is a reduction in N-terminal proBNP justifies that there is something positive going on in terms of remodeling. It improves N-terminal proBNP in patient from baseline to 8 months, just suggesting that it has got a positive remodeling effect. This is another very good study. Sometimes you find that ARNIs are not able to be used because of low pressure phenotype. What is interesting to know is that if you start these patients on dapagliflozin, then the pressure improves, and you may find around 1/4 of such patients who will subsequently tolerate the ARNIs. I don't have time to explain you the mechanistic of Frank-Starling law, how dapagliflozin helps in improving the cardiac hemodynamics and blood pressure. It helps in remodeling even in acute coronary syndrome following PCI. SGLT2 inhibitor reduces epicardial adipose tissue, which are very, very important in arrhythmiogenesis and recurrence of event. That's why it is understandably very good drug, that epicardial fat pad is reduced, and it helps in decrease arrhythmias and decrease recurrence because there is a continuous crosstalk between vessels and adipose tissue. So, ladies and gentlemen, I'll just stop here that ticagrelor and dapagliflozin, they are very good companions in diabetic vascular disease and should be used in the first opportunity to give patients better outcome. But never forget lifestyle modification. And I'll just summarize food is the most abused anxiety drug. Fasting is the most common forget cure. I showed you that if you do fasting, your insulin levels go down. Frequent meals or what we call intermittent fasting is that's why important. Exercise is the most underused antidepressant and a vasculoprotective drug. So never forget the value of rehabilitation. Think outside the box, learn newer pathways, mechanistic pathways, newer molecules, how they can be used best to the patient's benefit. And I'll end up that this is, we all go to the sea, some find pearls, some find fishes, some just find the feet wet. Life is common for all, but we can only get what we try for. I'll say use these two molecules with understanding and give benefit to your diabetic acute coronary syndrome patients. Thank you very much.
Thank you, sir. Dr. Pankaj, sir.
So thank you, Dr. Rajiv, and I'm quite fortunate that I've shared number of times the dice with Dr. Rajiv in some of the symposium. So you are always excellent, boss, and good orator, and a lot of take-home messages you gave in between. So it's quite amusing. And rightly said that we are actually suffering from sweet enemy, that is sugar. And you rightly said that in Japan and US they don't sugars for 2 years for infants and young children. So it's very, very important, right? And the emphasis on lifestyle modification is utmost importance, and we should tell all the patients of diabetes, because I'm a diabetologist and treating diabetes, and the prevalence of diabetes, we all know it's more than 100 millions now in India, according to the recent ICMR study. So, and you rightly said that 1 in 2 patients with ACS actually have the comorbid diabetes. So it's hand in hand, and if we control diabetes early on, definitely we could able to manage ACS better because of glycemic legacy. So Dr. Rajiv, what is your take on regarding the legacy, the glycemic legacy that we called upon? Because most of the patients with diabetes, they are not diagnosed, they are not being diagnosed, but they are not taking care proper by themselves or physicians at par. So what is your importance in early control of diabetes with this newer molecule like dapagliflozin, as you said, regarding the pleiotropic effects of dapagliflozin? So what is your take on early inclusion of this dapagliflozin molecule in new onset of diabetes? This is my question,
sir. Thank you, sir. Dapagliflozin or flozin as such can be used in pre-diabetics, and the conversion from pre-diabetes to diabetes will be less. I hope I am audible.
Yes, sir. Yes, sir. You're audible.
You are quite audible, sir. Yes.
Yeah. So if you want to talk about pre-diabetes and conversion to diabetes, these drugs may help. Metformin and flozins, they are very good drugs for reducing the conversion to non-diabetics. Non-diabetics, fortunately, they also express the same benefits in every front the way diabetics are. In a way, if you look from the perspective of non-diabetics, it is good, but if you look from diabetic perspective, it is bad, because we wanted magnified effects in diabetics. What we are having a problem with all the drugs, they are at par in terms of gains, whether they are antiplatelet lipids or these vascular drugs. They do not do like GLP-1 receptor analog, like let me say tirzepatide and semaglutide. They reduce almost same or less weight in diabetics than in non-diabetics. We wanted more weight loss in diabetics. So that is the paradox we are facing. We are still not able to make diabetics non-diabetics. We are giving them better life, but the problem sticks there that the gains in diabetic populations are not higher than non-diabetic population.
And regarding the salt, sir, because the first speaker, Dr. Janti, has gave emphasis on the reduction of salt intake. So one is sweet anemia, other is salt, because Asians are more salt sensitive, and definitely they have a higher blood pressure values than the counterparts in West. So sweet definitely is an enemy, but I think salt has to be also considered in our Indian population. So what is your take on that?
Pawan, you have to repeat the question because I'm not hearing it clearly.
Salt intake,
So
salt
you
intake
can
in India.
repeat the question.
Sir, salt intake in
Sir,
our
salt
Pawan,
intake.
Pawan, your voice is clearer to me than
Sir,
his
sir,
voice,
salt
so you
intake-
repeat the question.
Yeah, salt intake for?
for Indian pop, because we are more salt sensitive
Yes,
as
yes.
compared to the Western part.
Rajiv sir is asking that Indians are more salt sensitive. So what should be the salt intake for the Indian patients? For Indians, patient shouldn't be, it should be lifestyle, as lifestyle.
Yeah, so if the salt comes into, there is no clinical test where we can diagnose salt sensitivity in hypertension. We as a blanket advise 3 to 5 milligram of the 5 grams of salt every day. On an average, Indian consume 2.5 times what is recommended. Salt reduction in shell food like chips, like namkeens which we eat is an additional, and there is a continuous effort by World Health Organization to tax salt, and they want to reduce the limit, but we are salt eaters. Sometimes we are compensated because we live in tropics, we sweat a lot. So 4 or 5 months we lose enormous salt. But rest of the year, like winters, we don't lose the salt, and salt consumption should be reduced. Many patients in your practice, when you reduce salt, it works for them. Many patients, if you don't reduce the salt, if you reduce the salt, their BP doesn't go down. So there is no clinical test to understand a salt sensitivity in an individual except a trial and error method and how sincere they are. But salt per se should be reduced to 3 to 5 grams per day.
Hello,
So,
sir. Hello, sir.
yes,
it,
yes,
has,
please.
it has been observed that during the fasting, the blood sugar is rise. Why?
So during fasting,
Blood sugar is rise.
Dr. Pankaj sir is asking.
So during fasting, when we fast,
Sorry sir, I couldn't get. You can answer that also.
no. The question is in fasting. So when we fast, okay. So how many of you have fasting have checked their blood sugars, right? So I think definitely there is some anecdotal, right? In fasting there is a little the HGO, that is hyperglycemic flow from liver. This glycemic outflow from liver is increased to a bit, and you have the fasting blood glucose a little high than compared, but it's not a universal form. Some patients do have high blood glucose, but it is not universal. They say when you fast, the liver try to compensate and increases the hepatic glucose output. So the fasting is more and post-prandial is low, right? In that case, right?
So Rajiv sir, so hapud ke papad should be without this salt, or they are still relevant?
There is a gentleman, I was talking in a public lecture, and there was a gentleman who was old enough, and he said it is better to die with blocked arteries than live with open arteries. So you cannot make your life so miserable. I think salt is an enemy, but what I have learned in my own life, if you sleep well, if you exercise well, if you maintain your weight, you are reasonably good. We should not medicalize our life every day like this much of salt, this much of fat. What we need to be maintaining good weight and physically active. Hapud ke papad is a problem, but is good. It tastes good.
Sir, I would like to ask one question. This T2DM is considered equivalent to cardiovascular diseases. How will you justify in context of our evolution of our knowledge to both the entities?
So
Yeah, repeat the question, Dr. Pawan.
Pankaj Ranjan sir is asking. Sir is able to get the questions rather quickly rather than me. So are you able to get that?
I'll repeat again. My question was, T2DM is considered equivalent to cardiovascular diseases. I will ask you, how will you justify this thing in terms of context, in context to our knowledge in the evolution of both the entities?
Sir, Pankaj sir can
Basically,
answer.
he's asking, I think he has query that anybody who is diabetic and not suffering from any CAD, his life expectancy is equal to a person suffering from CAD. So why it is so? He wants to know that.
So
What makes a diabetic patient equally vulnerable like a patient who is already having a CAD?
yes,
Despite he is not having a CAD. The diabetic person himself is not having a CAD, but his life expectancy is similar to the person who is having CAD.
yes.
So
Sir,
he has that query.
Yeah.
sir is asking, sir, Rajiv sir.
Yes.
Am I audible? Sir is asking why the diabetes and cardiovascular conditions are equidated.
Equivalent.
So they have equivalent risk. Somebody is having only diabetes, the risk is same as for the CAD risk, as we have
Yes.
demonstrated. So,
Yes.
so sir want to ask why both are equidated. It is the data based. Is it true like that?
That's a good question. And the definition of diabetes, give me 2 minutes to make you understand. Number one is the definition of diabetes is still in control of endocrinologists. They have not changed the definition in last 60 years or so and not brought in a vascular component in the definition. That is one major drawback. The initial part of the century, the longevity was an issue and people were dying of diabetic glycemic disease, infections, amputations, poor control, ketoacidosis. But as the diabetic treatment improved, glycemic treatment improved, it brought longevity and it was the time to express vascular disease. So now from diabetic glycemic disease, we are facing diabetic vascular disease. And insulin resistance is one of the epigenetic mechanisms which provokes a procoagulant environment in the body. If you are more than 10 years in diabetic, you are bound to have vascular disease. Hyperinsulinemia, dyslipidemia, they precede clinical diabetes. If insulin assay are like blood glucose, then we'll pick up diabetes in situ. There is a term called diabetes in situ, where diabetes has not expressed and only insulin resistance is visible. But we have very difficult test for insulin. Now the new definition from my perspective is diabetes is a vascular disease with peripheral dysglycemia. It is reverse what we are taught. So large number of patients today in diabetes, they die. In fact, the number one killer of diabetes today is not infection. It is vascular disease, macroangiopathy. Microangiopathy, which are glycemic related, are debilitating, crippling, but they do not cause sudden death. You don't die of chronic renal failure suddenly. It takes decades. You don't die of retinopathy one morning. It takes decades. Neuropathy takes decades. Stroke, leg stroke, and heart attack can kill you in a minute. So macroangiopathy, which is a killer, is a reflection of insulin resistance. Microangiopathy, which is a reflection of age, advanced glycated end product, is a chronic debilitating disease. So because of longevity, the vascular component of diabetes is expressing more in the community than what it was. Thank you.
Thanks a lot, sir.
Thank you, sir.
So in
Thank
the
you,
interest
sir.
of time, Dr. Ram Sharma, this should be the last question, I think, for this session. Sir, Dr. Ram Sharma wants to ask.
Everything has been discussed, but what are the lipid targets for a diabetic patients with ACS or without ACS? And second, can we use statins as a primary prevention? Are there any guidelines?
Sir is asking about the diabetes with ACS, lipid LDL levels, lipid guidelines. Diabetes with ACS.
What are the targets for
Target.
the lipids in diabetic patients? And can we use statins as a primary prevention?
And
Pankaj, you
statin
know,
says-
I love lipids. Pawan,
Yes,
you
yes,
know, I love
I know,
lipids.
sir
And
was-
it will be, I'll just summarize because there is less of time. It should be in every situation less than 55. I'll end up here. So, and start triple combo. If you are really wanting two messages, one is always am less than 55. Number two, that start a triple combo. We were awarded the best paper award from India last year. We showed data that triple combo patients, that means high dose statin, ezetimibe and bempedoic acid started on 0 day. That means on the time of admission resulted higher number of patients on less than 50.
So thank you, sir. So we will continue for the next session because lipid, we should end this session with the lipids. I was just itching to ask something from the sir, and Dr. Ram Sharma has completed my work. So
Next year you give me a topic on lipids.
So I think most of the patients with a non-diabetic, the LD should be less than 100. Patient with diabetes, the LD should go less than 70. And patient who are higher risk, right, any comorbidities, the LDH level should be less than 55. So I think these are the latest guidelines which have been published by LAI. So it's very, very clear now that, and regarding primary prevention, yes, every patient with diabetes has to be on statins, whatever the LDL level would be.
Yes,
So
we have a very good session on that. Dr. Sir's friend, Dr. Naresh Goyal, our teacher, one of teacher, will be speaking on this. So we will move on to the next session in the interest of time. And thanks a lot, Rajiv sir. Thanks again. And thanks for being with us for around 10 years. A big applause to you. Thanks a lot, sir. Thanks a lot.
Thank you. Thank you.
Sir. Thanks a lot, sir. Thank you. So I will ask Dr. Namit to please facilitate the and for the next session in the interest of time, I will start with that. Thank you, Gijesh sir. Thank you, Devinder sir. Thanks, everyone. So the next session will be on basically how indemnity insurance companies deny your crores. Dr. Gaurav Agrawal sir. So Professor Gaurav Agrawal sir will take this session, and sir is, as you can say, sir has so as chairperson, I will invite Dr. Arvind Narayan sir, Dr. Bedi sir, Dr. Arvind Arya sir, Dr. Naresh Gupta sir, please. Rocky, एक शेयर and Dr. Kalra sir, sir please. एक चेयर के थोड़ा सा
Very good morning. So, thank you, Dr. Pawan Sharma, Sneh Society, for this opportunity, and thank you, all of you, for taking out precious time for this session. So, how many of you, let me begin with a question, have indemnity insurance? Just a raise of hands very quickly. How many of us have indemnity insurance? Because those who do not raise hands, I'll assume they do not have any indemnity insurance. So 50% of us do not have indemnity. It's like, driving a car without valid insurance. You have to be having a lot of cash to dole out in case of an accident, or a Mediclaim insurance without, you have to have lots of money for your health benefits in case you get admitted in a hospital. Similarly, mind you, if you're practicing without indemnity, it can cost you lakhs and few crores if you are unlucky. So this is about, this is a very new topic, And you know what is the trend? Till such time, abhi tak kya hota tha, insurance companies were granting money to patients in case there was a complaint against a doctor by a patient and a consumer court awarded a few lakhs or crores of rupees. But now the trend is changed. On the slightest of reason, because there's so many policy terms and conditions, they are simply refusing money. Okay? So if this doesn't wake you up, then, and you have lots of money, then please be ready to pay lakhs and probably crores of rupees from your own pocket to the patient in case the patient is awarded. Because even if the district consumer commission's limit is 50 lakhs, they can still grant you crores of rupees to the patient from your pocket if you are not insured enough. So, and there are, simple things. This talk is not to, scare you, but take important lessons home that, simple precautions can save you a huge amount of money and harassment from courts. So one of the things is criminal claims are denied by an insurance company if they arise from criminal activities such as doctor being convicted for an unauthorized organ transplantation. For example, a doctor in India was part of a racket involving illegal removal of transplantation of kidneys from poor donors without proper consent or regulatory approval. Multiple victims filed criminal cases and civil claims against the hospital and the doctor and won compensation. Insurance company denied to pay compensation for the insured doctors, citing involvement in criminal activities. Similarly, a person with forged medical credentials posed as a doctor and conducted surgeries, including unauthorized organ removals at a private facility. The doctor was not legally entitled to practice, making all acts outside the scope of insured risk. Insurance company denied claim of compensation awarded by the consumer court to the patient. Right. So this is one policy condition. The second is intoxication. Imagine you attended a medical conference on the previous night of patient surgery and consumed some alcohol and proudly posted some pictures, you cheering with some drinks on social media, and the patient produces them in court in his complaint against you for causing medical negligence. In such a case, the insurance company can deny compensation to the patient if the award is granted against you to the patient. Very common thing, and it has actually happened. In one of my cases, it has actually happened. So please refrain from party all night, drink alcohol, but avoid posting all those pictures on the net, right? Cosmetic procedures. Claims of cosmetic plastic surgery are typically denied unless it is for reconstructive purposes due to burns or traumatic injury. Reconstruction of nose, breast augmentation performed for cosmetic purposes are not covered by indemnity. They are, however, covered if there is a medical necessity like injury, mastectomy, or congenital abnormalities, right? Weight loss drugs. I was talking to Dr. Pankaj a while ago. Tirzepatide or Mounjaro or semaglutide Ozempic are approved for usage by the CDSO in India, but they are mainly for diabetes mellitus. Only tirzepatide is approved for weight loss, but semaglutide is not. But many doctors are using semaglutide for weight loss. Now, please be aware that it is only about banned weight loss drugs and not other drugs. So if you are using it for weight loss like tirzepatide, semaglutide, then the patient will not get the benefit if he gets admitted due to whatever cause in the hospital, right? Or he suffers any negligence, then you have to justify why are you not taking care of standard of care. Because you can only use drugs or principles of management which are approved by the regulatory authorities or by standard textbooks of medicine, not otherwise. HIV or AIDS related claims. If a doctor contracts HIV through an accidental exposure during surgery or any procedure and makes a claim citing that he contracted it for medical negligence or claims of financial loss incurred in context of HIV, then the said claim, if awarded by a consumer court, is not covered by indemnity policy. Okay? I'll tell you what is the solution. See, solution is not only, that you take precautions but it is that we have to represent through our associations to the Government of India, to IRDA, to make modifications in the policy so that, the insurance companies can take it and change their policies. Some associations have done this for their states, especially Maharashtra, but it has not yet happened in Delhi and so many other states in India. Non-hospital anesthesia, it is only for dental surgery though. Contractual liabilities, it means that the insurer will not cover financial liabilities. For example, nowadays you have third-party contracts with the laboratory facilities ki theek hai so and so lab dega, or radiology facilities. That contract is not known to the insurer. So if there is a medical negligence at the level of the hospital or radiology or any other department that the hospital is contracted with under an official contract, then if there is a medical negligence claim involving any of these departments, your indemnity insurance provider, despite you are insured for 2 crore rupees, they'll simply deny the claim because they'll say that we are not aware of the contract or we are not party to the contract. We do not have any knowledge of the contract, hence we will not reimburse you for that amount of money, even if you might have to pay it through your own pockets only. So your insurer should know if that the hospital employees, or the hospital has a contract with third parties regarding whatever services. Willful non-compliance. Insurance policies are designed to cover unforeseen accidents. That is why you get it done, or errors or negligence, not intentional wrongdoings or blatant disregard for established laws and regulations. If a patient is harmed due to deliberate breach, for example, develops cancer due to excessive radiation exposure from the faulty shielding, or burns while giving phototherapy to a baby, that means the standard of care has not been taken care of by the treating doctor. In such a claim, you'll say कि insurance कराया किस लिए? Insurance इसलिए तो कराया indemnity का कि अगर कोई injury हो जाए तो company उसका claim दे patient को. But this is beyond the standard of care. If you're not taking proper precautions, so this is what I was talking about. On flimsiest of grounds, insurance companies refuse to pay. And you have to shell out the money because now the case is not against you in a consumer court. That is not the one case only. You will have to initiate a fresh case against the insurance company, because if the award is granted against you, you have to initiate a fresh proceeding in a consumer, because doctor is also a consumer of the indemnity insurance company, asking the court to force the insurance company to pay money on your behalf. So harassment सिर्फ एक केस की नहीं है, it becomes 2 cases now, and then again another few years for that case, for the result to come out. So if you fail to sign on the consent form due to being busy or an oversight, the insurer fails to compensate you for your medical negligence. It also means that if you fail to take care of all the requirements to maintain standard of care that is required as per Boehm's test, then the insurance company may deny the claim simply. Financial loss only. There are many components to an award that the consumer court grants. I'll come to that probably in the next slide. So what happens is, there are physical injury, there is physical injury that has happened to the patient, there is harm to the doctor, there is harm to the reputation of the patient, or mental torture, and so many other, there is fine, there is interest. All these components are there in an award, in a typical consumer court order. Okay, so the insurance company grants only the physical injury part. The rest of the components are excluded from the policy, all the policies in the country, and you have to pay it from your own pocket. That is a very unfortunate part. And sometimes if the award is total, let us say 1 crore rupees, then 60 or 70 lakhs will be for physical injury, the red 30 or 40 lakhs will be for all other components. Sometimes the interest portion is more than the principal component. There may be only 30 lakhs or 40 lakhs as physical injury, but the interest is 50 or 60 lakhs. Insurer does not pay this amount. You have to pay it from your own pocket. Very unfortunate part. This is there in the policy terms and conditions. Personal injury for defamation. If a patient defames a doctor, then the insurance company does not pay for the loss of reputation or defamation of the patient. fines, penalties, and exemplary damages awarded by the court are not paid by the insurance companies. These are the components, 6 components. Compensation for deficiency in service, refund of amount paid by the patient to the hospital, compensation for mental agony or harassment, litigation cost or legal expenses, interest on compensation from date of filing suit. As I said, this is more than the principal amount. It could be 60% and the main principal amount could be only 40%. So 40% तो insurance company दे देगी, but 60% आपको जेब से देना पड़ेगा. Punitive damages or fine, वो तो कोई भी insurance company नहीं देती है. It is very clear. So, as an association, as IMA leaders, we have to strongly represent our case to the IRDA, to the finance ministry, to, whatever the powers that be, that there should be serious changes in the insurance policies, indemnity insurance policies. War and nuclear risks are excluded from all the policies, whether it is, motor accident claims or indemnity insurance. So if there is a riot in the area where your hospital is there, and there is a case of medical negligence against a doctor, the insurance company will simply, because of being excluded under war, nuclear risk and riot category, we are not going to pay any compensation to the patient. Pandemic, COVID pandemic, many insurance companies during the COVID pandemic have taken this excuse that we are excluded from pandemic risks, epidemic risks. This is actually what has happened. We have clients to that effect. Genetic injuries. Pregnant patient undergoes multiple unnecessary X-ray procedures causing radiation exposure more than what may have been prescribed due to a doctor's oversight, resulting in alleged birth defects in the child. The insurance provider may deny coverage, arguing that the doctor failed to adhere to safety protocols or that such claims fall outside the policy's scope. Pre-retroactive dates. For obvious reasons, before the date from which your insurance cover started, if there is an injury or medical negligence complaint, that is obviously not paid by the company. Conscious risk regard. For example, a surgeon skips standard sterilization procedures during surgery and patient develops post-op infection. Okay. Somehow during a casual conversation, one staff member of the condition on anonymity shares with the patient's relative about the same. The patient could claim that his post-op infection was caused due to some highly resistant bacteria that could have happened only if his sterilization was not good or doctor did not take proper precautions. So all these things are there in the insurance policy. Employee injury. Claims sustained by employees due to an injury like fire, electrocution or incision caused by a surgeon while performing a procedure is not covered by indemnity insurance company. Late notification. This is a very, very common thing. We have so many clients, my dear friends. Legal notice आता है, आप reply दे देते हैं. Consumer पुलिस की inquiry होती है, reply दे देते हैं. State Medical Council का notice आता है, आप reply बना देते हैं. But you fail to notify the insurance company about this. और जब consumer court में जाता है, तो insurance company ये कह के बच जाती है कि I was not informed about it. It is there in the policy. The doctor should have informed me about time, and they are right as per policy terms and conditions. So again, you have to start fresh proceedings in the consumer court against the insurance company to award the patient claim if a claim is awarded against you. So whenever you receive a notice, the first thing before filing a reply to that authority is report to the insurance company that you received a notice. You are at least safe that they may pay you money. Unauthorized admission. For example, you settle a out of court settlement with the patient. अभी recently मेरठ में ही client थे, उन्होंने out of court settlement किया, but insurance company को नहीं बताया. Insurance company और दोबारा क्या करता है, patient उसी पैसे को लेकर डॉक्टर से और कोर्ट में चला जाता है against the doctor. ठीक है कि इस बार मोटा पैसा मिल जाएगा. तो इंश्योरेंस कंपनी क्या कहती है, और जब अपना डिफेंस बनाते हैं तो डॉक्टर बोलेगा कि मैंने तो आउट ऑफ कोर्ट सेटलमेंट किया था. तो इंश्योरेंस कंपनी टेक्स द एक्सक्यूज कि वी वर नॉट पार्टी टू दैट आउट ऑफ कोर्ट सेटलमेंट, हेंस वी विल नॉट पे यू मनी. So whatever you do, there is nothing like out of court settlement. Dr. Arvind will agree. He's a medical legal consultant and professor anesthesia at IVAS, that whatever settlement that you do should be within the court's knowledge. That is one. If you do it out of court, then it should be through a proper arbitration authority, which is also like, paralegal authority, or you make a indemnity bond, जो banks अक्सर बनवाते हैं customer से, indemnity bond and affidavit, something called as a not to sue covenant, that the patient will not sue you in a court of law. वो फिर proper stamp paper पे बनता है, only that has legal validity. Not कि आपने 2 लाइन लिखवा ली पेशेंट से कि हमने आपको 2 लाख 5 लाख रुपए दे दिया है और आप हमारी सर्विस से खुश हैं. That has no legal value in a court of law, which is what most of the doctors and hospitals do. Non-cooperation or not submitting documents to the insurance company, obviously the insurance company will say, I'm not liable to pay you any money. Misstatement, not disclosure. If a surgeon applies for a new professional indemnity insurance policy, but intentionally omits information about minor claim filed against her 2 years ago for a misdiagnosis that resulted in a small settlement, or falsely states that she has never had any disciplinary actions against her medical license in the past, then if a new claim is filed against her, and if the previous claim is discovered from the history of your previous insurer, then the present insurance company will simply refuse to pay. Fraudulent claims, then failure to sue in time. जैसे limitation period होता है, Consumer Protection Act में 2 years का है, उसके बाद अगर patient करता है, obviously that is not in our control, then the insurance company can take a plea that it is in the policy terms and we are not going to reimburse the patient for the same. Claims for a series, for example 3 साल के gap के बाद हुआ है या पहला claim था, फिर same case में patient दोबारा चला गया, तो insurance company can refuse to pay. Then policy limit exhausted. Now there is something called as any one accident and any one year. You have to understand that for a moment. Now इसकी एक ratio होती है, हर policy में होती है. You have to opt between the ratio of 1:1. Any one accident means per occurrence limit होती है, ठीक है? और any 1 year means all the accidents, that is medical negligence accidents in 1 year. For example, if you are covered for 1 crore rupees, okay? For I suggest for cardiologists, cardiac surgeons के लिए तो 2 crore plus होना चाहिए, but for all patients should be at least 1 crore. And how much is the premium for 1 crore? It is only 4,500 per annum, which is peanuts actually. So if you are not taking at least 1 CR cover, you are, you could be in a lot of soup tomorrow. So 1:1 का है कि you are insured for 1 crore rupees for 1 accident in 1 year. Okay. Usually you should always opt for 1:1 and not 1:2, because if you opt for 1:2, because you have to specify it at the time of signing the policy every year. If you are opting for 1:2, that means per accident or per case limit is only 50 lakhs. That is half of what you are insured for. If it is 1:4, then you are insured per accident only 25 lakhs out of the total amount of 1 CR. But taking it for granted that you might not have more than 1 accident per year, okay, general principle, then you take it for 1:1 only. If you want to take it for 2 cases, for example, if your specialty is surgical or very high risk, you have a lot of complaints, few complaints against you, I suggest you take policies from 2 companies of 1 CR each. Okay, because then one company can refuse it, but the other company cannot refuse it, because you can find it. जब आप कंज्यूमर कोर्ट में अपना रिप्लाई फाइल करते हैं तो आपको इंश्योरेंस कंपनी का नाम भी और उसकी पॉलिसी भी अपनी रिवील करनी होती है. तो उसमें आप एक केस में एक पॉलिसी रिवील करोगे एक कंपनी का, और दूसरी केस में दूसरी कंपनी की पॉलिसी रिवील करोगे. एंड 2 CR विल कॉस्ट ओनली 9,000 रुपीज पर एनम. ओके, सो दैट इज द जनरल रूल. So I think I'll stop at that, and if there are any questions, I'll be happy to take. Thank you so much for listening.
Please, sir.
Very nice talk, Dr. Gaurav.
Thank you, sir.
ये आपकी टॉक के बाद तो ऐसे लगता है कि हमें कुछ भी नहीं पता कि हम क्या कर रहे हैं अपने इंश्योरेंस पॉलिसीज़ में. At the level of DMA or at the association level, I have seen that we keep bargaining for the premium. We do not go into these intricate matters which they are going to refuse later on. This is an eye-opener for us that we should look into so many other aspects rather than only the premium. Because the premium would hardly matter once you are in soup and you are in a case. Then only the terms and conditions of the policy will matter. That is one thing. Secondly, I would like to ask you at what stage the insurance company should be informed about any mishap that has occurred in the hospital or in the clinic, and is it necessary that it has to be done only after that person goes to the consumer court or to any other court, or it has to be informed immediately after any mishap?
Very good question. So earlier I said that you inform the company immediately when you receive the first notice or complaint from the patient. But even better practice would be immediately when the mishap happens in the hospital, you immediately inform it to the insurance company. That would be the best practice. You inform, keep a acknowledgement that you have informed, and sit quietly. Because the insurance companies, even if they do not reply, but you have a document that says that you have informed the company, tomorrow they cannot claim that they were not in the knowledge.
Secondly, I would like to ask you, most of us
briefly, about the first part that you said. See, Maharashtra has done it. Delhi can do it. We do not know about it. Yes, sir is a very prominent leader in IMA. And we can actually do it. And if we bargain with insurance companies, they are willing to change the insurance policy for the state of Delhi. Okay? They will not do it for the entire country. But for DMA, they will do it. For IMA, they will do it. But we have to ask for it. If we do not ask for it, they'll say कि हमें ज़्यादा पैसे देने की ज़रूरत क्या है? हम क्यों policy terms and condition change करें? It can be done, sir. Yes, sir. Please go ahead.
Next question I had for you was that most of our indemnity policies are nowadays being done by some third party.
Service providers.
Service providers. They come to us, they tell us about the indemnity amount, and they take the premiums, and they say that they will be covering up when we are in a suit. So informing them is sufficient, or we have to make sure that the information of any mishap goes to the insurance company directly?
You should inform the insurance company directly, because they share the insurance policy with you. Sometimes they do, sometimes they do not. If they do not, it is our duty to ask for a copy of the insurance policy. उसको वो अपने पास ही रख लेते हैं, कहते हैं डॉक्टर साहब हम बैठे हैं, ठीक है? And sometimes they forget to inform. Okay, so it is in our interest to inform the insurance company directly before they do. That is one. And second part is, despite their services, see, who is the best defendant or best advocate for a doctor? It is not that service provider. It is the doctor himself or herself. So you have to know about each aspect, even legal aspects of the case. So despite they claiming that they will provide services to you, you can do best for yourself by studying the case and knowing all about the legal aspects of the case.
Thank you, Dr. Gaurav, for great explanation. Actually, just I want to have the summary nutshell. First, we see that when you raise the hand, actually more less than 50% you are having the indemnity. Please get the professional indemnity. Secondly, the government, even sectors, the doctors working government, they are not immune. Many cases has arisen that many doctors who are even had been sued from the both consumer court as well as by the civil courts. So get the professional indemnity. Third is the quantum of the amount should be good. It should be at least 25 to 30 times of the major surgery. Means in Delhi, if we are considering some angioplasty or something, means the expenditure is of 5. So almost 30 times. So 1.5 to 2 CR is the amount you get so insured. Fourthly is the, whenever you have the, just see the document whether they are providing the legal service or not. Sixth point is that when are you going for this? always report immediately जब some mishaps, as Dr. Gaurav already said, and many times even if we get some legal notice or some notice from the court, then still we ignore. Lastly, the most important thing, please take the help of medical legal person. Still, if you are having the professional indemnity, because the lawyers with the professional indemnity, they provide the services not as good at all, and there are many chances that you will be having failure in your protection.
Very good, sir. You know, are there any government doctors sitting here? Government sector doctors? So, you know, 1.3, normally government doctors think that hum to immune hai, as Dr. Arvind said. 1.3 crore rupees was granted to a patient against a government doctor and hospital, by the way. और ऐसा नहीं कि सरकार देगी, गवर्नमेंट देगी, डॉक्टर ऑल्सो हैज टू पे सम अमाउंट ऑफ दैट. पूरा 1.3 करोड़ नहीं, फॉर एग्जाम्पल, सम अमाउंट ऑफ दैट फ्रॉम देयर ओन पॉकेट. गवर्नमेंट डज नॉट पे द एंटायर 100%. So you are not immune. We have cases against government, state government, central government hospitals, army, air force, navy, and ESI corporation, in which consumer courts have granted money despite patient not spending even a single penny. And about the second part that Dr. Arvind said, see, most of my clients are hospitals and doctors who already have service providers. But उनका क्या होता है, copy paste advocates होते हैं. They know nothing about medicine. Doctors know nothing about law. So you definitely need professional services of a medical legal consultant. Sir?
So, Dr. Gaurav, excellent talk as usual. So most of us are actually working in the corporate hospitals. So they have their own professional team, right? Legal team. So anything happens, suppose against us or against any corporate hospital, so they are also taking our indemnity also as well. So they have all the legal cover also. So in that case, the hospital would fight for us, or what is the legal issues regarding that if anything happens to me in the hospital, right? Because they have both, they have their own legal team, and I have all my insurance policy. So what is your take on that? Number one. Second,
I'll answer this first, then I'll take the second one. So what happens is, I've seen many clients from corporate hospitals. See, if everything is, you are in good terms with your administration, your management of the corporate hospital, it is good. If they are preparing the defense on your behalf, it is good. But sometimes it has happened in so many cases of mine that hospital says, no doctor, I do not agree with your reply. Because sometimes you have to transfer the onus on the hospital. And when you do that, as a consultant or a surgeon or a physician, the hospital administrator says, no, I will not take your blame on me. You are responsible for. So us samay, the hospital management simply forgets that you have been an employee for 20 or 30 years with them. They make their own reply, and that at that moment the corporation says, you make your own reply, Dr. Saab, I'll make my own reply. So you have to take your own advocate. So mind you, it is a double-edged sword. If it is working fine with them, sometimes you have to compromise on your reply to make their reply stronger. But in any case, the corporation can never escape their vicarious responsibility. 50% has to be paid by your pocket and 50% by the corporation, the hospital. So it is a double-edged, it depends from case to case.
Right, the second part.
Very quickly,
Second part of the question, right? So as rightly said by Chairperson, that we need to see what is the indemnity policy and what is the cover-up. So they are from government policy makers also, as well as the private institute. So what is your take on that? Which policy actually which would take for indemnity policy?
So always go for government insurance companies. See, I have worked for Star Health for 1 full year just to understand how it works, okay, as a panel medical officer. So I'll tell you in very clear terms. Private, whether it is Mediclaim or indemnity insurance, private insurance companies behave like they are donating blood. They are giving blood in form of money to clients. So they will refuse on any pretext whatsoever from refusing money. They will refuse to give money. And government insurance company का एक ही attitude होता है, मेरी जेब से क्या जा रहा है? सरकार दे रही है ना. So please always go for very practical advice. I'm telling you, National Insurance, New India, Oriental, go for these companies आंख बंद करके. Do not go for whether it is Mediclaim or indemnity private insurance companies. Last question, please.
मैं डॉक्टर शर्मा को बहुत बधाई देता हूँ कि ये पॉइंट अच्छी तरह डिस्कस हुआ है. आपने बहुत मेडिकल लेवल पॉइंट बहुत डिस्कस करे हैं. ये बहुत ज़रूरी है.
So what is the question, please?
लेकिन क्वेश्चन नहीं है, रिमार्क मैं कर रहा हूँ. मैं आपको ये
Thank you, sir.
लेकिन हर एक चीज़ की जैसे हम कार्ड हार्ट में कहते हैं कि प्रिवेंशन इज द बेस्ट ट्रीटमेंट, प्रिवेंशन बहुत ज़रूरी है। और प्रिवेंशन में ये पॉइंट भी बहुत डिस्कस हो चुके हैं IMA में बहुत फोरम पे कि आप अपने पेशेंट्स को अच्छे प्यार से बात करें, रिलेशनशिप अच्छी तरह प्यार से बात करें, प्रॉपर डॉक्यूमेंटेशन ठीक रखें और अपने डॉक्टर फ्रेंड्स के बारे में बहुत बड़े ध्यान से उनकी ओपिनियन के लिए बहुत बोले। कोई ऐसा ना हो कि आप ऐसी बात कर दें कि वो पेशेंट के और पेशेंट के रिलेशन के मन में आ जाए कि जो पेशेंट मेरा डॉक्टर ट्रीट कर रहा है उसने गलत काम किया है। ये बहुत ज़रूरी है कि आप कोई ऐसे रिमार्क कोई पेशेंट को सेकंड ओपिनियन के लिए आया या कुछ आया उस पर ध्यान करें।
थैंक्स अ लॉट, वेरी गुड।
Thank you so much.
हाँ, नरेश गुप्ता
सर एक छोटा सा सवाल।
सर,
ये सवाल नहीं है सर, मेरी सोच है। आई एम थिंकिंग व्हाई इन द मेडिक्लेम्स व्हिच वाज यूजुअली difficult to get the claims, now it is not.
Indemnity.
The motor claims were also difficult to get, but now it is not. To the extent they have started a zero depreciation models. Why in the indemnity this problem is coming? It is because what I feel is the amount of premium which we give in proportion to the claims which are there.
It's peanuts actually, yes.
It's a vast this thing, which I feel will be reduced, and once that is reduced, like a zero depreciation policy, this will include everything. They will not find excuses for refusing it. I think that what is required is a look into the indemnity policy as a whole. And,
so what the insurance, I'm sorry to interrupt you, I was just, just to support your statement, insurance companies are going to increase the premium sharply. If you are paying like, as I said, for 1 crore rupees, only 4,500 or 5,000 rupees, it is going to be increased sharply. It is peanuts actually, and it has been there for at least 20, 30 years, same amount, So it is going to increase very quickly, and it is going to be very high now.
Excuse me, sir.
If want to say something, Arvind Narayan sir.
Dr. Pankaj, I will answer your. Dr. Pankaj, you asked, yeah. The answer is that because actually if even you are working at the corporate hospital or the hospital where you are working to the responsibility, it is called as the vicarious responsibility, and hospital cannot deny his responsibility. But the problem lies with in the court actually. The primary responsibility lies with the treating physician or surgeon. So you have to take care of yourself. Though hospital will have its own responsibility, but that's primary responsibility you. So you have to take your own legal consultations.
Sir, I'm sorry, but I wanted to ask you a question from an OPD perspective. Like if for OPD, what is the time frame I have to keep my documentation, and what is the procedure for that, sir? If I'm not attached to hospital, I just have my OPD. How should I do it for this?
So there are at least 10 or 11 laws which guide the amount of time that you have to, preserve the documents. For OPD, as per NMC, you do not have to keep any records. But at the same time, there is another law which says that effort should be made for electronic documentation. So what I suggest is, it is not for the law, but to save your own behind, that you should preserve the records in perpetuity. See, I'm making a very big statement. Perpetuity means for lifetime. You scan it, preserve it, destroy the originals. It is all right after a few years, after 2, 3 or 4 years. And the electronic records, you keep it on a hard disk for a long time. The patient, maximum time that a consumer court has accepted a complaint from a patient against a doctor or from a, service provider is 10 years. Or the consumer court, law में है 2 साल का, ठीक है, Consumer Protection Act में. But 10 years में भी उसको relax करके उसने accept कर ली. तो 10 years तक तो रखना ही है ना. So it is to save our own ass that we have to preserve the documents for a long, long time. Okay, perpetuity is my answer.
Thank you so much,
Dr.
sir.
Gaurav, Dr. Gaurav,
Sir, Arvind.
all
Yes.
said and done, all these loopholes should be plugged. And at the level of IMA and DMA, as a team, we can just go ahead and
So
plug
DMA,
these
and please take IMA headquarters also with you, because we can try to have it for the entire country. Why only think of Delhi, you know?
It has to be.
Yes, sir.
Yes. It should be
Because
at the IMA
you
level.
are the leaders who will take it forward.
We'll
you know?
definitely take it.
Yes, sir.
With awareness, everybody will agree that we should take it.
Yes. So
Thank you
remarks
for
from-
such a wonderful talk,
Thank you,
Dr.
sir.
Gaurav.
Sir, just 30 seconds last. Dr. Deepak Jain, sir, one of the IMAs of we can say IMA Ghaziabad leaders, one of our pioneer is here. Sir was with us in first conference also, and we most of us are Dr. Naresh Gupta. So I want some question or concluding remarks on this.
You should represent the entire state of UP for new policies, sir. Please.
Thank you, Dr. Gaurav, for the comprehensive presentation. In fact, I joined this session in the midway, so I'm not aware what happened in the last half an hour. I just want to ask one question. In what circumstances insurance company refuses to pay indemnity insurance to a doctor?
Okay, so this was the talk about, and there are many reasons, and I'll just summarize it one way. I'll share with the presentation with you, sir. Earlier the insurance companies were happily paying compensation, ठीक है, because cases कम होते थे. Now the cases are rising, and district courts are granting lakhs and crores of rupees, like if it is, वो कहते हैं डॉक्टर साहब तो आपको तो कुछ देना नहीं है ना, कंपनी देगी अपनी जेब से. So they are very happy granting compensation to patients. And patients now, it is not about the amount of money they have spent during treatment. It is about कि 60 years तक, अगर वो 25 साल 30 साल तक का था जब डेथ हुई फॉर एग्जांपल, तो उस साल में कितना कमा सकता था, प्लस अगर 5 साल या 10 साल केस के चले तो वो इंटरेस्ट मिला के, तो द टोटल अमाउंट गोज few crore rupees easily. So my point is that the amount of compensation is not decided by the amount that we are, वो कोर्ट से कहते हैं कि डॉक्टर साहब तो कंपनी देगी 1 करोड़ 2 करोड़ आराम से, तो आराम से compensation grant करते हैं, that is near to the amount that we are insured for. And there are many companies are increasingly denying crores of rupees to patients on flimsiest of excuses.
Can compensation be awarded in the absence of any medical negligence? Proved
Yes.
in the court. Suppose
Yes.
there is no medical negligence.
Many cases, sir. Many cases. We've got many cases. For example, डॉक्टर की कोई गलती नहीं हुई, ठीक है, it might be a surprise to you. No negligence whatsoever. But if you are a surgeon and you performed gynecology surgery, 1 crore, 2 crore easily granted. Qualification अगर प्रॉपर नहीं है, ठीक है, तो उस बेसिस पे हो जाता है. आपके यहाँ पेशेंट ठीक था, आपने सब कुछ ठीक ठाक ट्रांसफर कर दिया दूसरे हॉस्पिटल में, तो उसमें दूसरा हॉस्पिटल पार्टी बने चाहे ना बने, लेकिन आप ज़रूर बनेंगे when you referred the patient to another hospital. But आपकी कोई गलती नहीं थी, स्टैंड डॉक्यूमेंटेशन सब कुछ ठीक है, बट इवन देन कुछ ना कुछ फॉल्ट इन कंसेंट फॉर्म में. मैं एक छोटा सा क्वेश्चन पूछता हूँ, बस सिंपल MCQ. How many signatures should be there in a consent form? Options are 1, 2, 3, 4, 5 or 6. What is the answer? Anybody? Except Dr. Arvind Arya. Anybody? Anybody else? 1, 2, 3, 4, 5 or 6 in a consent form. Because ये सबसे ग्रेव एरिया, ग्रेवयार्ड एरिया है. हमारा consent form सब कुछ ठीक है, consent form में proper नहीं है. So most of us do not know it. There should be at least 4 signatures. Doctor and witness, you are right sir, and patient and witness. अगर कम है तो यहाँ भी negligence आ गई. मतलब ऐसा नेग्लिजेंस ट्रीटमेंट में, मैनेजमेंट में नहीं है, बट कहीं ना कहीं डॉक्यूमेंट में वो, सी कंज्यूमर प्रोटेक्शन एक्ट इज अबाउट डेफिशिएंसीज, मिस्टेक्स. सब कुछ ठीक किया आपने, यू आर द बेस्ट डॉक्टर इन द वर्ल्ड, बट कहीं ना कहीं कागजों में कुछ कमी रह गई. 1 crore, 2 crore rupees easily patient will get from the insurance company or from your pocket. Thank you so much. Thank you, Dr. Pavan.
Thanks a lot. Thanks a lot, sir. A very nice session. I should appreciate. You have done wonders for all of us. Thanks a lot. So, in the interest of time, I will ask Dr. Namit to felicitate the mementos. And the next session, we will be going with the tide with Dr. Vibhut Pratap Singh, Dr. Vibhud is young, very senior intervention cardiologist. Dr. Vibhud is with Makkah of Cardiology, Fortis Escort Hospital, and the session will be basically on lipids, which we everybody wants to check. क्या आप lipid मेरा कितना रखना है, क्या रखना है, and the chairpersons for the session will be Dr. Ashok Sharma sir, please, Dr. Rajiv Singh sir, Dr. B.K. Gupta sir, Dr. B.K. Gupta sir, Rajiv Singh sir, Dr. Arjun Singh sir, please. Dr. Dinesh Saraswat sir, if present here, please sir. So, Dr. Vibhud is, as I have said, is a prestigious KGMC Medical College, and a professional and a doctor and a very good person, very good cardiologist with multi-dimensional versatile functions. If we have to ask for the valve, the transvalvular treatment, he is one of our guy. If we have to ask for the complex intervention cardiology, he is one of them, and he is from Makkah of Cardiology, I should again say, the Fortis Escort Hospital. So he will mesmerize us on this lipids. So to you, Dr. Vibhud, please.
Thank you, sir. Thank you to all the chairpersons. Sir is like an elder brother to me, so don't be flattered by his praises. This is just like an elder brother praising his younger brother. And been really part of the SIRS conference since its inception, and it's really an honor to come here in East Delhi and have present the topic today. So without wasting the time, let us go forward to the topic, changing paradigm in lipid lowering therapies. I'm Dr. Vibhud Pratap Singh. So what my basic whole goal of the presentation is, one, the LDL targets, what we are saying the reduced LDL targets now, and second, the newer therapies, most particular the inclisiran. So as we all know, the burden of atherosclerotic cardiovascular disease is too much in India. The prevalence is around 54 million. It is a number one killer. The years life lost to the cardiovascular disease have increased 60%. And there is a direct economic burden. As a physician and as a clinician, what we see in the last decade, there has been a tremendous rise in the cardiac patients. The three risk factors, hypertension, diabetes, diet, they have been talked about a lot. Somewhere down the line, LDL levels were missing the whole game. Dyslipidemia, the patients are, we will be treating it in the next year, we'll go with the diet, and that LDL levels goes on without being noticed. LDL is involved in every step of atherosclerosis. Initial eNOS activity to the formation of foam cells, increasing foam cell formation, foam cell necrosis, and the necrotic core being ruptured. So it is involved in the total cascade of a myocardial infarction. Cholesterol control is fundamental in reducing risk of ASCVD. Lifetime exposure to elevated LDL-C is a causal and cumulative risk factor for ASCVD. So we are in between healthcare, patient and physician triage. Now the very important question, how low would you go with respect to the target? We had heard in the Dr. Rajiv Agrawal session, and these are the slides which you should focus in your clinical practice from here on. The LDL goal has changed. It has changed a lot from 2011 to 2023. You can see in the last decade, the goal itself has been changed. Starting from ESC 2011, in which less than 100 was okay, coming down to the Lipid Association of India guideline, in which extremely low levels of less than 40 were indicated. If we talk about the guidelines, the two guidelines that are very important are European Society of Cardiology guidelines, and the other is Cardiological Society of India guidelines. And I will be talking a brief about them. 2023 ESC guidelines say LDL reduction to less than 55. What we mean by LDL reduction is the direct LDL measurement. Remember the word, when you ask for fasting lipid profile, go for the direct lipid measurement, not the calculated. The reagent costs only 20 rupees, but the labs give the calculated. Go for the LDL-C direct. LDL-C reduction more than 50% from the baseline for patients who have experienced a second CV event within 2 years. And lot of our Indian patient goes at LDL-C level of less than 40. This is how low we go. LDL-C is one of the top modifiable CVD risk factors. LAI had talked about extreme high risk lowering of this thing. We are focusing on ESC and the Cardiological Society of guidelines. Why there is a huge unmet need for LDL-C goal? The patients who did not achieve LDL-C target, monitor your patients, see the LDL levels, and you will find this data resonating in your clinical practice. Around 60% of the patients are not getting to the LDL. We are very worst that we have to get A1C down below 7. Fix LDL to that level. 2023 LDL guidelines for the ACS patients. So what it says, if the patient is landing as an acute coronary syndrome, he's on high intensity statin, continue, check LDL. Low intensity, go for high intensity, that is rosuvastatin 40 or atorva 80. If he is not on intensity, statins, start the high dose initiation. And if the goals are not meeting, add a PCSK9, add a bempedoic acid, or add a ezetimibe. Now here, this is a CSI guidelines, and I want to focus you all on this thing. Very important, the concept change has been in this guideline, that the first very important thing we have been taught in Braunwald, fasting lipid profile. The first thing in the ACS patient, go for non-fasting lipid profile. Fasting is not required. Second thing, what they say is, go for combination therapy. This is the newer thing which American College of Cardiology is also talking. The Indian guidelines are also coming up. Straight away go with the combination. Rosuva plus ezetimibe, atorva plus ezetimibe. Bempedoic acid is also catching up very fast because the bempedoic with compared to ezetimibe, 18% reduction as compared to ezetimibe 12%. But not talking into that, combination therapy is being advised, and then you should target the LDL-C level less than 55. Again, monitor the patient 6 weeks and 12 weeks. So important, non-fasting lipid profile, importance of combination therapy at onset, and the target of LDL goal. Now this was the CSI guidelines 2023, and there was a question, so I specifically got it incorporated just now in my presentation. You have to remember, this is how we target the lipid now. This is 2023 guidelines, hardly a year or two, we will be going more intense. Because this is one subset, as in practicing intervention cardiologist, I also feel that is most neglected. No risk factors is still LDL-C less than 100. Moderate risk factor, diabetes, hypertension, tobacco, family history, less than 100. High risk, all the patient going into less than 70. Generally, what we see in our clinical practice are extremely or very high risk. That was the reason Dr. Rajiv was saying LDL goal less than 55 or non-HDL-C targets of less than 85. So how soon do you recommend escalation of lipid-lowering therapy in your post-ACS patient? Immediately. And the very important thing is the statin, the LDL goal is also there, plaque stabilization is also there. So patient who has an acute coronary syndrome, the first 90 days are critical for his re-event. So always be very particular about the cholesterol medication. Do not decrease the high intensity statins. ACS patients are at higher risk of a future events. Guidelines recognize that early intervention is critical to improve outcome. So hit hard, hit early. That should be the buzzing mantra. Never shy from high dose statins. How to ensure access to early intervention? This is more for a corporate presentation as from the company itself. Pre-hospital, post-hospital, we should be taking that in mind. Now, very important, the talk that which I have to give, that novel therapies like inclisiran fit in the current lipid lowering space. So this is a wonderful drug, and this is really out of our pharmacology books which we were discussed and which we had read up. This is a therapy that is targeted RNA-based. So what it does, inclisiran is selectively taken up by the hepatocyte with the help of GalNAc conjugates. It is stored in the endosome where it loads into RNA-induced silencing complex or RISC, leading to PCSK9 inhibition and which increase the LDL receptors number on hepatocyte causing greater hepatic uptake of circulating LDL. So this work on a targeted RNA therapy. What important is this? Statins almost daily that we have to use. Targeted RNA therapies, 2 doses per year. That is what the better adherence with infrequent dosing regime. What are the salient clinical evidence and guideline recommendation? It is nothing new. It is new to the Indian context that we have been exposed last 2 years, but the trials have been over 30 years. The majority of the trials that are important are the phase 3, especially these 3 subset, Orion 9, 10, 11 series. 10 leads with ASCVD and 11 with ASCVD and risk equivalents. And this data and the use of inclisiran has now got around 8 years of experience. What it basically does, these are the 2 important points. It gives us a sustained LDL reduction along with the effective LDL-C reduction of around 50%. 70% of the patient achieved an LDL levels of less than 70 and 52% of patients achieved less than 50. If we look at the pooled analysis of 3-phase studies, a beautiful effect that inclisiran demonstrated. In Asian population, Orion 18 was done, around 60% effective LDL-C reduction and 56% sustained LDL-C reduction. Very important, that was noticed during the things, it lowers the LPA in Asian patient. Early treatment intensification with inclisiran can benefit ASCVD. That's a core concept of the Victorian Initiate trial, and which is advocating for the inclisiran first strategy. It offers a long-term efficacy. In 80% of patients achieved their pre-specified LDL targets, 90% of the patients achieved their global lipid targets, and on average, LDL-C level were reduced by 50% or less. Orion 8 demonstrated long-term safety, not going into much into that, but safe in renal or hepatic impairment, very important. No drug-to-drug interaction, no off-target effect as compared to monoclonal antibodies. Potential cardiovascular benefits are there, and patient-level pooled analysis of Orion 9, 10, 11 showed early initiation of inclisiran is associated with the numerically lower incidence of major adverse cardiac effect. Inclisiran first strategy was taken in Victorian Initiate trial, and there was 53% of significant LDL-C reduction, 2 doses per year, very easy to give, and again going to the guideline recommendation, CSI 2023, lower is better. So coming to the crux of the clinical thing, which patient would you take on for the inclisiran? There is a young guy on atorvastatin and ezetimibe, LDL-C 120, lipoprotein A 32, misses medication due to hectic work schedule, middle age with complex PCI, multiple vessels have been stented on guideline-directed therapy, LDL levels still not controlled, often forget medication. Elderly female with recurrent event, the LDL-C of 110, find it difficult to adhere medication due to polypharmacy. All 3 are target if the LDL-C goal is not achieved despite maximally tolerated statin therapy and ezetimibe. After 4 to 6 weeks, the addition of PCSK9 therapy is recommended. Convenience of 2 doses here, well tolerated safety profile. So in the nutshell, what I tried to give you the take-home message, lower is better, is now established. LDL target from 100 that we were usually taught, less than 55, that's the most important paradigm shift in target values. Beyond statins, combination therapies, maybe bempedoic acid, ezetimibe, we have been using it often, PCSK9 inhibitors or inclisiran, they have shown to give enhanced LDL reduction. This slide has been taken from European Society of Cardiology, and that is what the future goes on. We are here biannually. The work is on the vaccination and gene editing. This is one of the most important thing to monitor in the cardiac patient. So target LDLs, target to at a lower level in your patients. Thank you. Without wasting time, I'm open to any questions.
Hello. Hello. Thank you very much, my friend Dr. Vivid Pratap Singh, for a nice talk. My question is that if patient having ACS or major cardiovascular event recently and having renal dysfunction associated with this, which statin you prefer and how much be the dose? Whether the rosuvastatin, usually nephrologists not prefer atorvastatin over the rosuvastatin.
Very important debate between atorvastatin and rosuvastatin. Rosuvastatin, because of his constant lowering effect, slight further decrease in the LDL-FD. This is the one subset where atorvastatin scores over the rosuvastatin. Although no specific guidelines has said, even the CSI, ACS guideline has said for the both of them, but that is a one gray area in which I as a practice prefer atorvastatin more. And also when we should be seeing the CKD patient, and we have seen rhabdomyolysis even with atorvastatin. What rhabdomyolysis I'm talking of, the neurology friend will be explaining. Patient statin presenting with complaints of weakness in the proximal limbs, features of myositis, painful limbs. We should always get the CK levels monitored. If the CK levels are high, the statin should be the first drug to go off, and you should be monitoring it that. But to be concise, atorvastatin will be my preferred choice.
It's a great presentation, Dr. Singh. Just as a medicine person, I just want to ask you, with the statin, what is the best preference with the combination therapy, fenofibrate or azitamine?
Very important question, sir, and very nice. We have a long exposure with azitamib. So the combination, the CSI mentioned was with the rosuvastatin with azitamib. But the newer trials that have come up now, bempedoic acid has got more reduction as compared to azitamib. And that is what the reason of having rosuvastatin and bempedoic combination in the commercial arena. Bempedoic acid has got 18% reduction as compared to the LDL 12% in head-on trials. So bempedoic acid has got a newer and future role for the combination. I personally now prefer a statin with bempedoic as a combination. Even going one step further, the American College of Cardiology 2025 guidelines, they have mentioned that the combination can be any. There is no one fixed drug that should be combination. Even you can go with a statin or a monoclonal antibodies upfront. If a patient has come in ACS, you can legally, ethically also add an PCSK9. There's no point that we have to go and follow a stepwise approach. But coming back to the question, my personal choice with the bempedoic acid, guideline-wise, they have advised rosuvastatin or atorvastatin with azitamib.
Sir, one question. At what age one should advise for the LDL?
More than 18 years, definitely. Family history is down there. We should be evaluating much earlier also, but the recommendation wise, they are above 18 years. Above 18 years, a guy should always have his lipid profile. Family history, any sample done down there, we should get it up.
So one more thing. If the patient is having LDL more than 100, does the age matter if the patient has to be treated then
Yes,
50
that,
years or 60 years or 70 years?
So that is what the whole presentation and whole thing is. We are more focused on diabetes, we are more focused on hypertension in last 10 to 20 years of our practice. Cholesterol and the LDL level were least bothered about. As we go into the society where elderly patients are coming, patient with the disease adjusted life here, the patient who have got comorbid condition because of the cardiovascular effect are seeing, we are getting importance of the LDL. So guidelines, what they say, no risk factors, the LDL target should be less than 100. If the patient is LDL target more than 100, we should advise a lifestyle changes, but again 6 months, if it is not there, we should advise a LDL lowering therapy.
So how long one should continue the statin?
That is again a gray zone thing, but what generally we do, patient are thinking once it has started, Doctor Sahab, ye to pure zindagi bhar chalegi. Start the therapy, get the levels down, try to go for alternate low dose therapy or alternate day therapy. Till the point he's able to maintain that target, we should continue. This is what the scientific answer to this question will be.
After achieving the target, we can stop it.
No, just if say patient has got a LDL and less than 100 for 6 months, he's on statin, he wants to go off of the statin, he was on 20 mg, go for 10 mg. He was on 10 mg, go for alternate day therapy. But monitor the LDL levels. If the LDL levels are getting okay, that dose is okay for the patient.
In cases of resistant cases where LDL is not coming down, even in spite of dual therapy, does thyroid function has got some role?
Sir, what?
Thyroid function.
Definitely,
Because
definitely,
hypothyroidism
definitely. Yes, that is definitely linked to it. Definitely, sir. Raised TG levels. So thyroid is one of the important thing which we have to monitor for the LDL thing. But even if the thyroid is low, what the newer therapies and the goal was this, sometime which we see now most often that the patient in the zone of around 40 to 50%, in spite of the statins and all, they are not achieving the target, then the role of these PCSK9 inhibitors come to down the point.
Dr. Ram Sharma wants to ask something.
What's the importance of lipoprotein A and B?
Okay, so what the goal is, LDL and non-HDL. They are the two targets which have shown to, when we reduce that, there will be mortality benefit. Lipoprotein A is still in, we are in observation mode. It is known to have a causal risk association with the cardiovascular disease, but lowering it down will be reducing the mortality. This we do not know. But as our scientific evidence will go, will further increase. There are two therapies which target the lipoprotein A. PCSK9, which has got incidental finding in Orion 18 that lipoprotein A was reduced, and the second one is pelacarsen. This is a newer drug, but it will only be important when we have got this association that high lipoprotein A is decreasing, it will be getting the benefit of the mortality. So the targets will still now be LDLs and non-HDL targets.
So what?
Sir, I just want to add one.
Hello.
Siddharth is down here.
So
the questions also.
this one problem is that when we get these reports, the companies have to fill it. So they've started adding lipoprotein little a. Like sir has mentioned, it has not proven till date to reduce lipoprotein little a is going to improve our outcomes. It is just like how HSCRP used to be 20 years ago, telling us that this patient's HSCRP is high, so him having an event, chances are going to be high. Similarly, if somebody has a high lipoprotein little a, chances of having sudden cardiac events will be higher in this patient subset. So you cannot do anything for lipoprotein little a, but you can do for sugar, you can do for BP, you can do for cholesterol, you cannot smoke, you can do lifestyle modification. So it is just something which is telling us that, भाई आपकी चीजें थोड़ी गड़बड़ हो सकती है तो ध्यान रखो.
So
Correct,
what are
sir?
the
Yes,
limitations of RNA-based lipid-lowering agents? RNA-based lipid-lowering agents, what are the limitations?
Cost is the biggest limitation, sir.
And what are the side effects which are seen during their studies?
There's a local site reaction, that is one only thing. There have been a black box warning of neoplasm, but as such, no drug-to-drug interaction. It can be used in a patient who has got an impaired hepatic or renal insufficiency. Personally, I have been using it across last 2 years, and I've been using most number, I will say, in my region. And side effect, I have not found anybody to have so much serious
But in
adverse.
certain studies, evolocumab was found to have increased mortality during the later phases. That is why it was stopped in England. And silscran was used. Yes.
So
that was
what
thing.
I tell you what the thing was. There was two different strategies.
Yes.
There are two PCSK9 inhibitors. One target the circulating,
Yes.
and the other is the targeted RNA. So the controversy started with the circulating, that is the group that target the circulating. And these effects, because they had got a systemic effect, side effects, that was a time when this drug had an issue. Regarding the PCSK9, it was not. This is a targeted to the PCSK9, and that was a targeted to the circulating antibodies. That is what the difference was. Pardon, sir?
We cannot use expensive medication in this routine practice. So many of the people here are general practitioners.
Definitely, sir. What the thing is, now as the practice will go, you will see a patient who has got angioplasty 2 or 3 times. A single visit to an hospital will cost around 5 to 6 times. What we lack in the practice is seeing the LDL levels. We are not so much fixated about the LDL idea. Statins, we give high dose, we think that everything is okay. But what the whole take-home message and why the shift in the understanding is that LDL has to be targeted to a high low dose level. So the amount of the patient, and as a general practitioner, you will be seeing much more cardiac patient than us. Very important that LDL has to be targeted. Cost of therapy, definitely an issue. If the patient can say ki bhai cost of therapy, that's okay. But you have to advise because we have to get to that level to prevent the further mortality.
And what is the role of colchicine and other anti-inflammatory drugs?
No, not at all proven because of the kidney toxicity and all those issues. Colchicine, all the experimental stage, not much benefit.
So just the concluding question, if the last one, because we will have a question and answer session also, and that is the one of the best cardiologists in this, I think in the Delhi NCR, 4, 5, 6 are here. So you can ask as much questions that you can, but we have to spare some time. That is why. Just
Any role of Framingham scoring for starting?
Pardon, sir?
Statin. Role of Framingham scoring as a risk assessment.
Actually, sir, what the thing was, Framingham, the data was for the Western population. I think practical Indian subset Cardiological Society of India guidelines are much more specific. Because Indian patient, what we have seen, they are more prone to the cardiac events. And this is a guideline that is more on the Indian patient subset, that CSI 2023 guidelines. You can get it from net, and that should be the target which we should be following on. Rather than blindly going on the Western population is different. There's entirely different. I've worked across in the India also, and once their patient profile is much different, 70 to 80 years, elderly. India, the profile is entirely different, 40 to 50 years, high lipid levels, uncontrolled lipid levels. So we should be going in for the Indian guidelines. I think CSI 2023 or LAI, Lipid Association, they are the two guidelines which we should be monitoring on.
So thanks a lot, Dr. Vibhuti, and thanks for the great presentation, both and the basic questions that you. Thanks a lot. Thanks a lot. Thank you. And I will ask Dr. Namit to please felicitate. So next session will be by Dr. 10th Rehan. Dr. 10th Rehan is MBBS DNB DM Cardiology. He is Senior Intervention Cardiologist with the Maharaja Agrasen Hospital. And he is National Faculty and Intervention Cardiologist, a versatile molecule of cardiology in the generations, and a proctor for complex coronary interventions, tower, everything you can think of. And the last not the least and the best one, that he and we have all learned from the Almighty and from the second to the Almighty, which we will ask, I will name after some time, the well known for bypassing the bypass. So bypassing the bypass means the complex of the complex. If you want to address, then you can address him. So I will ask Dr. 10th to deliver on he will be speaking on the basic Novak, the anticoagulation topic, and then we will have a discussion over that also. Dr. 10th, please.
Thank you, Pavan sir, for such a lovely introduction, and good morning, good afternoon to everybody. First of all, a big congratulations to Pavan sir for 10th Cardiocon, and it takes a lot to organize such an academic feast for everyone and gathering so many people together on a Sunday just to improve medical care for future. So
my apology for the second for chairpersons. Basically, Dr. Vivek Chaturvedi sir. Sorry, Dr. 10th. It was in rush of. Dr. Pankaj Ranjan sir, Dr. Ankit sir, Professor Ankit, I should say. Professor Ankit is from GB 10th Cardiology, and wait for the sessions that they will be mesmerizing in the next sessions. And Dr. Ram Sharma sir, please.
So now it becomes even more difficult to sit in front of Ankit sir and Vivek sir to be delivering this talk on something which is, which we practice, but personally not my area of best expertise, I would say. So today I have been given the opportunity to talk about stroke prevention, and especially in atrial fibrillation. And we all know stroke is one of the most debilitating diseases which can be there, which has a huge impact in the longevity and the quality of life for most of our patients. So first of all, atrial fibrillation, hands down, is one of the most common causes, cardiac causes, I should say, which leads to people developing strokes. Atrial fibrillation is the most common, clinically relevant cardiac arrhythmia. The incidence of developing atrial fibrillation is directly proportional to one's age, which is approximately around 0.1% at 40 years of age, and it slowly increases up to 10% at 80 years of age. And despite whatever comorbidities you have, age is going to be a common denominator when we talk about the prevalence of atrial fibrillation. We all know that our population is aging. The expected life expectancy of India as a country has now reached around 73 years of age, so it's continuously increasing. So definitely the prevalence of atrial fibrillation is going to increase. It's predominantly classified as valvular and non-valvular atrial fibrillation. Valvular atrial fibrillation is usually seen by interventional cardiologists, and non-valvular AF is seen by all of us, whether we're interventionalists or non-interventionalists. Atrial fibrillation can also be classified as the duration that the patient has been having this arrhythmia. Somebody who's been diagnosed with the first time, has never had any past history, is called first-time diagnosed atrial fibrillation. An atrial fibrillation which lasts for less than 7 days, usually less than 48 hours, is called paroxysmal atrial fibrillation. If it tends to last longer than 7 days, it's called persistent atrial fibrillation, or any atrial fibrillation which may require cardioversion. Any atrial fibrillation which lasts for more than a year is called long-standing atrial fibrillation. And in certain subsets where, despite everything that has been tried, patients will continuously remain in atrial fibrillation, these are patients who are called permanent AF. So what's the real problem with anybody having atrial fibrillation? So patients may have an unusual or an upsetting feeling about their own heart rate, which is going to present as palpitations. Sometimes these patients may develop breathlessness. Sometimes they may have some chest pain. But despite that, the main problem is going to be of stroke. And these strokes are going to be unprecedented. You cannot really sort of predict them and foresee them unless you've picked up atrial fibrillation and started therapy at the right time. As risk factors increase, the chances of getting atrial fibrillation is high. One of the simple ways to sort of risk stratify patients for atrial fibrillation is the CHA2DS2-VASc score. I feel that this is something which is highly lacking. Each and every prescription of a patient with atrial fibrillation should have their CHA2DS2-VASc score mentioned, because these scores will change over a period of time. The patient's risk is going to change, and unless it's mentioned, you don't really know why this anticoagulation has been started or not started. So what is this CHA2DS2-VASc score? It is a mnemonic. So we have congestive heart failure, hypertension, age more than 65 as 1 point, age more than 75 as 2 points, diabetes mellitus, stroke or any embolic event, vascular disease, or females. And as your number of points increase, the chances of having a yearly stroke rate goes up. So if you want to prevent stroke, which is definitely due to khoon gada hona, so you have to sort of thin the blood. If we do go to the other side of it, if we thin the blood, we are getting some ischemic benefit or some stroke prevention, but at the same time, we are going to have bleeding events. So CHA2DS2-VASc score is, stratifying us for ischemia. Then we have a Hasbled score, which is going to stratify us for bleeding events. This Hasbled score includes hypertension, abnormal renal or liver parameters, previous stroke, any bleeding, any labile INR, which is more than 1.7, any elderly patient more than 65 years of age, patients who are taking some drugs which may lead to bleeding, or patients who are taking alcohol. And if we see that as the Hasbled score increases, the number of bleeding events per year increase. So standard, which has been the teaching, is that if your CHA2DS2-VASc score is high, Hasbled score is low, start this patient on anticoagulation, because the benefit of ischemia is going to be much more than the risk of having a bleeding event. So when it comes to management of atrial fibrillation, it's a simple ABC. A is going to be avoid stroke, which is the most important thing. And anybody who has a CHA2DS2-VASc score more than 2 for males and more than 3 for females should be started on anticoagulation, provided that they do not have any bleeding comorbidity. B is going to have better symptom control. Symptoms, like I mentioned, could be palpitations or breathlessness, which could be improved if we tend to control a patient's heart rate. Sometimes we need to control the rhythm as well.
And then C would be taking care of the comorbidities, whether it's some cardiovascular disease which has led to a patient developing atrial fibrillation, whether it is alcohol intake, whether it is obesity, whether it is somebody's thyroid. I think preventive aspect should always be considered despite whether a person has a disease or not, because over a long period of time, if we can change modifiable factors, patients tend to do better. So when we talk about anticoagulation, the standard of care has been vitamin K antagonists, and I think warfarin is probably one of the most famous anticoagulants which have been used over a long period of time. I think since 80s it has been used. But of late, for the last 1 decade, we've had newer oral anticoagulating agents. They have a simpler dosing. They have a much more reliable absorption. They have a reliable pharmacokinetics and reliable pharmacodynamics. They tend to have a direct action. They have less food interactions except for rivaroxaban. There's no need to check your PTINR levels repetitively, and patients tend to spend more of their time in therapeutic range in comparison to when it comes to using VKAs. So one of the biggest issue that people have when we have to initiate anticoagulating agents is how do we reduce the bleeding risk. I think one of the most important thing is look for the modifiable risk factors, like if somebody has an extreme amount of alcohol intake, or somebody has abnormal INRs, or somebody's taking some sort of a medication which is going to lead to increased bleeding risk, we can remove that. We can use a better anticoagulant. We can use a better dose of this anticoagulant. We can tend to offer rhythm control or AF ablation or LAA closure devices to such patients, which will reduce the risk of both stroke as well as the risk of anticoagulation. So in one of these trials, which was the Xantus study, it was seen that patients who had modifiable risk factors, their chances of getting bleeding were almost 2 times. And these modifiable risk factors included antiplatelet use, NSAID use, paracetamol use, hypertension, and heavy alcohol use. And if these patients removed or improved the modifiable risk factors, their bleeding events decreased dramatically. So in the market, we currently have 3 easily available NOACs, which are apixaban, rivaroxaban, and dabigatran. So the use and the benefit of all of these was seen in major trials, which were landmark trials. So we had the Aristotle study, which was for apixaban. We had the Rely study, which was there for dabigatran. And then we had the Rocket AF, which I'm going to talk about a lot more today, which was for rivaroxaban. In all these studies, we found that all NOACs fared far, far better than VKs, both in terms of stroke reduction as well in terms of bleeding reduction. One peculiar thing which was there amongst these 3 trials was that in Rocket AF, the usual patients which were there had a relatively higher CHA2DS2-VASc score in comparison to the patients who were taken up in the other trials. At the same time, these patients who had a higher CHA2DS2-VASc score also had a higher bleeding Hasbled score in the Rocket AF patients in comparison to the other 2. But despite having patients who had a higher CHA2DS2-VASc and a higher bleeding risk, these patients still did better than warfarin or acetrom in comparison to NOACs or rivaroxaban. A little thing was there that in the Rocket AF group, the amount of bleeding events was slightly higher, but they were still better than what they were for the VKA groups. In another study, which was done with rivaroxaban, where the CHA2DS2-VASc score was relatively lower, in this patient subset, it was found that bleeding risk was similar to apixaban as in the Aristotle study. So now that we've discussed modifiable risk factors, what about the non-modifiable one? And we know that diabetes is treatable for most and curable for a very few of us. So here's a patient, she's a 68-year-old lady, she's a diabetic, hypertensive, she doesn't have any significant risk of heart disease, she's taking her medication routinely, more or less all her parameters are fine. So if we look at her CHA2DS2-VASc, she's hypertensive, she's more than 65 years of age, she's diabetic, and she's a female, so she has a CHA2DS2-VASc score of 4. And if you look at her Hasbled score, she's hypertensive and age more than 65, so Hasbled score is 2. So considering CHA2DS2-VASc is higher than the Hasbled score, so definitely this patient needs to be started on anticoagulation for her atrial fibrillation. But now which one should we start? Is there any favorable anticoagulant that we can use amongst all the 3? So first of all, we need to decide whether a VK is the way to go or should we go towards a NOAC. So in all the trials that were done, all of them included diabetic patients, and in all of them we found that diabetic patients on NOACs did better in comparison to VKs or warfarin. And this was independent of presence of diabetes or not. And this is a meta-analysis which is showing the same thing, that both diabetics and non-diabetics in all the trials favored usage of NOACs. When it came to bleeding risk also, it was relatively lower for patients with NOACs. But if we look at in the Aristotle study, the non-diabetic patients had much less bleeding in comparison to the diabetic patients. So amongst all the NOACs, if I have to look at them, maybe apixaban has a slightly higher bleeding risk in comparison to non-diabetic patients as compared to the diabetic ones. So because of this, the ESC guidelines said that NOACs are better for diabetic patients, except for apixaban, in which there might be a slight increased risk of bleeding. So when it comes to cardiovascular death reduction, definitely using NOACs did do a better job than what the VKs did. In the Rocket AF study, Aristotle study, and in the RELY, in all the studies we found there was cardiovascular benefit for patients who received NOACs in comparison to VKs. So how do we protect patients from the life-changing complications of non-valvular AF? So there was another trial called the RIVER-DM trial, which sort of looked at diabetic patients who were put on rivaroxaban. And even in this trial, when it came to stroke and vascular death, it was reduced. When it looked at major bleeding and risk of ICH, it was reduced with using rivaroxaban. And surprisingly, patients developed less renal dysfunction when they were on rivaroxaban in comparison to being on VKs. And also they had less limb events and development of diabetic retinopathy. So this is a little surprise because generally VKAs or warfarin and acetrom are the drugs of choice when we look at patients who are having renal dysfunction. But if we look at the medicines alone, NOACs tend to induce less acute kidney injury and less need for dialysis in the future in comparison to somebody who's on warfarin and coumarin. So considering now that all NOACs are going to fare better, so it was clear that our patient needed a NOAC. She was a diabetic, and we have a good data in starting rivaroxaban, which is a single OD dose. So we started her on 20 milligrams of rivaroxaban, and she did fine for the next few years. Now the patient has grown older, 2 to 3 years later. Her diabetes was probably uncontrolled, and she's developed some renal dysfunction. Now her creatinine level is spiked up to 2.7, and her creatinine clearance has gone down. Now, the only catch with using NOACs is that the dose needs to be modified as soon as renal dysfunction starts setting in, because a lot of them have their clearances through the kidney. So again, this lady definitely has a high CHA2DS2-VASc. We know she needs anticoagulation, but which NOAC should we go to and what should the dose be? So in all the 3 trials that were conducted, there were patients who had renal dysfunction, and even with the renal dysfunction, they did better with NOACs in comparison to VKA. But the only point was that in these trials, patients did not have an EGFR which was less than 25. So the dose of all the NOACs needs to be adjusted. Up till 50 to 60 EGFR, we can continue with the same dose. As the EGFR declines below 60 and it comes down to 30, we use a reduced dose strategy for dabigatran at 110. We use rivaroxaban at 15 mg a day. And apixaban, we continue for 5 milligrams twice a day. As the EGFR falls below 30 and goes between 15 to 30, now we cannot use dabigatran. We can use rivaroxaban still at a low dose of 15 milligrams per day, and apixaban dose should be reduced to 2.5 milligram twice a day. In the Rocket AF trial, patients who had a low EGFR and were subjected to a modified or a reduced dose of rivaroxaban, patients who had an EGFR of 30 to 50 and patients who had an EGFR more than 50, both of them did better than the patients who were on warfarin. And when it came to significant bleeding or fatal bleeding, the risk with rivaroxaban was significantly lower in comparison to the risk of patients on warfarin. So if we look at it, when we reduce the dose of NOACs, rivaroxaban still did well. Apixaban surprisingly had slightly more ischemic events or slightly more risk of stroke in comparison to when used with warfarin. But probably the reason for that is an underdosing of apixaban, because until and unless you go to an EGFR between 15 to 30, you don't need to decrease the dose of apixaban, and you should continue it at 5 milligram twice a day. So over here we can see that if we underdose our NOACs, our ischemic risk goes extremely high all of a sudden, whereas we're not getting a significant benefit in reducing the bleeding risk. And again, we discussed this, that using NOACs tends to be better for patients' acute kidney injury and patients' development for need of dialysis. Another issue with starting anticoagulation is for our higher risk population, which is patients above 75 years of age or frail patients. So again, all these patients were also studied in the 3 studies which were done, and despite the age being on the higher side and patients given the standard dose as per the CHADS-VASc and as per the Hasbled score, these patients did well. Definitely bleeding and ischemic risks were higher in patients who were above 75 years of age, but overall the risk and the rate of events were much lesser for patients who were taking NOACs in comparison to VKAs. So my take-home points is that, remember, AF is going to be the most common relevant clinical arrhythmia. Treatment strategies include rate control, rhythm control, and stroke prevention. Risk stratification should be done for all patients, and the CHADS-VASc and the Hasbled score should be mentioned on their prescriptions. VKs are as much of a nuisance as they are of benefit. For non-valvular AF, NOACs are as good as VKs for stroke prevention and with better bleeding outcomes. Rivaroxaban, due to its single dosing and broad indication, is a good anticoagulation to start with. Dose should be adjusted as per the renal function and the Hasbled score. Age alone is not a criteria to reduce the dose. Do not underdose because it increases ischemic risk. And patients' Hasbled and CHADS-VASc score will change from time to time, and it should be evaluated at every follow-up. Thank you so much.
Thanks. So any questions? Thanks a lot, first Dr. Siddhant. It was difficult topic, you have rightly said, and covered it in a nice way. And I will request the chairpersons to have some inputs. Dr. Vivek Chaturvedi sir, Dr. Ram Sharma sir, Ankit and
they have been benefited. His father was actually, he was excellent cardiologist at J.V. Pant Hospital. I know him since then. There's one thing that all the time we have talked about diabetes and everything, but in our clinical practice at hospital level, most of the valvular AF and many patients with cardiomyopathies and AF, low ejection fraction, they come with what we label as a cardiac cirrhosis. The liver functions are poor and they are deranged, bilirubin and everything is there. So in those patients, what is your take? Whether we start with any anticoagulant, if at all, which one? Then secondly, you have already covered, but which one is a better anticoagulant? Is it 2A inhibitor or 10A?
So for your first question, whether we should start anticoagulation for somebody who has a deranged liver function or cardiac cirrhosis.
So most of the patients,
yes, sir.
when they come to the hospital
Yes,
with
yes,
disease,
sir.
they
So-
have already developed cardiac cirrhosis.
So I'll tell you an interesting story. So we had one doctor himself, he was a professor retired from AIMS. His son is an interventional cardiologist, a pretty senior interventional cardiologist. But for some reason, he was coming to my father and to me. So I had started him on apixaban because he had an episode of stroke, which was, a cryptogenic stroke. We don't know the cause for it, but he had a very poor LV. So I'd started him on apixaban, and he eventually had a bad GI bleed. So it is similar to having a deranged liver function, but it's worse because this is an actively bleeding person. So he's a doctor, father of an interventional cardiologist, bleeding with risk of stroke, and I told him, you continue your apixaban, but he said that my son has told me not to take it, but I think I will take it. So his reason was that I would rather die with a brain hemorrhage than live with a debilitating stroke, which I think makes sense. Also, I think it's abnormal PTINR will increase your Hasbled, and I think we should just calculate the CHATS-VASc and the Hasbled for every patient individually. So it is not the right way to say that this anticoagulation is the best one, or rivaroxaban is the best, or apixaban is the best. I think it is extremely important that we individualize for each and every patient, look at his risks for ischemia and bleeding, and also discuss with the patient whether he would live with a stroke or live with a brain hemorrhage.
No, but
So
the specific
it has to be
question is
individualized.
In case also of liver disease or patient's cardiac disease along with hepatic dysfunctions, shall we start with the NOACs or not?
Sorry, sir?
Patients with valvular heart disease with hepatic derangement, shall we start with NOACs or not?
So if valvular heart disease is there, then generally NOACs are not advised. You have to use a VK as of now. There will be more data which will come in the future where maybe a different dosing strategy might help using a NOAC in patients who have valvular atrial fibrillation.
No, but there are many data which suggest that we can use NOACs. That is one thing. Already a lot of data is there. So people are now changing from the regular
Warfarin and acetylrom, yeah.
to the NOACs. Well, there's a lot of things.
I think
What
Vivek
is
sir
important is
can
during liver
probably...
diseases, we should basically have a very cautious. What you have said, we have to see the Hess blood score. So liver disease, once the patient is controlled and his liver functions are reasonably okay with normal PTINR. Sometimes patient has normal PTINR, even with compromised liver function, but with high risk of embolization. Then we have to take a risk.
One more area which I think there is some confusion, that which patients should be considered valvular AF, non-valvular, but which patients should be
So-
non-valvular AF. Patient of let's say 55 years of age comes us with atrial fibrillation. You did an echo, no, there was no history, and then you see that mild mitral stenosis is there, or mild MR, or let's say aortic stenosis. So, just to shed some light that for a general physician, which category of patients to be considered as actually valvular AF?
So I think it's a brilliant question, and I'm sorry, it's my mistake. I should have covered it in my talk as well. So like I mentioned, permanent atrial fibrillation is an atrial fibrillation which is probably not going to go away. So the patient has to live with this atrial fibrillation. So valvular AF is one of the categories where atrial fibrillation is probably going to be permanent. Secondly, the amount of stasis of blood which you will have in the atrial chambers is going to be higher in these patients who have a valvular atrial fibrillation. So the risk in these patients will be high because of permanence and because of stasis. So now if we look at what exactly is valvular AF, any sort of a patient who has severe valvular disease, it has to be severe, whether it's aortic, tricuspid, pulmonary. But when it comes to mitral, any moderate mitral stenosis as well, moderate or higher, and when we say moderate mitral stenosis, we mean that the MVOA is mitral valve orifice area is 1.5 to 2, which is the current recommendation. So moderate mitral stenosis is going to be atrial fibrillation, and all others with severe ones are going to be atrial fibrillation. Along with this, I think now we've started looking at left atrial sizes as well. So if the left atrial size starts going beyond, let's say, 5.5 centimeters, there is a good indication that these patients may go into paroxysmal AF, and because of this large left atrium, which is going to have more stasis, they will have chances of higher stroke. This also can apply to right atrium, but right atrium will generally cause smaller emboli, which will go to the lungs, and they will not have that bad events in comparison to a small clot which goes to the brain. The unfortunate part of atrial fibrillation or any cardiac embolization is that 50% of the debris is going to go to the brain. And anything which goes to the brain, we obviously know is a bad event. So I think, I hope that answers.
Good afternoon, sir. Sir, one question.
Very interesting thing. A patient, 50 years old, with the chronic AF. Shall we put him on long-term anticoagulant therapy with high risk of bleeding, or shall we go for surgical intervention? So what is your take about it?
Sir, so plain surgical intervention for atrial fibrillation is going to be a open maze procedure which is not needed because the risk of that is going to be too high for relatively small thing. Other things that can be done is also an appendectomy, which used to be done, but still as an invasive procedure. Now we have interventional procedures as well. So it is going to be totally up to the patient whether he's okay with that pill burden and that risk of bleeding in comparison to undergoing maybe a couple of maybe an AF ablation procedure, and then he can also have a left atrial appendage occlusion. So there are procedures which a patient can do. But if you look at an atrial appendage occluder, it costs around 5 lakhs. So then the cost of procedures, so at the end of the day, it is going to be dependent on, we will see definitely some patients will say, nahi bhai, mere goli khani hi nahi. Sir, my suggestion would be to go as per guidelines. Take your NOAC and you should be fine.
I think, in my opinion, no intervention for AF is, as of now, justified for its general population.
So, master is on the table also.
Yeah, exactly.
Basically, we all go to the last sentence to Dr. Vivek Chaturvedi. For the topic is like that, and it is difficult for me also. So the master is on the stage, and he is silent, just listening like the God. So we think some time. So sir will give the concluding remarks.
Very pertinent things which sir has asked, and Siddhant has replied them brilliantly. So I'll address the 3 things which you have asked, and the first is the last one, which you are saying, a 50-year-old with chronic AF. So one thing is that per se, that word chronic AF is not defined in that sense. How do you define chronic? Because in the terminology there is something called persistent AF, which is more than 7 days. Then there is something called long persistent AF, more than 1 year. Permanent AF is actually a philosophy. It is not the description of a type of AF. Permanent AF is a terminology where the cardiologist has given up. He says, look, I cannot treat this. There is no meaningful chance that this AF can be converted back into sinus rhythm, so I accept it. Whether that's because multiple times it has been tried, or whether it is because the LA is 7 centimeter, or whether the person is 90-year-old. So that is permanent AF. Now, when you say a 50-year-old with chronic AF, I'm assuming you're saying permanent AF in a 50-year-old. So again, the guidelines are very clear. The anticoagulation is decided by the CHATS-FAS score. The CHATS-FAS score for a 50-year-old with no other comorbidity will be 0. Except if it's a woman, where it is a conditional score of 1. It's a conditional risk factor for gender. That too, in the last ESC meeting, they have taken it away. So a person with a CHATS-FAS score of 0 at 50-year-old, I would not give any anticoagulant for that matter. But there's a caveat here, and that is that there is some indication, not from India, but there is maximum Asian research in AF has happened in the Far East countries, China, Japan, Korea, that this 65 age group cutoff for CHATS-FAS score of age should be brought down for the Asian population. So maybe 55 or something. Plus, if suppose you have some other factors which can increase the coagulation risk. 2 very important factors to my mind, one can be, kidney dysfunction. So if you have chronic kidney disease, then again I would err on the side of caution and still give him some anticoagulant. But somebody with what was used to be called as lone AF earlier, nothing but AF and no other complications, no other risk factors, nothing, I would not give him any anticoagulation because the risk-benefit ratio would not justify it. Typically, with a higher CHATS-FAS score, you get something like 3 to 4% per year. With a CHATS-FAS score of 0, it would be something like less than 1%. All the NOAC trials also, it has been, they brought it down to something like 0.7 to 0.8%. At the risk of a bleeding of somewhere near 0.5 to 1%. So there is no point of giving this. Coming to valvular AF, and how do you define valvular AF? So ESC has defined it very clearly, and that is at least significant mitral stenosis, as what Siddhant said, or a mechanical prosthetic valve. So mechanical prosthetic valve or metallic valve and significant MS for the European purposes is defined as significant valvular disease in which you should not give any NOAC, you should only give VK antagonists. They actually don't have rheumatic heart disease, they have mostly degenerative MR. So they freely give this. There is also some indication that for bioprosthetic valves, you can still give rivaroxaban. There has been a river trial and everything. But a very important trial was conducted in India called the Invictus trial. The Invictus trial had significant MS with or without other disease, and they were again randomized to rivaroxaban or VKA, and this trial actually showed harm with rivaroxaban as compared to VKA. So I was actually discussing this with Dr. Karthike. He's faculty at AIM and he's the main PI of this trial. So I asked him that, you had some patients who had probably milder MS and more MR, and whether in those category rivaroxaban can be given, where there is more MR but less MS, but there is still significant mitral valve disease. And the sub-analysis, which has not been published yet, he told me that practically any significant rheumatic mitral valve disease is there, don't give rivaroxaban. In all of those subsets, it was not found to be a good drug. So significant rheumatic mitral valve disease or mechanical prosthetic valve is what I will say is you should not give rivaroxaban. Coming to your first question about valvular disease with chronic liver congestion or cardiac cirrhosis. So amongst all these, probably apixaban is the one which is secreted most through the liver. And that too, they have, I think, till child C category of liver disease, it can be given, but child C, nothing can be given. So like he also correctly said that, I think if the INR is not high, if it is a compensated liver disease, you should go ahead and give whatever you feel. Almost all of them are practically fine. Because the pill burden is a huge issue, so I think in today's era, probably once a day preparations like rivaroxaban and edoxaban are probably a little bit better in that sense. So I think that is what.
So thanks a lot, sir. We have more sessions.
One
and,
question, sir. One
to
question.
ask something.
Yes, sir. Sir, one question is only there. Sir, is screening echo should be done in every patient presenting to emergency with ischemic stroke?
Sorry,
Sir, screening echo to be done in every patient whom we had got that he or she might have ischemic stroke.
So I think if anybody has a stroke, so whenever anybody has any symptom, this is not just for this question, just in general also, this is at least how I practice. Any symptom one has, define it as a serious symptom or a non-serious symptom. If it is a serious symptom, you have to do everything in your power to get to the etiology of it. As simple as that. Even if, let's say, somebody has a simple syncope, it is a serious symptom because a person can die from the syncope. So get to the bottom of it. If you do not have an obvious reason, do an echo. If you don't find anything, do an ECG. You don't find anything, this patient should be put on a Holter also. If you don't find it, put him on an ELR. Point is, as a patient, the curiosity should come from you that you tell me the cause. I don't want to be sitting, living with the risk for a future event because it's a serious event. So I feel that any serious event, you should do everything in your practical capacity to find the etiology of it so that you can maybe prevent it in a much better fashion in the future.
Sir, in the emergency setting also, even screening echo should be done in every patient, the only thing.
Let's say this patient, you are thinking that the patient has had a stroke. Let's say he has a left ventricle thrombus. So you do an echo, you'll find it. Yes. Let's say the patient has a left atrial thrombus. You'll do an echo, you'll find it. If you don't do it, in fact, I'm sure Ankit sir and Vivek sir are here. They've also seen like patients who have aortic thrombus. They have had an aortic dissection. There's a thrombus which is there in the aorta. So you will definitely, and echocardiogram is such a non-invasive test. It is not even painful, and a screening echo, I think, is absolutely, I don't know if there is any contraindication to do an ECG or an echo because of the sheer non-invasiveness of them. So doing an echo should be done, and I don't see why it should not be done because it gives us more information.
Thank you, sir.
So thanks a lot for the excellent session. Thanks a lot, Dr. Siddhant. Or just a big applause to Dr. Siddhant. Thank you. So I will request for the basically felicitation from on that side to the chairs also. And Dr. Vivek sir will be leading. Just timings का है. हाँ, Dr. Vivek Chaturvedi sir को. हाँ. So next session we will start almost the same because the discussion is so much good that we are just running short of time, and it is directly from, as Dr. Vivek Chaturvedi sir, I am speaking a lot about him, but this time I will just say a word that in around 22 years back, sir was in AIMS. Sir is MBBS, MD, DM, everything from AIMS. Sir is the final word in academics. Most of the intervention cardiologists say, sir, if you have to ask something, the final word in intervention, in anything of cardiology, Dr. Vivek Chaturvedi is the person. He is so good academician, a very good person, very good, usual. And my teacher, because in MBBS only I have learnt, I think Pulse was in AIMS, so I went there in MD first year. And sir was just describing the hypertension on behalf of Dr. Reddy. Dr. Reddy was HOD cardiology, I think, a very renowned name in cardiology in AIMS. And the hall was mesmerized. Sir's sentence always reverberate in my mind, and my hypertension and most of cardiology practice for 20 years, although I haven't done at that time DM or entered in DM cardiology, is from the feet of Dr. Vivek Chaturvedi sir. So to Dr. Chaturvedi sir, and sir will discuss the CHF, the important condition. Thanks.
Thank you so much, Dr. Pavan. You are too kind. I am sure you are yourself such an
And sorry
accomplished
for
cardiologist.
my again apology. Dr. D.K. Chauhan sir will be the chair, and then and Dr. Mukesh Dwivedi sir, Dr. H.B. Singh sir, Dr. Singhal, and Dr. L.K.S. Sinha sir, please.
Generally, it is the job of the chairpersons to introduce the speaker.
Yes.
But I think Chaturvedi Sahab doesn't require an introduction.
Thank you, sir. Thank you.
And Dr. Pavan Sharma has very eloquently described in just a couple of words, sum up everything. One more thing, almost 1% of Indian population is suffering from CHF. Almost 20% people in Delhi are diabetic. A little screening was done in diabetic at random without asking for any symptoms, and echo was conducted, as was just discussed, a very non-invasive and simple test. 67% people diabetic had an echocardiographic abnormality. Quite often we say कि भाई A by E ratio को छोड़ दो. Then we say diastolic dysfunction सब में होता है. No, सब में नहीं होता. I think Dr. Chaturvedi will highlight these things.
I think you have beautifully summarized the big problem we are going to face in India now, and that is the double whammy of diabetes and heart disease. But today, the mandate given to me by Dr. Pavan is to talk about a part of heart failure which is very important. It is being increasingly recognized only now for the last 4 or 5 years. So heart failure with reduced ejection fraction or severe systolic dysfunction, which is described, is a very well known entity, and we all, I think, are already exposed to it, and we are treating these patients. We know how to treat these patients with what is called as guideline directed medical therapy, which includes the RAS inhibitors like ACE inhibitors, ARBs, and nowadays ARNI, that is sacubitril valsartan, beta blockers, and then spironolactone or eplerenone, and finally, in the last 7-8 years, the effects of dapagliflozin or empagliflozin on heart failure. So these 4 are called the foundational therapies for guideline-directed medical therapy. Now, if we look at the time course of a heart failure patient typically, so initially they have some LV dysfunction, or they may have, like Dr. Saab mentioned, some diabetes with some diastolic dysfunctions being found out on routine echo. And then at some point, their risk is increasing, and then they become, this is when they're diagnosed to have heart failure with this function. Maybe they have had an MI, and now they are getting this, or they are diabetic and long-standing diabetes. They can get diabetic cardiomyopathy, and from here the treatment starts. What treatment? Like I said, the guideline-directed medical therapy of the 4 foundational drugs, and that brings down the risk of heart failure, hospitalization, or risk of death. So these do come down, but they don't come down to zero. This comes down a little bit, maybe 40-50% of the baseline risk. It comes down, and then it stays there for quite some period. But typically what we see, maybe after 3-4 years, maybe in some people earlier than 3-4 years, what we see is that the stable heart failure starts behaving badly. And then there are some ups and downs. So you will deteriorate, then you will improve, maybe after hospitalization, then again you will deteriorate and again improve, the risk will go down. But the gradual graph is actually going to climb up, and finally you are into the stage of no return, where there is advanced heart failure or end stage heart disease. So from chronic heart failure to advanced heart failure, there is a gap in between, and this gap is what I will be discussing today. And a name has been given to this gap, is called WFH, or worsening heart failure. Now, within worsening heart failure, what we are realizing is that earlier the concept was that you are stable like this over time, then you have an acute decompensated heart failure, then you go up, but you don't reach here. Your status is still a little bit below, then you have progressively downhill course, then you go down again, then you come up again, and then finally the graph keeps on going down. But what is being realized now is that this graph is not like a series of perpendicular lines. What is happening is that there is no sudden deterioration as we think it is. There is something cooking from before. There are certain signs, certain things which are present, which we don't recognize as physicians and as clinicians. And that this is not a sudden precipitous fall. It is actually a gradual decline from here. And once you've been hospitalized and you improve, then you don't improve so much all of a sudden. Again, you gradually go up, and when you are at this period, you are again at a very high risk of another heart failure event. So when we say heart failure worsening, typically it has been meant to indicate that you are requiring either a hospitalization because of acute decompensated heart failure, or it means that sometimes you are requiring to go to an emergency where they give you IV Lasix and then they send you home because you are a little bit walking breathless, but you're not that sick that you need to be admitted. But what has been a recent concept is that worsening heart failure is much more than just IV diuretics or simple hospitalization. It also means now that if you are requiring higher and higher dose of oral diuretics, so somebody who was on 10 mg of torsemide earlier, now all of a sudden he says ki Dr. Saab, abhi to meri saans kafi phul rahi hai, and you say fine, you're already on sacubitril valsartan, beta blockers, and you are on MRA, and you are on a dapagliflozin, your blood pressure is fine, and your heart rate is also stable, so I'm going to increase your torsemide. So you increase his torsemide and send him home. So what is this thing where a stable heart failure patient needs higher and higher dose of diuretic? So very important registry from Denmark, it clearly showed that if your diuretics need intensification, it is probably not as bad, but half as bad as actually getting admitted. And this has a significant impact on your survival. So if somebody as compared to a heart failure where you don't require escalation of diuretics versus somebody who requires escalation of diuretics, the second person is going to have, many more of them will die because of heart failure in the next 1 year. Also, something very commonsensical, but we never give a thought to it. There are patients who are coming and they're saying that, okay, I missed 1 dose of Lasix, and he's landed up with heart failure in the hospital. So what kind of a person and what kind of homeostasis is this, that missing a single dose of a drug, the person is landed up in a hospital? Or he says कि डॉक्टर साहब शादी में गया था, ज़्यादा खा लिया, अगले दिन से वापस he is back in the hospital. So what kind of a disease is this, that a single indiscretion in your lifestyle causes this? And although it is not mentioned anywhere, I believe, and I've seen repeated chest infections in somebody who is unexplained, and then that is causing heart failure. So what is this? This is nothing but the sign that the body is actually giving you signals that the heart failure is worsening. So even though the person has sprung back to near normal after the event, it is not nearly normal. This is a sign that there are worse things to come, and we must address it at this stage. How do we find out about this? So there is one good way is that, if the troponins or anti-proBNP keep on getting elevated despite stable condition, then that means that there is something wrong. That means that there is some insidious thing which is not expressed clinically yet, but it is causing, it will cause more and more heart failure events in the future. And this is exactly what is worsening heart failure. And this is how we can actually diagnose this. When patient is unstable, requiring doubling of dose of diuretics, or with a single missing of a diuretic, or with a single indiscretion of salt intake, he's landed to you with heart failure, or his troponins are still elevated despite his rocking around normally, then you know there is something is wrong with this patient. So now, whatever the 4 therapies that I have mentioned to you, typically they are all inhibitors. They inhibit some bad pathways in the body which are causing heart failure. So we have ARNI and RAS inhibitors, which I mentioned, beta blockers and SGLT inhibitors. So the new drug, which is not new really, it's been almost 7-8 years now, but in India it's been available for a couple of years now only. It's called vericiguat. So vericiguat is a type of guanylate cyclase, soluble guanylate cyclase activator. It was preceded by something called riociguat, which I think many of us have used for PAH. This is more selective for the arterial vasculature, and vericiguat basically increases nitric oxide, soluble guanylate cyclase, and finally GMP. So others are inhibiting bad things. This is actually promoting a good thing. So a different kind of a mechanism to address the heart failure pathophysiology. So all the 4 others are having a different mechanism to address it, and this is having a different mechanism to address the heart failure. So what does it do? The increased GMP, which is caused finally because of giving this drug, it causes increased blood flow and decreased hypertrophy in the heart. Most importantly, it causes some vasodilatation and increased compliance in the vessels and increases flow in the kidney. These 3 things are the foundational pathophysiologic mechanisms by which heart failure acts. Typically, that is something else, that heart failure is not equal to LV dysfunction. We all know that. LV dysfunction is just one part of heart failure. Heart failure is a syndrome in which nearly all organs of the body are involved. But typically, kidney, blood vessels, and heart are the ones which are most important. So it has an action on all of them. And the landmark trial which was done for this was the Victoria trial. Now this trial is a very interesting trial. If you look at any heart failure therapy, then the relative risk reduction of endpoints has been something like 25 to 30%, 35% for beta blockers in fact. But in this trial, the reduction was only 10%. Even then, the absolute reduction in mortality was actually higher than many other trials, including that of ARNI. So why is that so? Because this was a sicker population. All these trials have been done in patients who had stable heart failure. This trial actually addressed the population we have been discussing all along, and that is worsening heart failure. So much so that if the event rate in these trials was like 15-16%, the event rate in this trial was 35% and 40%. So very, very sick patients who were class 3 to 4 or patients who were just discharged from a hospital, those kind of patients were enrolled in this trial, and they had a significant reduction absolute of 4 events with a number needed to treat of 24. So just to give you the landscape of the different trials and what risk they have addressed in heart failure. So for example, paradigm heart failure, which is this foundational trial for sacubital valsartan. So you can see patients were at much lower risk. Look at Victoria trial for vericiguat. It is right here. So very sick patients were addressed in this trial. So this fills up a gap. It cannot replace the foundational 4 therapy. It replaces an unmet need in patients who have worsening heart failure. So how high is this risk? Typically, American Heart Association says that if you have 7 to 10% risk per year of cardiovascular events because of atherosclerosis, then heart failure risk actually starts beginning from there. So typically, even today, somebody who gets discharged from a hospital because of decompensated severe systolic dysfunction heart failure, you'll be amazed that despite all the treatment being given today, about 50% of them will not be around to see their 3rd birthday from the time of hospitalization. So this is this sick population which is there, and that is why rightly so in all our textbooks it has been said that heart failure with dysfunction has a worse prognosis than cancer of the breast. And despite our addressing with all the 4 therapies, still patients keep on dying, and the residual risk is a lot despite giving all the best possible treatment. And this is where vericiguat has a role of reducing little bit more of that residual risk. So like I said, somebody who has been on all the foundational therapies and then now you have nothing more to offer and the patient is still symptomatic, like this patient, prior MI, LV of 25%, and then subsequently it increases, but over the years he keeps on getting more and more breathless, he's requiring more and more diuretics, and his blood pressure is borderline. He's already on furosemide, sacubital valsartan, EMPA, spironolactone and bisoprolol, and despite this he's still breathless. So what do we do with him? This is the patient in which we would like to add vericiguat, which is available in 3 dosages, 2.5, 5 and 10, and gradually we escalate the dose. The good thing with vericiguat is that the response of blood pressure and kidney is not so bad as with, for example, with sacubital valsartan. So you can afford to give it to these patients. Now, one criticism of Victoria trial has been that when this was instituted, very few people were taking ARNI. So some subgroup analysis have been done in which it has been shown that even if you take all the therapies, still vericiguat adding it will make a lot of difference. Like I mentioned, it is very easy to titrate, and in fact there is a recent article from Europe where they have, in patients who have a decent enough blood pressure, they've started with the 5 mg dose straight away, and that has also been very well accepted. Otherwise, it's a simple titration of 2.5, 5 and 10. On an average, my patients I've seen, the blood pressure reduces by about 2 to 3 mm of systolic blood pressure. So that is something very, very inconsequential. And typically, till now, the biggest patient segment in which we have been using this are patients who are symptomatic despite everything that we can give them, or patients, in Indian patients, we have a big problem that even with very small doses of the GDMT, the blood pressure drops. It drops below 100, and you don't know what to do because, what do you offer to these patients? Typically women who are of so slightly smaller stature. So one tip here I would like to give you is, I don't go by any absolute value of the systolic blood pressure. Obviously, it cannot be less than 80, 85 systolic. But I'm not afraid of giving therapies to people if the blood pressure is less than 100. Because the blood pressure is something which is unique to every individual, and we cannot say that 100 is some sacrosanct figure which needs to be followed, or 90 is a sacrosanct figure which needs to be followed. Typically, I up-titrate these molecules till the time the patient is saying that either I'm too fatigued, I cannot walk, or typically what they will say is that they get postural dizziness. So they will get postural dizziness when they get up from sitting or lying position to standing position. So this is the time when I say that, okay, that's enough, I can't add more therapy to you. But at that place, I may be able to squeeze in a little bit of vericiguat to these people, because nothing else can be given. Again, like I mentioned, no excessive blood pressure reductions were seen with vericiguat. The other scenario, like I mentioned, was that you have started giving GDMT, but you can't complete it because the patient is having hypotension or there is CKD, so creatinine of 2.2, and the blood pressure is 100. You have not been able to add any ARNI to this because of the creatinine and this is a very common scenario. It's a very, very common thing along with diabetes, that you can't add anything further. This is one place where you can add vericiguat, and like I said, because of various reasons like hypotension, hyperkalemia, worsening renal function, you have to stop giving the foundational 4 therapies. And almost 1/3 to 1/4 of people, actually you have to stop giving them altogether or scale it down. And this is again where vericiguat is very, very beneficial, because hemodynamically it is almost neutral and it has very minimal impact on the kidney function as well as potassium. The interesting question now is, what about patients? Can we add this to people who upfront, even when they are not symptomatic, but we anticipate that something is going to go wrong? So typically we do add right in the beginning, even without waiting for GDMT intolerance or GDMT non-response. We sometimes add it to people in whom we know that we need everything to aggressively go right from the front. And typically these are the patients who have long-standing heart failure and in which we don't want to take a chance. So this is where we give these patients vericiguat upfront along with the 4 therapies. And the trick nowadays is, and that's a recommendation, that rather than starting 1 therapy at a time, increasing the dose, then starting second, increasing the dose, and third, increasing dose, you rapidly add very small dosages of all the 4 or 5 drugs. And once the patient is stable over 1 month, has accepted all the 4, then you gradually increase all the 4 in dosages at different points of time. So this is how we manage our patients with heart failure. Worsening heart failure is a very, very important concept. And I would not take, I think I've already taken too much time. And as I said that this is where vericiguat is useful. Vericiguat is now being also tested in the stable heart failure population in the Victor trial, which is already enrolling patients worldwide. And so I'll just summarize this by saying that worsening heart failure is a distinct entity which is only recently been clinically recognized. It is a stage between stable heart failure and end-stage heart disease. It is essential to rapidly identify this stage, because if you miss it, the person will be further down the track of going towards the end-stage heart disease. And it is recognized by clinical worsening in outpatient setting, increasing use of oral diuretics, need of intermittent IV diuretic, and worsening on mild deviations from lifestyle or in medical therapy. Meaningful opportunities exist to address this with vericiguat. There are other molecules also being studied. Ivabradine is one more, which can be added here if the heart rate is not high. Omecamtiv medoxamil is a new drug which is myosin contractor agonist, which is being addressed in this. And I think there are many more drugs in the pipeline for this particular group itself. And residual risk in stable heart failure can also be addressed by vericiguat, and Victor trial is also already ongoing for that. Thank you so much.
Thanks a lot. Thanks a lot, sir, for elusive and beautiful presentation. So we can take questions because FAQS session and time is, we are running short of time. So I will ask the fraternity to take the mementos, and I will also ask for the next session the FAQS sessions. Either side, please. So it will be in almost continuation to the FAQS session, and this is one of the soul of the sessions, the conference. So the questions, there will be frequently asked questions for the common physicians and OPD base, and Dr. Ankit, Professor Ankit is Professor of Cardiology in GB Pant Hospital, Delhi. And 2-3 years back, I think nobody was go to the lunch because of the session he has taken like that. So although we have some shortage of time, but this will be one of the best sessions, although all sessions are very good. So I will ask Dr. Ankit to come, please, for the session. And on the stage, I will ask Dr. Siddhant. Dr. Naresh Goyal sir has come. Sir is one of the senior most persons. Dr. Naresh sir. And then Dr. N.K. Gupta sir. Yes, sir, please. So I will request Dr. Chauhan sir if possible, and Dr. Vivek Chaturvedi sir to be on the stage if possible, because this is one of the session. So Dr. Ankit, please. Dr. Ankit is doing tremendous work even in CSI Delhi. He was one of the inspirational, we should say. So he is handling one of the academics in GB Pant Hospital, Delhi. GB Pant, many of us are alumni of GB Pant, and he is one of the stalwart of GB Pant, the one which is doing excellent job there. So he will be mesmerizing with his topic, with frequently asked questions. We will be interactive. We will try to be short but interactive. Thanks.
Thank you so much, Pawan sir, for a kind introduction and a warm welcome. With the permission of the respected chairperson, I am beginning the session, and it's a case-based discussion, and I would like to request you to be a little bit interactive. So to begin with, 36-year-old male, IT executive by profession, without any hypertension or diabetes, occasional smoker and drinker, presented with left-sided chest pain, multiple episodes daily lasting for 30 seconds to 1 minute for past 1 month. According to the patient, the pain is severe, stabbing in character, unrelated to exertion or any activity. Pulse BP are relatively normal. This is the ECG of the patient, which is also relatively normal. So according to you, what further testing is recommended? Please feel free to answer, then only we can have some interaction.
TMT.
TMT, okay. So somebody wants to do TMT. Any other opinion?
The other opinion is 2D. 2D echo.
2D echo. So we are increasing the job of cardiologist. TMT, 2D echo, somebody also like to do CT coronary angio, or patient may insist that at least do CT angio or do the calcium scoring. So let's see what the guidelines say. So the answer will be here is none. We don't need any further testing in such patients. So first of all, this patient, what is the chest pain? So patient's chest pain is not coming in typical angina because it is not typical in nature. It is not precipitated by the exertion, no use of any nitrates. So if all these three characteristics are meeting, then it is a typical angina, further testing is required. Even at least two characteristics are meeting, then also some testing is required. But this patient's chest pain is typically a non-anginal chest pain, probably does not qualify for further testing. Also, chest pain which lasts for less than a minute is very unlikely to be because of CAD. The symptoms of CAD classically becomes more severe with the increased level of exertion. They have a typical character of pressure, tightness, heaviness, radiation. So here the pretest probability, the age is 36, the patient is male, and the chest pain is non-anginal. The pretest probability of having a coronary artery disease is 1%. The guidelines say if the pretest probability is less than 15%, you don't need any further testing. You can safely reassure the patient that you don't need anything. You can go home. So I hope I have cleared the first question. I am little bit fast. You can stop me wherever you want. A 60-year-old female, diabetic for last 20 years, known CAD for last 5 years, angiography was done, diffuse triple vessel disease, not willing for intervention, presented with worsening of angina for 1 month. Patient is already on aspirin, clopidogrel, atorvastatin, and metoprolol for 50 mg per day. The pulse is 56 per minute, blood pressure is 94/70. Pulse 56, BP 94/70, dual antiplatelets, statin and metoprolol already being given. What else you can do for this patient for worsening of angina? Stop metoprolol, give nitrates, stop metoprolol, add diltiazem, add nicorandil, add trimetazidine. Okay, somebody said add trimetazidine. So answer is yes, okay, add trimetazidine. So if you go by this anti-anginal compass, your patient is lying in this category where the heart rate is already optimized, it is 64 or it is on the lesser side, blood pressure is already low. So you are left with only two options, one is ranolazine or one is trimetazidine, because these are the two drugs with no hemodynamic side effects, neither they decrease heart rate nor they decrease the blood pressure. So if you land up with such of the patient where already the BP is on the lower side, heart rate has already been taken care of by the beta blocker, you are left not with the much choices, you have to give one of these two drugs, and these are more or less similar kind of drugs, both are recommended by the guidelines.
Excuse me, in your compass you have not mentioned about nicorandil, potassium channel opener in your compass there.
Because nicorandil is not available in many countries, it's not used, and this is the compass given by the European countries, they don't use nicorandil, so they more use trimetazidine and ranolazine.
Sir, what about sending to some hospital to do EECP? EECP.
So,
or Karoli Sahab?
The respected Karoli Sahab is no more, so no, please not take his name. But EECP, as per the European, American and as per the Indian guidelines, have no clear-cut evidence and no rules. So I would not send patient for EECP. Although I will try to persuade the patient to at least get the angiography done, and one or the other vessel can be revascularized, then that can take care of the angina if the angina is refractory.
No, practically, I think if you add the trimetazidine also, or ranolazine or whatever metabolic agent, if the patient is still symptomatic, then at least either the nicorandil or ECP as discussed can be considered if patient is not for intervention.
So if patient is clearly unwilling for intervention, then we can think of, but EECP to me, I have never sent any patient for EECP, and I will not talk about EECP on this forum.
And I think one thing which you have mentioned, very important, is that triple vessel disease does not mean complete revascularization.
Yeah, definitely.
You can very easily go and open one artery, one point, which will decrease the symptoms and the patient's
Yes, we have to increase the quality of life. I am not going to increase the quantity of life. We have to increase the quality of life also.
One thing is clear here that if you go by absolute evidence base, ranolazine has more evidence than trimetazidine. Trimetazidine is still not accepted in many parts of the US. There is no FDA approval for trimetazidine, and ranolazine has definitely, there is
definitely,
definitely. The other thing obviously is, one needs to think why the BP is so low. So that is something worth thinking about.
So these are hypothetical questions just to engage the audience and to give an idea. Such type of patient may end up in their OPDs. So how to approach these patients?
Can you go back to the previous question and
CHF would be there in
stop
this
here,
patient.
stop there.
So that may explain, low blood pressure.
Further down.
If you want to say.
This one?
Yeah. So this graph is something I think everybody should see very carefully. This graph represents the whole of, practice of diagnostic possibility of CAD, which is what is all of us are actually doing. If you look at this graph, some things are very, this is called Bayesian probability. So if you look here very clearly, look at with a typical angina, the risk of CAD in a 30-year-old is just 3%. And if you look at a 70-plus-year-old with a non-anginal chest pain, the risk of CAD is still 24%. So somebody who has a typical non-anginal chest pain but is 70-year-old is definitely going to have, 24% will have heart disease. And if you add a modulator here, so if somebody has diabetes, then this again changes the whole thing, because then the risk factor is there. So somebody with an atypical symptom who has 40 to 49 age, men 10%, the moment you put diabetes there, this atypical chest pain probability becomes from 10 to 30%. So whenever we say, what is this person, should I send him for some testing for CAD, we should know the quality of pain and the pretest probability, which is defined by age, gender, and presence of risk factors.
And one more thing I want to add to what Vivek sir just said is that there is a huge misbelief in people that if a patient undergoes an angiogram, कि उसको stent तो डलेगा ही डलेगा. My point is that whenever an interventionalist advises an angiogram, this pre-test probability is going to decide whether this patient needs an angiogram or not. If the patient undergoes an angiogram and angiogram comes out to be normal, why did you get the angiogram in the first place? An angiography, if it is done, should be having a significant blockage. अगर patient को stenting या bypass की ज़रूरत है तो angio क्यों हो रही है? It is extremely important, but unfortunately the concept is different. लोग कहते हैं कि angio हो गई तो stent होगा ही होगा. My point is कि अगर angio तभी हो कि अगर patient को treatment की ज़रूरत हो. And इस चीज़ का decision more or less commonly in pre-test probabilities के basis पे we are very well able to achieve or come to that.
My point is just, I want to add one thing, that these are the European basis guidelines. And we do see the patients, in fact, all of you, the intervention cardiologists or the senior cardiologists who are looking for the patients, we do see the patients of 30 to 40 age group. Probably every week we see one patient of a cardiac MI. So these pretest probably what the West has seen, probably we have, in particular, typical angina patients. In typical angina, we very frequently we see the patients who are less than 40, or you can say the young MI patients are presenting. And every month, in fact, we see a patient who is less than 30. So the pretest probability in a person who has a typical angina of an Indian origin, I think that the percentage bias should be the bit on higher side and should be more intensively investigated, these patients,
Definitely.
if they have a typical angina.
Definitely, typical angina you need investigation, but the question was the patient how to differentiate between the typical angina, atypical
That's
angina.
important.
Yeah.
How to differentiate. Your first question was already there with the typical versus atypical. But what I mean to say, in Indian origin, the age group of 30 to 40 is also very vulnerable for having a CAD.
Definitely, sir.
Also, please, I would request you to add a word to these so-called chelating agents which are being given IV for months for angina reduction. You heard of it?
Chelating agents.
Yes. I'll tell you, there is some people, who give EDTA and other chelating agents through an IV drip to reduce angina, and ये दुकान काफ़ी अच्छी चलती है, which has got no meaning, no proof, and there are lots of such shops in Gurgaon and other places, if I'm not mistaken.
So, moving forward, a 55-year-old male diagnosed as non-ST elevation MI, angioplasty to right coronary artery done 5 months back, non-diabetic, no hypertension, non-smoker. Patient is on aspirin, clopidogrel and statin. Patient went to a physician with a lipid profile of total cholesterol 130, LDL of 50, triglyceride of 200, SDL of 40. The patient is absolutely fine, no complaints. So what you are going to do with the lipid management? Reduce the atorvastatin to 10 mg as the LDL has come to 50, reduce it to 20, change the atorvastatin to rosuvastatin, or continue with the same dose of atorvastatin. So Currently, the patient is taking atorvastatin 40 mg, the LDL is 50, total cholesterol is 110 or something. So what will you do? The patient is saying that, Dr. Sahab, LDL to bahut kam ho gaya hai.
Continue on the same day.
So everybody agree with the continue of the same dose? So I hope the audience is agreeing on the same dose of atorvastatin. You are absolutely correct. So if the patient has had an ACS, our goal should be the LDL should be less than equal to 55, and if we are maintaining of less than 55, we should not interfere with the treatment, and we should not decrease the dose, then LDL should increase, then we should decrease it again. Let it be. The LDL should be aggressively controlled and nothing to be done for this patient. A similar patient, here the LDL is 120, patient is taking rosuvastatin 40 mg. The patient again has no complaint, patient is doing fine. What will you do now? You had many sessions on lipid management earlier. So what will you do now? Continue with the rosuvastatin, add ezetimibe, change to atorvastatin 80, or consider for PCSK9.
Change to atorva 80 mg.
So somebody said to increase to atorvastatin 80, already taking rosuvastatin 40, and now somebody wants to change it to atorvastatin 80. Add ezetimibe. So, although the LDL is not alarmingly high, but it is well above the guideline recommended level. After the angioplasty, that to a left main to LAD in a setting of anti-wall MI, the LDL should be less than 50. Patient already taking the maximal tolerated dose of rosuvastatin, and shifting to atorvastatin 80 will not help. So in such patient, we have to add on some drug. The best recommended guideline directed drug is ezetimibe 10 mg per day. Some people would like to add the bempedoic acid, but the European and American guidelines both are saying that first we have to add ezetimibe, and then if it is not controlled, we can think of bempedoic or PCSK9. So here the patient is already taking highest tolerated dose of statin, and if the LDL is more than 55, then we have to add the statin and ezetimibe. And if it is still not controlled, we have to give PCSK9 or bempedoic.
Ankit sir, one small thing I would like to add, that this patient, despite Rosuvas 40 mg, is still at 120. So Rosuvas 40 is obviously high dose statin. It reduces LDL by 50 to 60%. So after his 50 to 60% reduction, he has reached 120. If we add ezetimibe, that's another 5 to 10%. Adding bempedoic is going to be another 5 to 10%. So absolutely that we have to go as per guidelines, because it's still early and we don't need to be so hyper, and as per the Lipid Association of India, we can go up to an 80 to 90% reduction of LDL with oral therapies. But at this point, I think briefing and counseling them that they may need PCSK9 is going to be good, because I think we might miss despite using ezetimibe and bempedoic, because baseline has come only till 120.
Definitely. So a very commonly asked question to all of the cardiologists, that I have got 5-6 stents implanted for any of the reason. Now I am having low back pain, somebody is having shoulder pain, somebody is having knee pain, and somebody has got stroke. Whether I can do MRI or not. So this patient was advised MRI lumbosacral spine and was sent to a physician for the clearance. The patient has absolutely no complaints, no angina or dyspnea. Patient is taking regular medicines. So what is your advice regarding the MRI and the cardiac stenting? So patient can go MRI at least 6 weeks after the stenting, and preferably after the 3 months. This patient has been implanted stent recently. Patient can go only 1.5 Tesla MRI in the presence of stents. MRI should not be done in the presence of multiple stents. Up to 3 stents it can be done. After more than 3 stents it should not be done. And patient can go under MRI safely anytime in presence of cardiac stents.
Can undergo MRI safely anytime?
Only one of the audience is participating. I need more participation from the audience.
Usually even my paramedics, everybody asks, and this is a very genuine question. So initially we used to think कि भाई अंदाजे से कह दो 3 महीने बाद. So I will be with one. Endothelialization के लिए.
Sir, he can undergo MRI safely because the stents that we use nowadays are MRI, like they can be used
So
in MRI.
some people will say the older generation stents. Some people will come to you that I
Sir,
have been.
but you said 1 month before only he has put in the
People may
stent.
come to you that I have been implanted stent in GV Pant 20 years back when the stenting was started. So can I go MRI this time?
That is no
So
idea.
all the stents from the previous generation also were from the non-ferromagnetic materials, and they do not interfere with any of the described MRI protocols, and you don't need to wait anything for the MRI for 6 weeks, 3 months, and it does not depend on the number of the stents. So all of the commercially available stents can be imaged at even 1.5 Tesla, 3 Tesla at any time. Be it cardiac MRI, you can also safely prescribe cardiac MRI also in these patients. So MRI is absolutely safe for the patients of cardiac stenting. The things differ with the pacemakers, but for the stenting there is no such recommendation.
Can be done anytime.
Anytime, in any
Even
number of stents.
With the previous generation stents also.
All with the previous generation stents also. So very pertinent question for the physician. A patient is coming to you who underwent angioplasty with 3 stents 2 months back. Patient is on aspirin 75 milligram, ticagrelor 90 milligram, BD, atorvastatin 40 mg OD. Patient is unable to afford the costly ticagrelor and went to physician for a substitute कि cardiologist तो बहुत महंगी महंगी दवाई लिखते हैं, कोई सस्ता सा substitute बता दीजिए. So what will you do and how will you change the medicines in this patient? So I am giving you options. The simplest is कार्डियोलॉजिस्ट ने ट्रिकाग्लोर लिखी है, नो सब्सटीट्यूशन अलाउड, वही खाने पड़ेगी. स्टेंट बंद हो जाएगा तो हम जिम्मेदार नहीं हैं.
Stop ticagrelor and start with clopidogrel.
Stop ticagrelor and start with clopidogrel 75 milligram daily. One option. Third option, stop ticagrelor, load with clopidogrel, continue with 75 milligram daily. Fourth option,
Option 3.
No need of ticagrelor, only aspirin is sufficient.
Third option.
So
Dr. N.K. Gupta also with the third.
So why third? Why we can't just give clopidogrel 75 milligram OD? So the answer is correct. The explanation is, so whenever you are changing anything from the ticagrelor is a reversible inhibitor. So whenever you are giving, either you are upgrading the therapy to prasugrel or you are descalating the therapy to clopidogrel, you have to reload. So you have to, clopidogrel also you have to reload, prasugrel also you have to reload. Also in the acute phase within 30 days or even after the 30 days. So whenever you are shifting from ticagrelor to any therapy, you have to reload the therapy. The only exception is you are downgrading or descalating the therapy because of bleeding, then only you can omit the loading dose and you can just give the maintenance dose.
Just a brief note on this thing, that whether I just want to know that that loading should be the full, the 600 milligram or
Yes,
300 milligram.
it
If
is
the person is definitely on ticagrelor full dose from long
So
time.
you have to load after the 24 hours of the last dose of the ticagrelor. So if patient is taken the today morning dose, you have to load tomorrow morning with the clopidogrel. Omit the today evening dose of the ticagrelor.
So why don't we just continue, and whenever we want to shift over, then half dose loading would be sufficient, 300 milligram.
So there is no evidence for half loading. This is our convenient dose that half.
We want to skip the second dose of ticagrelor and to give this after 24 hours. Ki, okay, you skip today's dose and tomorrow morning take the 600 milligram totally once the ticagrelor is washed out.
So
and second, the take is suppose this loading. Okay, that why can't we use the prasugrel in these patients, which is a good medication, and 60 years probably the weight is also good, and 3 stents. So prasugrel is better if the finance is only the constraint for ticagrelor.
So the finances here were the constraint. That was the question. The finances are the constraint. The prasugrel is also the similar cost. And clopidogrel is easily available in any of the government setups freely also.
Sir, in the same vein, in the continuation of the same, what's the minimum duration of DAPT? 1 month, 3 months, 6 months, or a year?
So if the stenting has been done for acute coronary syndrome, the duration of DAPT should be at least for 1 year. If the stenting has been done for the chronic coronary syndrome or what we call as stable angina, then the duration of DAPT is 6 months.
Can you stop DAPT at 3 months also? There are papers.
Sir, you can stop DAPT at 1 month also. There are multiple papers. What the guideline recommend is for ACS, it should be preferably given for 1 year. For CCS, it should be given for at least 6 months. There are newer generation stents for like master depth trial with Ultimaster. You can safely stop DAPT at 3 months. With the Zynes 90, you can stop at 3 months. With Zynes 60, you can stop at 2 months. There are multiple papers with 1 month also, but the guideline recommend for the benefit of the patient that at least 6 months of DAPT to be given for chronic coronary syndrome if there are no contraindications. If the patient is having bleeding, you have to stop. But if there are no bleeding, you have to give for 6 months.
See, the whole thing is cardiology is totally, the whole subject is always based on Taraju, risk-benefit ratio. Stents were being put even when there was only one single antiplatelet, and most of the people were doing fine. But we always see the risk-benefit, so adding 2 drugs increases the benefit while the risk of bleeding is not that much increased. This is why we add 2. But whenever there is a bleeding, then obviously we de-escalate, and then it's not as if all the stents close if you stop one antiplatelet. So like he has mentioned that all these things are done just to show, but the maximum evidence is for 1 year for ACS and 6 months for.
And just to add on this, I think we all know that as the number of stents increase, the length of metal increases, the complexity of it increases, the chances of having bad events if you stop your blood thinners are going to be high. Unfortunately, वो कहानी थी ना कि जिन की ताकत तोते में होती है, तो blood thinners for us is very much similar to that, and I think it has to be sort of mentioned as a cardiologist. We should mention on the paper that, you know, if there is a bleeding issue or anything, this needs to be done or this should not be done, which is lost sometimes, and that's why the confusion sort of arises.
So again, a very simple question. A 55-year-old female diagnosed to have a gallstones, non-diabetic, non-hypertensive, no CAD, CVA. Which of the following tests are recommended before giving clearance to the cholecystectomy?
ECG and echo.
ECG and echo. So why you are leaving TMT?
participating. Mainly the non-physicians also are interested. ECG काफ़ी हो जाए तो काफ़ी रहेगा, अच्छा रहेगा. सर्जरी तो होंगे नहीं तो बड़ा मुश्किल होती है.
So बिना कुछ करे तो सर्जन सर्जरी करेगा नहीं. वो कुछ तो
सर्जरी कर देगा, एनेस्थीसिस्ट नहीं देगा.
तो आपको उसे कन्विंस करना है कि क्या कम से कम करने से काम चल जाएगा.
ECG and echo.
ECG, somebody saying ECG को फिर इको में टाइप 1 डायस्टोलिक डिस्फंक्शन आ जाएगा या माइल्ड MR, माइल्ड TR आ जाएगा, तो उसके बाद फिर TNT.
गाइडलाइंस क्या कहती हैं? गाइडलाइंस क्या कहती हैं? You will be surprised.
So you will be surprised, as sir has already told. You don't have to do anything.
Just
ECG
you
is
have
not
highlighted the answer, but what I mean to say, what I wanted to add upon is, the question is incomplete because you have not mentioned the functional capacity of the patient.
You don't need to assess.
No, I think that is very important.
So
in
I am
any
explaining, you
patient,
don't need to assess.
that functional capacity of the patient, whether the patient is able to walk, not walk, what is the symptoms, the patient is having typical angina or not angina, at least the functional assessment should be the criteria.
So functional assessment is one thing, but functional assessment is required in some of the other things I will tell you. So first, how we approach such patients. So first,
This is the most discussed question. Please listen. Please listen.
so how you have to approach such things? First, you have to find what the surgeon is going to do. So always ask what surgery he is going to do. what organ he is going to operate. So where your surgery is lying, whether it is a low risk surgery, it is an intermediate risk surgery, or it is a high risk surgery. So if he is going to high risk surgery, I will advise you to involve a cardiologist. Don't give clearance for these high risk surgeries. Your domain should be in these two. So where the cholecystectomy is lying, it is lying in an intermediate risk surgery. So if the intermediate risk surgery, then you have to think what is your patient. So your patient is non-diabetic, non-hypertensive, not a known case of CAD. ठीक है, age less than 65. So where he is lying, age less than 65, without hypertension, without dyslipidemia, smoking, without diabetes, no history of CAD, not a pre-existing CAD.
Sir, I will have a contrary view. Actually, I am anesthetist. I am professor and head of the Department of Neuroanesthesia.
Okay,
and
sir.
our guidelines, the American Society of Anesthesiologists, ASA guidelines, they certify according to the grade 1, grade 2, grade 3, according to the morbidity and mortality and also the systemic illness. So somebody is, even if patient is not having the hypertension or diabetes or some systemic illness, but above the age of 40, you must have to go for the ECG. And above the age of 50, this is a clear-cut guidelines of American Society of Anesthesiologists, which is followed in India, Indian Society of Anesthesiologists, otherwise you will be held medico-legally. You have to get the, if the age is above 50, you have to get both ECG and echo done.
No, sir, I completely disagree with you.
This is my guidelines of Indian Society of Anesthesiologists.
No.
You may not be agree, but this is the takeoff.
So don't use the word medico-legal. If somebody is not doing ECG and echo, he will be held medico-legally.
As a cardiologist, you are saying that, but something happens to you. So it lies on the anesthesiologist to defend himself. That's why, because I am facing such cases also, and as a person, because in the court you have to follow some guidelines, and as being an anesthesiologist, you have to follow the guidelines of the Indian Society of Anesthesiologists that clearly says that above the age of 40 you must get the ECG and chest X-ray done. Above the age of 50 you must get the echo done, even if the patient is having the abnormal.
Okay, so let's not increase the controversy. Guidelines may differ from region to region, from societies to societies, from a perspective of a cardiologist, from a perspective of an anesthesiologist. My job is to clarify what the guidelines of the cardiologist say to you, and you can always follow these guidelines because these are the most standard guidelines being prescribed by one of the most prestigious institutions. And here is, you have to identify your surgery, you have to identify your patient, and then you have to tell your patient what risk you have of the cardiovascular complication. Anything can go wrong even with the simplest of the cataract surgery. I am not talking about what may go wrong, but what is the risk of cardiovascular complication in such patient, that while doing the surgery, what is the risk of having a cardiovascular event? Can you have a heart attack? Can you have a cardiovascular stroke while doing the surgery? So that risk depends upon these findings. So if the patient is less than 65 years of age, without any risk factors, you are doing a low risk surgery or an intermediate risk surgery, then none of these major testings are required. If you are doing, then it is okay, it's up to you. But even if you are not doing it, then also nobody is going to catch your neck, and you are not going to land up a cardiovascular complications. But in this patient, similarly, here the patient is 70-year-old male who is diagnosed to have a mature cataract. He is diabetic, he is hypertensive, he is not having a pre-existing CAD or CVA, patient is asymptomatic, fair functional capacity, ECG already been done, he is having RBVB. Then again, what further testing is required? According to some of the guidelines, echo is at least mandatory. Every now and day, they are sending 100 of patients for us for echo. So most of us will agree that at least echo to be done before doing any surgery.
None for cataract.
So here,
because of the type of surgery.
not one risk factor, age, diabetes, hypertension, RBBB, 4 things are there. So still it's none.
Just one small thing, this patient should not be taking aspirin. Even though it is not indicated, but a lot of times we see a lot of patients taking aspirin just for primary prophylaxis. We can
So I'm
take that
coming to that also. So here also, echo is not required because again, cataract is extremely low risk
Low
surgery.
risk surgery, basically low risk surgery.
So even multiple risk factors you have, you don't need echo for the cataract surgery. You don't need any TMT. Even you don't need to assess the functional capacity also. So coming to one more question of like this. So here, the patient is having a diabetes, hypertension, ACS done 2 months back, for which he had angioplasty with 1 stent on aspirin and clopidogrel, severe toothache. The dentist has advised dental extraction of 2 teeth. The patient was referred to a physician for clearance and to adjust medicines. So what will you do? 2 teeth need extraction. Angioplasty has been done. At least wait for 1 year, delay the procedure. Because for ACS setting, patient is on DAPT, stent has been implanted. Stop clopidogrel for 5 days before extraction and restart after the hemostasis. Stop clopidogrel, start low molecular weight heparin or heparin and do the procedure. Continue DAPT and do the procedure. Very practical question.
Stop clopidogrel 5 days before extraction and restart after the procedure.
So somebody is stopping clopidogrel for 5 days before extraction and restart after the procedure.
Somebody wants continue DAPT and do the procedure.
I would prefer the fourth one, but none of the dentists will do this thing.
Will do.
I'm
Even if you keep on changing the dentist, they are not going to do it.
So
The guidelines say, sir.
because we have made it like that, so the answer again here is continue DAPT and do the procedure. You print out these charts and attach the photocopy of this chart to your dentist.
It is, I haven't seen any dental surgeon doing a procedure on DAPT.
So they have to do it because you are harming the patient by stopping the DAPT for a stent which have been implanted 1 month back.
I think what is important is to understand which bleeding is significant bleeding.
So
even if the patient undergoes a tooth extraction on the DAPT, he will have some bleed, but because it's not a significant bleeding, so there is no point of taking a risk of stent occlusion for just a dental extraction. So you can go ahead and...
So it is a dual phenomena. First of all, we are afraid of bleeding and we don't know when to stop the DAPT or in which cases we can continue with the DAPT. And second, the surgeons or the dentist or whatever who is on the other side is afraid of bleeding. So we have to convince, it is a mutual shared decision that this is a minor procedure. Even if some bleeding occurs, let's not risk the life of the patient with the stent. Continue the DAPT and do the procedure. Whatever bleeding will occur, we will take care of the bleeding.
So Dr. Naresh, I have a novel solution to this. So basically, you will be interested to know this, that American Dental Association guidelines also mention DAPT to be continued. So that way, unlike anesthesia, here we are on the same platform. So I tell the patient to not tell it at all. Because the reason is very simple.
So practical.
See, this, unlike a spinal bleed, a tooth bleed is accessible to pressure. You know, you can accept, rather than 5 minutes, 5 minutes you hold it, you can hold it for 10 minutes. It will stop eventually. So DAPT continue and...
So what I would do this thing is, first let the 3 month pass and let the patient bear some pain and get at least 1 month, wait for 3 months at least. And once the 3 months has been passed, and then tell the patient that for the shortest duration, you need to hold only 1 antiplatelet, because as we discussed previously also, it is the risk versus benefit. And see where the stent has been placed. If the stent has been placed in the proximal LAD or left main, again you need to wait for 1 year. But if the stent is placed in a minor band like a diagonal or obtuse marginal, then at least 3 months to be on DAPT. After DAPT 3 months, if the patient is very much in problem and the dentist is not ready to do it on DAPT, then probably you can proceed with holding 1 antiplatelet. And because I have seen most of the dentists are able to do the procedure on 1 antiplatelet.
Sir, people who even hip surgery on aspirin, there is no problem, which is supposed to be a major surgery. And if the tooth is really aching or a root canal is exposed, I think one would not like to wait for months.
लास्ट क्वेश्चन तो फिर मैं दूसरे दिखा देता हूँ इंटरेस्टिंग वाले. So in the interest of the time, we are stopping the session, but for the interest of the physician, some different questions out of this box. So you have to identify the drug. Can you identify the drug with this hint? I am giving you 4 hints. Whoever identifies the drug will get a prize from Pawan sir.
Yes, agreed.
I have got 3 such questions.
I will give to Ankit at last, I think so.
So this is a map, there is a hint. Questions are not for Vivek sir and Dr. Siddhant. Okay, second hint. So speak loudly to get your prize. Okay.
Warfarin Coumadin.
So it is a warfarin. So how these figures are connected? So it was the University of Wisconsin where the warfarin was first synthesized. Green leafy vegetables decrease the effect, so they are prohibited. It was first introduced as a rat poison, warfarin, and it is used in DVT and pulmonary embolism. So identify the drug.
Before, just sorry for this interruption. Another tip I'd like to tell. How much ever you try, patients will not stop their greens, and it's not advisable also. So what do you do for these patients? Everybody has patients on warfarin. You must tell them to take green vegetables consistently. Don't stop them altogether, but they should not be yo-yoing in that. That एक हफ्ते खाया, फिर एक हफ्ते नहीं खाया, 3 दिन खाए, 3 दिन सर्दी खा लिए, गर्मी में नहीं खाए, वो नहीं हो सकता. If you keep it at the same level, then you can dose adjustment of warfarin can be done according to that.
So can you identify with this hint?
The drug with the 6 o'clock.
It is one of the most commonly used drug by all the doctors.
Clopidogrel?
No.
Unicontin?
Unicontin, no.
It's always used at 6 p.m. It's always used at 6 p.m.
Somebody has said Lasix.
Lasix, who said Lasix?
Many of them. My counting is increasing for the gift.
Okay. So,
Now it's a diuretic Lasix.
and these are the ECG features of hypokalemia.
Okay, bas
So
ho gaya.
what this 6, the brand name Lasix came with a drug that lasts for 6 hours. So half-life is typically less. So we have to give the Lasix frequently at least 3 times a day or 4 times a day. So brand name Lasix was introduced as furosemide that lasts for 6 hours. It is used in pulmonary edema or cardiac asthma, hypokalemia, ECG changes, and it's a diuretic. The last question to conclude the session. Whoever identifies this drug will get a bumper prize from Pawan sir. It is the toughest of the question. And you will be really amazed to see the drug at the end. Can you identify this plant? Eucalyptus? No. Can you identify this person? And what is this? Iqbal. No, it is a Spanish artist. Yeah, Salvador Dali. A Spanish artist. But difficult. So one more thing. Can you identify him? He is one of the most famous painter of human mankind. No. Vincent van Gogh.
Morphine? No.
Morphine has nothing to do with Vincent van Gogh.
Digoxin?
Digoxin.
Digoxin. session can continue for 1 hour, if but everybody is hungry, so one session is more. That
So
is
what
why
was, is presumed that the Vincent van Gogh was having heart failure and was being prescribed digoxin, and what his all paintings are famous for this yellow halo around his painting, be it a Starry Night. This is this painting is called Starry Night, one of the most sold painting in the world. And this starry halos are because of the side effect of the digoxin called xanthopsia. Salvador Dali, from this the reverse mustache sign of the one of the side effect of the digoxin came. This is a foxglove purpura from which the digoxin is being synthesized first time. Digitalis has been extracted, and this is the atrial fibrillation in which the digoxin is used. Thank you so much. You have been a wonderful audience.
Thanks a lot. Wonderful session. Wonderful session. A big applause to Dr. Ankit. Great. He has done wonderful job.
And sorry,
this is
I might disagree with some of you regarding
the bumper prize, first of all.
bumper prize. He deserves bumper prize, and for the 10 minutes also, because Dr. Ankit will be on the dais and we will remain the same.
And
Naresh sir session is there for 10 minutes. We
Yes.
will go for the lunch after that.
Yes.
Please be for 10 minutes. Or sir, you can go after lunch or whatever you want.
just one thing, there might be a disagreement regarding one of these guidelines and some things. Whatever you are following, please keep on following. This was just for the discussion and a healthy discussion purposes. I don't want to demean anyone.
So we will continue with Dr. Naresh sir session, and then for 10 minutes please. Dr. Naresh Goyal sir is a very senior cardiologist. He is a senior director with Marbagh. Sir is a very gentle person, very approachable, and I should say a very practical person. And he is one of my teachers. He is from GB Pant. He was from AIMS, GB Pant, and he will mesmerize us on a home-centric approach in treatment of CHF. Please.
Thank you, Dr. Pawan, and all the audience who give us an opportunity to interact with you. And I think Dr. Vivek has already discussed a lot about the heart failure treatment and the management. They've make my topic easy. It's not exactly on what I mean to say on the medicines or the treatment. It is that approach, how we need to analyze the things and what are the parameters which are really important. We have seen different medications are being prescribed. If you ask a common person, why should I take these medicines? Suppose his blood pressure is on higher side, why he should take the medicines? He is totally asymptomatic, but we still give him a medicines to control his blood pressure so that his future should remain good, better, and he should have a better time at home as well as having less time to the hospital or have any kind of a complication. Or like what we prescribe the statins to any person who has a dyslipidemia. His main or only question कि डॉक्टर साहब दवाई क्यों खाऊं मैं? He was totally asymptomatic कि भाई तुम ठीक ठाक रहो उसके लिए that medicine is important, and that's what we are going to discuss about the home time. When we discuss about any medication, we talk about the hard endpoints, like what are the MACE, what are the chances of having myocardial infarction, what are the chances of having any like a complication or a hospitalization. Then we talk about the morbidities, ki how many the hospitalization he required, the readmission rates, the other complication rates. So which metric really matters? The mortality, when we discuss about the hard endpoints has not been achieved with this particular medications. Nowadays we are talking the recent medication is the inclisiran, where we are not discussing that what are the mortality benefit of inclisiran. Or when we talk about the morbidity, we have discussed about few medication in the past also that they patient have a morbidity benefit, but there is no mortality benefit. But what is the most important concept for the patient perspective is how many time, what is this home time, when he is comfortable at home and he is not going to have a repeated hospitalization, he doesn't require to repeated go for a consultation or admission or have any kind of a complication. So this home time concept is probably much more important for the patient than he is comfortable. So mortality and readmission rates has been widely studied in the context of heart failure outcomes, and nowadays we have a worsening heart failure, readmission rates, hospitalization rate. but these clinical endpoints may not fully account for the overall patient experience. What the patient needs is, what is this home time defined as a time spent by the patient alive and out of any healthcare institution for the consultation or the revisits. It's an important patient-centric outcome, you can say, for patient with particularly cardiovascular disease. So these are the times that account for the total number of the hospitalization. These are morbidity and mortality, and objective measure that does not require any adjudication. Because when we discuss about the mortality, when the patient has a death which is cardiac or a non-cardiac death, then you need to see the record, the sudden death, whether it was cardiac or non-cardiac. But what matters the most is how much time the patient has been comfortable. So the success of particularly heart failure treatment kind of a disease where you have a repeated hospitalization, repeated admissions, the treatment is impactfully measured by the length of the comfortable home time. And mostly it is being underutilized in clinical practice, and most of the studies has not calculated these things. That was the concept, and how the home time has been modified by certain medication in particularly heart failure. That's what we are going to discuss. So when we talk about the heart failure, there's a mortality rate around 10% at the 30 days post-discharge period, and years after discharge it's around 30%. But if you see, only 1/5 of the patients experience 100% home time in the year after discharge. So how we can increase this home time, that is today's topic and discussions. When the patient is being discharged from the hospital, the initial few weeks, 2 to 4 weeks, is very important, where he is more liable to have more complications. Because we have seen, you have modified the medication at the time of hospitalization, you have started the 4 pillars of the medications, you have started the ARNI, MRAs, beta blockers, but the complication what is going to may happen in the recent discharge after the first time, after 3 to 5 days, you need to check what is their potassium level, you need to check what is their blood pressure level, how there is urine output, what is their renal functions. So this is a very vulnerable period when the patient may develop hypokalemia, hyperkalemia, and land up again repeat hospitalization or have a more complication. So this 1 month period is really need aggressively to be monitored to improve his home time. So what are the medication, what are the process, how we can improve it. So first is, as Dr. Vivek has discussed, to start all the 4 medication, possibly heart failure medication, as soon as possible. But once the patient is being discharged, because we don't have here at rehabilitation facilities, most of the hospitals are being discharged. Once the patient is fit enough, they don't want to stay in the rooms or the wards in the hospital, they want to go home. But that time is very vulnerable, and we should strictly monitor those periods. Mostly around 3 to 4 patients require rehospitalization in next 1 year. So almost 30 to 40% patients require rehospitalization. So clinical impact of prior heart failure hospitalization is around 30% of patients are readmitted 1 year, 25% are readmitted more than once during the first year. So this rehospitalization, how we can reduce this rehospitalization? For this, we have certain medication that we are going to discuss, and it's and rehospitalization not very benign things. If you see the mortality, once the rehospitalization increases, the mortality also increases. Every second hospitalization, every third hospitalization increases the mortality. So it's not always the mortality which is important. The rehospitalization morbidity is also important. It have a financial implication as well as the health implication. So we need those home times, time that reduces the morbidity and mortality and have a better home time. And another parameter is what we can discuss about the quality of life that also improves when we have a better home time. So this is the composite outcome of mortality or heart failure hospitalization inversely related to the KCCQ score. So if a patient has less hospitalization, the score is very good. If patient has more hospitalization, the score is less. So its impact on survival and how we can improve these things. So we need less hospitalization, low mortality, improved quality of life, and so that we can improve the home time. So therapy that reduces hospitalization, lower mortality, they only do things. And these are the standard medication what we are using. Although most of the guideline has suggested to use ARNI in heart failure, and we have a good number of patients who are either on ACE, ARB. SGLT2 inhibitor is another things which need to be added, but B, C, D and SGLT2 inhibitor are very important. And one point I want to highlight here, whenever you get a chance in any patient of heart failure or particularly HFrEF patient or mid-range ejection fraction, we should give them an option to start an ARNI, that is sacubitril valsartan in these patients, because that has shown a very good outcome in these patients. So what the guideline says. So this is the ACC guideline what we commonly follow. Initiate ARNI de novo without prior exposure to ACE or ARBs. It is administered in conjunction with a background of GDMT for heart failure. And ARNI is the preferred renin-angiotensin system inhibitor, should be used as the first line therapy. And almost the same European guideline also say about to start ARNI as soon as possible. But what is the Indian consensus document is ARNI should be started in all patients with decompensated heart failure before discharge, once they are out of their parenteral diuretics or inotropes. So the crux is, whenever you have an option to start an ARNI in any heart failure patients, we should give this option with its clinical benefit to the patient to decrease the morbidity, to decrease the mortality and improve the home time. So if you see the primary composite outcome, CV death, heart failure hospitalization, almost 20% benefit in comparison to the ACE inhibitor. So the point which I want to highlight again and again here, even if the person is comfortable on ACE inhibitor, I think again we should give them a chance to switch to the ARNI. It's a recommendation based by the evidence. If you see, there is a significant benefit in the different outcomes of CV death, heart failure hospitalization and all-cause deaths. So these kind of the things only improve the home time, and once you give them ARNI, probably in a heart failure patient you can have a better home time. So this is reduce the CV death and the heart failure hospitalization and improves the home time. You have seen there is a significant benefit, more than 20%, 20 to 30%, and this is a molecule which has shown on top of the routine GDMT therapy. Initially, we know that ACE inhibitor has shown benefit of 20%. That is the only molecule above these things has shown significant benefit. Even up to 60 days, there is a significant benefit is maintained, reduction in heart failure readmission as well as reduction in all-cause readmission with sacubitril valsartan in comparison to the enalapril. So better decrease in mortality rather than ACE inhibitor as well as the angiotensin receptor blocker also. I can skip this slide. Yeah. This is the common parameter which we usually see, and the patient usually also, once the patient are asymptomatic, then they want to know how they should and why they should continue these kind of medications. So that is the molecule which has shown there is a benefit also in ejection fraction. Most of the patients do see the benefit over from 3 months to 1 year. There is a significant benefit you can see from 3% to 10% almost improved in LV ejection fraction in these patients of HFrEF patients. In different other echocardiographic parameters has also shown benefit, that is end diastolic volume and systolic volume, left atrial volume or E by E prime. So it helps in improving the quality of life. As you can see with the KCCQ score, that is not very typical, but you can do a 6-minute walk test at your activity level, even in your clinic. Domestic activity, respiratory efficiency, sexual activity in these patients has also been better with the ARNI in these patients. These are the different parameters you can ask these patients. Basically, daily living activity, you can have that KCCQ score and you can ask how, that is how you can have the patients who he knows, because the patient is also very much interested about the numbers. In cholesterol, you have that what is my LDL level, what is the cholesterol level. In blood pressure, you have a level of the blood pressure or hypertension patient. In dyslipidemia, have a LDL level. But here in the activity level, if you get a KCCQ or a 6-minute walk test, that helps to maintain the patients so that my walk test or my distance has increased, that gives a benefit. These numbers are important for the patients. And it has shown sustained improvement with the quality of life, even up to 1 year, that improvement sustains and persists for these things. So to conclude, home time is defined as the time spent by the patient alive and out of any healthcare institution, represent a novel trial endpoint that intrinsically reflects mortality and hospitalization event, but with a patient-centered approach. Heart failure therapy, that reduces hospitalization, lower mortality, enhance quality of life, it improves the home time. And sacubitril valsartan, that is ARNI, is a guideline recommended first line treatment for all HFrEF patients. It has proven benefit which maximum home time in HFrEF patients. Thank you.
Thanks a lot, sir. Sir, beautiful talk. And I will request for just these 5 to 7 minutes, please be here. We are just doing the inauguration and oration, and I want everybody to be here, please. We will be together. We are together for around 10 years. Thanks a lot, Dr. Naresh Goyal, sir. Thanks a lot, Dr. Vivek Chaturvedi, sir, and everybody. And we will be inaugurating the lamp, and everyone is a part of that. Please be wait for 5 minutes for the lunch. ये book दे दो, ये शुरू करो, वो दे दो book दे दो. So, in the meantime, with 3-4 minutes, I will share the journey. So, एक दे दो, वो इधर दे देना. The thing being that most of us are together for around 10 years. This was started because of one of the, in one of conference I said, one of my teachers and Dr. Sebel sir, that I want to do a meeting, and he convinced everybody for doing that. One of the regret is he is not here. The other was Dr. Anil Chaturvedi sir. He was always there on the stage in this. So we have made a small souvenir for them that will be inaugurated by all of us. The second thing is that Dr. D.K. Chauhan sir was in the first meeting also. The most of the persons who are there were in the first meeting also. So thanks a lot for coming, and thanks be the part of this journey for around 10 years. So I appreciate, and with everyone we will be trying to do a small tribute to the Saraswati Vandana, and then with a small souvenir. And after that I will say for the lunch, sorry for the delay, we are delay in timing, but we will try to be as fast as possible. So please keep patience for 3-5 minutes if possible, please. Sir, kara de. Please come, sir. Dr. Vivek Chaturvedi, sir. D.K. Chauhan, sir. Please, sir. Naresh Goyal, sir. Please. Professor Ankit. Please. And Dr. Divedi, sir. Dr. Ram Sharma, sir. Please. Whoever I am calling everybody. Please, you can come in queues. Please be stand if possible. And then we can do. Everybody is a part. We all are the part. Sir, please.
Saraswati वंदन ध्यान को, मूरख हम नहीं जाने जननी, पूजन वंदन ध्यान को। आदि शक्ति कर क्षमा हमें, आदि शक्ति कर क्षमा हमें, पूजा के उद्गार दे, पीड़ा पाड़ी तार दे, तार दे।
बदल दे।
इसका तो पूरा नहीं डालना यार। मुझे पता है ये एंड टाइम पे दो से जाके तीसरा नहीं पूछेगा, ये किधर गया।
कौन सी बोलिए?
SNE is a charitable trust making a positive impact on people's lives. With its commitment by providing essential medical and philanthropic aid, it stands by the people always. SNE takes various social welfare initiatives, and Walkathon is one of them. Walkathon. This is one of the social welfare steps SNE takes with the general public. It's a program that promotes awareness about the importance of fitness and physical activity. Thousands of individuals, including children, women, and senior citizens, participate in this walking marathon. Prestigious doctors educate the public about healthy lifestyle choices, including nutrition and exercise. They provide guidance on the importance of maintaining a balanced diet, incorporating exercise into daily routines, and adopting healthy living habits. SNE organizes philanthropic programs from time to time to help marginalized sections of society improve their lives. They distribute artificial limbs and wheelchairs to improve mobility. SNE workers distribute food to people in need. Additionally, SNE conducts plantation drives and other activities for social welfare. Since 2016, SNE has organized Cardiocon every year. This medical conference provides a forum for doctors to learn about the latest research, treatments, and clinical trials. Cardiocon also offers an opportunity for doctors to share their own views, research, and findings. Sarve bhavantu sukhinah, sarve santu niramaya. This mantra is driving us forward to create a healthy and happy society. SNE is a charitable trust making a positive impact on people's lives. With its commitment by providing essential medical and philanthropic aid. It stands by the people, always. SNE takes various social welfare initiatives, and Walkathon is one of them. Walkathon. This is one of the social welfare steps SNE takes with the general public. It's a program that promotes awareness about the importance of fitness and physical activity. Thousands of individuals, including children, women, and senior citizens, participate in this walking marathon. Prestigious doctors educate the public about healthy lifestyle choices, including nutrition and exercise. They provide guidance on the importance of maintaining a balanced diet, incorporating exercise into daily routines, and adopting healthy living habits. SNE organizes philanthropic programs from time to time to help marginalized sections of society improve their lives. They distribute artificial limbs and wheelchairs to improve mobility. SNE workers distribute food to people in need. Additionally, SNE conducts plantation drives and other activities for social welfare. Since 2016, SNE has organized Cardiocon every year. This medical conference provides a forum for doctors to learn about the latest research, treatments, and clinical trials. Cardiocon also offers an opportunity for doctors to share their own views, research, and findings. Sarve bhavantu sukhinha, sarve santu niramaya. This mantra is driving us forward to create a healthy and happy society.
Share.
SNE is a charitable trust making a positive impact on people's lives. With its commitment by providing essential medical and philanthropic aid, it stands by the people, always. SNE takes various social welfare initiatives, and Walkathon is one of them. Walkathon. This is one of the social welfare steps SNE takes with the general public. It's a program that promotes awareness about the importance of fitness and physical activity. Thousands of individuals, including children, women, and senior citizens, participate in this walking marathon. Prestigious doctors educate the public about healthy lifestyle choices, including nutrition and exercise. They provide guidance on the importance of maintaining a balanced diet, incorporating exercise into daily routines, and adopting healthy living habits. SNE organizes philanthropic programs from time to time to help marginalized sections of society improve their lives. They distribute artificial limbs and wheelchairs to improve mobility. SNE workers distribute food to people in need. Additionally, SNE conducts plantation drives and other activities for social welfare. Since 2016, SNE has organized Cardiocon every year. This medical conference provides a forum for doctors to learn about the latest research, treatments, and clinical trials. Cardiocon also offers an opportunity for doctors to share their own views, research, and findings. Sarve bhavantu sukhinha, sarve santu niramaya. This mantra is driving us forward to create a healthy and happy society. SNE is a charitable trust making a positive impact on people's lives. With its commitment by providing essential medical and philanthropic aid, it stands by the people always. SNE takes various social welfare initiatives, and Walkathon is one of them. Walkathon. This is one of the social welfare steps SNE takes with the general public. It's a program that promotes awareness about the importance of fitness and physical activity. Thousands of individuals, including children, women, and senior citizens, participate in this walking marathon. Prestigious doctors educate the public about healthy lifestyle choices, including nutrition and exercise. They provide guidance on the importance of maintaining a balanced diet, incorporating exercise into daily routines, and adopting healthy living habits. SNE organizes philanthropic programs from time to time to help marginalized sections of society improve their lives. They distribute artificial limbs and wheelchairs to improve mobility. SNE workers distribute food to people in need. Additionally, SNE conducts plantation drives and other activities for social welfare. Since 2016, SNE has organized Cardiocon every year. This medical conference provides a forum for doctors to learn about the latest research, treatments, and clinical trials. Cardiocon also offers an opportunity for doctors to share their own views, research, and findings. Sarve bhavantu sukhinha, sarve santu niramaya. This mantra is driving us forward to create a healthy and happy society. SNE is a charitable trust making a positive impact on people's lives. With its commitment by providing essential medical and philanthropic aid, it stands by the people always. SNE takes various social welfare initiatives, and Walkathon is one of them. Walkathon. This is one of the social welfare steps SNE takes with the general public. It's a program that promotes awareness about the importance of fitness and physical activity. Thousands of individuals, including children, women, and senior citizens, participate in this walking marathon. Prestigious doctors educate the public about healthy lifestyle choices, including nutrition and exercise. They provide guidance on the importance of maintaining a balanced diet, incorporating exercise into daily routines, and adopting healthy living habits. SNE organizes philanthropic programs from time to time to help marginalized sections of society improve their lives. They distribute artificial limbs and wheelchairs to improve mobility. SNE workers distribute food to people in need. Additionally, SNE conducts plantation drives and other activities for social welfare. Since 2016, SNE has organized Cardiocon every year. This medical conference provides a forum for doctors to learn about the latest research, treatments, and clinical trials. Cardiocon also offers an opportunity for doctors to share their own views, research, and findings. Sarve bhavantu sukhinha, sarve santu niramaya. This mantra is driving us forward to create a healthy and happy society. SNE is a charitable trust making a positive impact on people's lives. With its commitment, by providing essential medical and philanthropic aid, it stands by the people always. SNE takes various social welfare initiatives, and Walkathon is one of them. Walkathon. This is one of the social welfare steps SNE takes with the general public. It's a program that promotes awareness about the importance of fitness and physical activity. Thousands of individuals, including children, women, and senior citizens, participate in this walking marathon. Prestigious doctors educate the public about healthy lifestyle choices, including nutrition and exercise. They provide guidance on the importance of maintaining a balanced diet, incorporating exercise into daily routines, and adopting healthy living habits. SNE organizes philanthropic programs from time to time to help marginalized sections of society improve their lives. They distribute artificial limbs and wheelchairs to improve mobility. SNE workers distribute food to people in need. Additionally, SNE conducts plantation drives and other activities for social welfare. Since 2016, SNE has organized Cardiocon every year. This medical conference provides a forum for doctors to learn about the latest research, treatments, and clinical trials. Cardiocon also offers an opportunity for doctors to share their own views, research, and findings. Sarve bhavantu sukhinha, sarve santu niramaya. This mantra is driving us forward to create a healthy and happy society. SNE is a charitable trust making a positive impact on people's lives. With its commitment, by providing essential medical and philanthropic aid, it stands by the people always. SNE takes various social welfare initiatives, and Walkathon is one of them. Walkathon. This is one of the social welfare steps SNE takes with the general public. It's a program that promotes awareness about the importance of fitness and physical activity. thousands of individuals, including children, women, and senior citizens, participate in this walking marathon. Prestigious doctors educate the public about healthy lifestyle choices, including nutrition and exercise. They provide guidance on the importance of maintaining a balanced diet, incorporating exercise into daily routines, and adopting healthy living habits. SNE organizes philanthropic programs from time to time to help marginalized sections of society improve their lives. They distribute artificial limbs and wheelchairs to improve mobility. SNE workers distribute food to people in need. Additionally, SNE conducts plantation drives and other activities for social welfare. Since 2016, SNE has organized Cardiocon every year. This medical conference provides a forum for doctors to learn about the latest research, treatments, and clinical trials. Cardiocon also offers an opportunity for doctors to share their own views, research, and findings. Sarve bhavantu sukhinha, sarve santu niramaya. This mantra is driving us forward to create a healthy and happy society. SNE is a charitable trust making a positive impact on people's lives. With its commitment, by providing essential medical and philanthropic aid, it stands by the people always. SNE takes various social welfare initiatives and walkathon
lunch, we will be starting the proceedings again. And thanks to all of you for the presence and for the patience also. You were all through for this time. So I will request you to spare some time for some time also. So I will request Dr. Praful Pandey. For the next session is Dr. Praful, and I think he is here about just. So, and the chairperson, I'll just give me 3-4 minutes. I think he must be doing lunch. So first he is keeping the audience ready, then he will come. So just give me 3-4 minutes, please. सीवी नहीं आया, कोई बात नहीं, वो खुद बोल देंगे.
मैं लैपटॉप चेंज कर है ना.
आ गए. अच्छा सर, वी वर कॉलिंग यू, बेसिकली यू मस्ट बी बिजी. सो जस्ट 5 मिनट्स के इसके बाद फिर कर देते हैं, कर दो फिर. सो डॉक्टर प्रफुल्ल पांडे विल टेक दिस सेशन. मैम उसके बाद 10 मिनट में सर कर दें. आइए प्लीज़. सो आई शुड, ही इज़ one of the toppers of basically MBBS, MD, DM. One of the renowned cardiologist is associated, he's son of a very close friend and renowned cardiologist. So I will request Dr. Pankaj Chaudhary. Dr. Pankaj Chaudhary sir. Dr. Harish Gupta sir to chair the session please. Dr. Pankaj Chaudhary sir. Dr. Prakash Gera sir. Dr. Himanshu. Topic is basically, topic Dr. Praful will tell, cancer immunotherapy and cardiotoxicity. Dr. Ashok sir, please sir, आइए. And Dr. Sushil Tyagi sir. The topic is cancer immunotherapy and cardiotoxicity in and newer anti-cancer molecules. As we all know, very
senior panel is there on that side, and I will request Dr. Praful to start the proceedings. Please, Dr. Praful, please.
So, Dr. Pawan, I think.
Dr. Yuvraj has also come. Thanks a lot, sir.
Dr. Pawan, it's very important to know the side effects of a drug rather than the effects of the drug.
Yes,
so, I think we are dealing with, at times the patient comes and we don't know about the adverse effects. So, it's very imperative to know each and every drug and their adverse effects as well. I think cardiotoxicity is very important, and it is most of the time is not diagnosed properly actually.
Yes.
So, I think Praful will take it and will discuss afterwards.
Yes. The thing being that sometimes the counseling is also important. Dr. Gera sir is here, Dr. Prakash Gera sir, and he has vast experience. So if you say for some of the medications which are chronic one, for example beta blockers and all that, sir, you advise the patient do some counselings. What you usually suggest?
I try, but majority of patients these days we see these come via Dr. Pawan Sharma, isn't it? Because he is the primary kind of cardiologist and special hypertension. But I must add one thing here regarding Praful. What a wonderful profile he has got. Congratulations, and I think we are blessed to have you today here.
Thank you, sir.
And cardiotoxicity with all these things is a very, very relevant, important topic today. Because as a physician, at times we get lost regarding that. And I think with your kind of expertise, we will be much more wiser today. Thank you, Professor.
Thank you, sir. Thank you so much, sir.
Yes.
So, good afternoon, everyone. I am Dr. Praful Pandey, currently a consultant at Yashoda Hospital, Kaushambi. And the topic I have chosen today is cancer immunotherapy and cardiotoxicity. There are some reasons for choosing this topic, because as will be covered, immunotherapy is something that is coming up in almost all the malignancies that we are seeing. And myocarditis from this agent is something that is, as sir has rightly pointed out, difficult to diagnose, difficult to treat, but has a 40% mortality. And as the patents of the drugs go away and the drugs become more and more accessible, this side effect is something that cardiologists and physicians in general should be very much aware of, so as to be able to support us in the treatment of this case, because at the end of the day, all of us want the same thing. We want the best possible outcomes for our patient. And if we give a drug and it shortens the lifespan as compared to the malignancy itself, then we have done the patient a disservice. So this will be the overview of the presentation, a brief primer on immunotherapy, then why is diagnosing myocarditis an issue, what is the role of the commonly available tools such as our serum biomarkers, ECG, echo, GLS, cardiac MRI, and in some cases biopsy, and then how are we expected to manage these particular cases based on the current. Starting with why is this topic necessary, what is immunotherapy and why is it important for us. The story started with James P. Allison, Sir James P. Allison and Taksu Honjo, who were the first people to be able to map the PD-L1 receptor, for which they won the Nobel Prize. It was a breakthrough because unlike our conventional understanding, it was realized that in every average individual, including you and me, 15 to 20 malignancies form within our body every day. And yet the immune system of our bodies is somehow able to curb them. However, immunity must be failing at some point for the cancer to progress. And that was typically by the malignancy cells being smart and co-opting the PD-L1 receptor so as to stop the immune system from attacking against the malignancy. So the notion was that by blocking these receptors, we may be able to get a type of drug that will prime the immunity in fighting the cancer. So as I mentioned, chemotherapy was nothing but a poison that was poised towards killing rapidly dividing cells. So once the chemotherapy was stopped, there was no protection. And because the body has many other rapidly dividing cells such as the GI cells or the hair cells, the side effect profile was not very good, which is justified by the people being very much afraid of chemotherapy. Immunotherapy, on the other hand, does not have that side effect profile, and because immune cells, once primed, will keep attacking the cancer cells, it provides something that has been mentioned here. Post-treatment protection is very high. So a drug for patients which is more tolerable, has more long-lasting effects, is obviously a win-win for oncology as compared to conventional chemotherapy, which is why it took up in a big way. Keeping that in mind, a multitude of drugs have been innovated by the pharma. What I have highlighted here are the drugs that are commonly used. So in clinical practice of most cardiologists, you may get a reference for patients with nivolumab or pembrolizumab. These are the two drugs that are most commonly used, and the nivolumab patent is about to expire in 1 to 1.5 years, so it will become even more common. Not to mention, a lot of institutes are researching on low-dose immunotherapy. So even the drugs which typically cost around 2 lakhs per dose may have their cost reduced to 30 to 40,000 per dose, and hence a multitude of patients may be receiving these drugs and coming to you. This is just a figure to show how immunotherapy has come. As you can see in this figure, these are all the current indications of immunotherapy, and for all the major malignancies, we have immunotherapy in first line or second line. In Indian settings, because of tobacco use, head and neck cancer remains the most common malignancy overall as per registry data. And immunotherapy has recently been approved in radiotherapy settings also, and in metastatic settings it remains the mainstay of treatment. One of the innovations that has happened in the last 40 years. In the last 40 years, we had no new drugs for head and neck cancer, but now we have these with staggering survival benefits, very difficult to ignore. However, as I have mentioned, immunotherapy just primes the immune cells. The drugs don't know which immune cell will kill the cancer and which immune cell will have adverse effects. So even the autoreactive clones that we have in our body that are typically suppressed by the thymus at an early age can also be forced to proliferate, because of which the side effects of immunotherapy, while not like cytotoxic chemotherapy, are basically any and every autoimmune manifestation you can think of. Most commonly starting with rash and pruritus, going on to colitis, going on to myocarditis, going on to endocrine abnormalities, basically any and every disease as a physician with an autoimmune basis, that side effect can be seen with immunotherapy. And we have to be very vigilant because some of them present so occultly and in such a way that unless we are primed with these disorders, we won't know that this is what the patient is suffering from. Fortunately for us, incidence and lethality of these side effects have an inverse relation. Myocarditis, which will be discussed in this lecture, is amongst the uncommon manifestations. However, amongst all side effects of these agents, it has the highest mortality reported. Starting with the clinical features and diagnostic challenges faced by these patients. The biggest challenge is the uncommonness of this side effect. It is seen in only 1% patients. However, the mortality with this side effect is somewhere around 35 to 40%. This is the highest amongst all side effects of this drug. Even with chemotherapy, when we talk about mortality with the agent, we don't have side effects going beyond 20 to 25%, even in average volume centers. But here we have a side effect with an average mortality of 40%. 4 out of 10 will die of this disease, even if everything is done right. So it is exceptionally important to be able to pick this up early. To complicate matters even more, the disease can present from nothing but asymptomatic troponin rise to fulminant cardiac failure and malignant arrhythmias and complete heart block. To complicate the matters even more, unlike most of the complications, we never know when this side effect will come up. While most side effects happen within 3 to 4 cycles, we know that myocarditis can happen within the first dose of immunotherapy itself. Because cancer is a very complicated milieu, we have a multitude of competing causes that can cause similar side effects or similar clinical presentations. And there are no specific findings for this disease barring endomyocardial biopsy, which may not be feasible in most of the circumstances. Lastly, because it's an autoimmune phenomenon attacking the muscles, concomitant myositis is seen in 10% cases, and it can complicate via respiratory muscle paralysis, confounding clinical presentation, diagnosis, treatment, and further monitoring. As can be seen from this graph, what I want to show here is that the probability that a patient will have myocarditis not only varies by the type of cancer, but also by the type of agent we are using. It is impossible to predict. It depends upon the patient's profile, the drug used, the cancer they have, their gut microbiome, their fitness, because of which, although even artificial intelligence has been tried to figure out which patients will respond and which patients will have side effects, in the current scenario, we don't know who will end up having this complication. And since we have a 40% mortality, we need to be very vigilant about this. The timing of this side effect is completely unpredictable. So this is a small gist of the modalities we have for diagnosing this. These will all be covered in more detail. But as with any cardiological disorder, blood biomarkers, ECG, echocardiogram go a very big way in diagnosing. Cardiac MRI only when things are suspected, with limited role of nuclear imaging and endomyocardial biopsy for only those cases which are highly equivocal and we don't know what we are dealing with. Patients with cancer presenting to you with heart failure or myocardial dysfunction or conduction abnormalities or arrhythmias, type 2 MI is amongst the most common differential diagnosis that we have, followed by acute coronary syndrome via plaque rupture. We also have competing drugs that can cause these syndromes. Radiation can also cause this, although it is typically not caused in the acute setting. So, starting with the main part of the talk, what is the role of biomarkers that we commonly have? So, as we know, the key biomarkers are troponins, creatine kinase, and some other enzymes that are elevated in myocardial injury. Conventionally, troponin I was preferred because troponin T and CK was elevated in myositis as well, something that is known to happen with immunotherapy. So there was a perceived lack of specificity with these markers. However, as will be covered frequently, more recent evidence shows that troponin T is a much better marker simply because it is much more sensitive, and we will not miss these cases. This is somewhat akin to the myocarditis dilemma with the COVID vaccines, where the more intensively we investigate, the more patients we get. Sensitivity has been denoted to be as high as 100% in some registry data, which is why if currently a patient with suspected myocarditis comes, or if a patient comes for clearance being planned for immunotherapy, cardiac troponin T is the preferred biomarker because of its very high sensitivity. This is the study that has evaluated the diagnostic and prognostic utility of these serum biomarkers by Lemon et al. So as you can see from this graph, the troponin T is significantly higher in almost all the timelines in patients with myocarditis, and as you can see here, 98%, 100%, 100%, 100%, 98, 97, 90. So in a vast majority of patients, troponin T is elevated. So biomarkers and enzymes will never definitively diagnose. They are a modality for us to figure out which patient to evaluate further. By that regard, because the elevations are much more severe and much more ubiquitous, cardiac troponin T is the test to go if you have to go with only one biomarker. Additionally, troponin T is also prognostic. Compared to the lab threshold, if it is more than 32 times elevated, then these patients have a significantly higher risk of major adverse cardiovascular effects, 4-point MACE, with a hazard ratio of 11.2. To speak simply, they are 11 times more prone to have a major adverse cardiovascular effect while being inpatient. This data does not even capture the patients who may be discharged and then have an event after that. However, testing for troponin T alone is not a good idea because CPK also has a significant role, as has been tested. As you can see in this graph from this paper in JAMA, when all the three biomarkers are tested, patients having all three biomarkers elevated is 95% in patients with myocarditis compared to only 5% patients with no myocarditis, subsequently proven. So, while biomarkers are only a way for us to know which patient to evaluate further, if we need to have confirmatory or semi-confirmatory diagnostic clues with biomarkers, ordering all three might be a very good idea, provided that they are available. Additionally, in this study, creatine kinase was also prognostic in these patients. This is very important because, as will be covered subsequently, depending upon the possible outcomes of the patient, we will have to tailor our immunosuppression. So in clinical practice, a take-home message for biomarkers would be, go for both, ideally all three. Threshold for evaluation is universally accepted as more than 5 times upper limit of normal. Please keep in mind this is not based on prospective evidence. So there might be patients who do not have this threshold but otherwise have a very suggestive features, or you may not have a good feeling about the patient. Does not mean that we do not evaluate them further. They should be evaluated. This is a side effect with a significant amount of mortality. Assay specific upper limit of normal, ascertaining it is extremely important because all the evidence, all the thresholds are based on a ratio rather than an absolute value. And regardless of the values, in cancer patients, things like ACS, cardiotoxicity from alternative agents, or sepsis from febrile neutropenia will always remain differential diagnosis, and clinical acumen plays a very major role in deciding which patient to evaluate. A very common question is that while we are getting baseline markers for these patients, which is recommended by European Society of Cardiology, because a lot of these patients may have subtle baseline elevations from some other causes, do we monitor them serially? Unfortunately, all these trials are ongoing. However, from a practical standpoint, there is no harm in evaluating these patients serially prior to every cycle with ECG and troponin, because if we detect these patients in an asymptomatic phase, they can get away with subtle immunosuppression rather than marked immunosuppression with multiple agents. ECG is another investigation that is to be done at baseline and ideally for monitoring if resources permit. They can detect arrhythmias, they can detect AV blocks which have independent prognostic value, and they can detect malignant ventricular tachycardias which are an indication for upscaling therapy. The role, as I mentioned, is unclear in surveillance. However, it is still something that should be done if the resources and patient allows for it. Most common abnormalities are tachycardia, QRS prolongation, and QTC prolongation. Abnormalities that have a prognostic impact in this setting are complete heart block, low voltage complexes, and the presence of pathological Q waves. As can be seen, complete heart block has a 7 times roughly risk of mortality, and pathological Q waves have a 6 times higher risk of mortality. However, given this milieu, there are a multitude of causes that can cause ECG abnormalities, including ACS. Antineoplastic agents are notorious for QTC prolongation, and the only way to confirm that is to stop the agent and assess QTC once again. Patients who are on chemoimmunotherapy may have severe vomiting or diarrhea, which can lead to electrolyte abnormalities causing variation in QTC. That again should be corrected and confirmed if QTC prolongation is the only evidence we have for myocarditis. So echocardiogram is a very important modality that should be done at baseline and for monitoring. The typical findings are reduced ejection fraction, regional wall abnormalities as will be covered, global hypokinesia, pericardial effusion, or with spectral echocardiogram in play, changes in global longitudinal strain. So what are the take-home messages or key points to remember with echocardiography in this setting? The most important thing is that a normal ejection fraction does not rule out this entity. Not only can these patients have myocarditis, they also have a 38% risk of MACE, even with a normal ejection fraction. And in these patients, monitoring for GLS has a very important role, because for even a 1% decline in GLS, the risk of mortality increases by 4.4%. It can be normal in early disease. So if you have a patient on this drug with a normal echo or a near normal echo, but you have a high index of clinical suspicion, cardiac MR would ideally be the next step to evaluate. Just a brief point about RWMAs. Regional wall motion abnormalities have typically been a part of coronary artery disease. However, because autoimmune myocarditis with this agent is a very focal entity, with the lymphocyte infiltration is not diffuse across the myocardium compared to other autoimmune disorders, we can have regional abnormalities in this disease. However, it is extremely unlikely they will be in a coronary distribution. So RWMAs by itself should not prompt you towards going for an angiography. However, if it is in a coronary distribution, then CAD should be ruled out. Apart from ICI myocarditis, anthracyclines, which you will typically see both these agents in a patient of breast cancer, they can be competing as a cause of myocarditis. We can also have sepsis as a part of infections in these cancer patients. Ischemic heart disease is always a differential. In patients who are receiving mediastinal radiation, that is a competing differential diagnosis. And as we know, cancers are a hypercoagulable state, so venous thromboembolism also remains a competing cause for patients with circulatory failure or respiratory failure in an acute setting. Lastly, in the echocardiogram, something about the pericardial effusion. Pericardial effusion is seen in myocarditis in 15 to 20% cases. However, it is not at all specific. Current evidence says that it is associated with a higher risk of heart failure but not with mortality. Unfortunately, there are a multitude of causes causing pericardial effusion in malignancy patients, including metastasis, radiation pericarditis, infective pericarditis, uremic pericarditis from tumor lysis syndrome or underlying CKD. Hypothyroidism, a common complication of checkpoint inhibitors by itself, can cause pericardial effusion. Heart failure from alternative causes, flare of an additional autoimmune disease. In cases with lung cancer, perhaps post-surgically, we can have pericardial effusions. And a multitude of agents, notoriously dasatinib, anthracyclines, VEGF inhibitors, or even non-malignant drugs that are used in these patients, for example, carbamazepine or naproxen, are known to cause pericardial effusion in some cases. So it's very important to delineate, especially if pericardial effusion is the only abnormality that we have.
Praful, can you summarize because time is up? Just summarize.
So cardiac MR is the modality that will be able to help us in diagnosing it further. For cardiac MR, we need to know that quantitative mapping is better than typical imaging. As far as endomyocardial biopsy is concerned, it is typically indicated only for patients who may be having superadded viral infection as well via molecular diagnosis and PCR. Treatment mainly is dependent upon the grade, and the mainstay of treatment is steroids, pulse steroids for 3 days, followed by low-dose steroids for 4 more days, followed by taper. In patients who have severe disease upfront, abatacept and ruxolitinib are good drugs that can allow us to deal with these patients better. Trials are ongoing for these agents, but in the current practice, steroids with ruxolitinib or abatacept, which is a CTLA4 antagonist, remain the mainstay of therapy.
So thank you, Praful, for highlighting the importance of this adverse cardiotoxicity of immunotherapy. Generally, the immunotherapy is safe, right? Because as we compare to chemotherapy, chemotherapy has more side effects as compared to immunotherapy. But yes, it depends on indication, right? Some patient needs immunotherapy, some patient needs chemotherapy. But I think probably the chemotherapy would be the gold standard as of now. But maybe the recent advances coming up, newer drugs are coming up. Immunotherapy may take over chemotherapy in future because of the least side effects. And you all said that this myocarditis and other cardiotoxicity is 1%, adverse effects. But if there could be fatal, that's actually is very important to, diagnose it early and manage it wisely, right? So as you have already said that MACE is another side effect that has to be taken care. The pericardial effusion and then acute MI sometimes mimics acute pericarditis. So and cardiac biomarkers definitely mainstay, and I think bedside echo is one of the important tool of investigation that actually rule out whether it is dealing with pericarditis, myocarditis, or acute myocardial infarction.
Yes.
So thank you, Dr. Praful, for bringing up this matter, and I think this is a very niche topic. So if any questions from the chair that can be taken on. Dr. Ashok?
Yes, Dr. Ashok, please.
Thank you, Dr. Praful. Your presentation is very simple, and I think a lot of people might have understand the your modality of treatment for various cancer and had very good effect of, I have seen many people have responded well. They have gained life 4-5 years. So keeping that in mind, the cardio toxicity with this medication is very low, as you stated already. And the method of detecting is very simple also. You have to do the just cardiac biomarkers, you have to do the ECG and echo also follow. And already you stated MRI, cardiac MRI can be done, but biopsy it is not recommended, and I think it is not, nobody is doing it. So
Yes,
it is easy way we can understand the pathophysiology of these drugs. So nice presentation. Over to Dr. Pawan sir.
I just want to give
Yes.
this information that Praful is, the son of Dr. Anand Pandey, very known cardiologist in this area. And congratulations, Praful, for getting into this MD, DM in oncology from Indian Institute of Medical Sciences.
Thank
and
you,
all
sir.
the best for your future.
Thank you, sir.
Thanks a lot, Dr. Praful. And Dr. Gera sir has summarized that one should have a CV like him, I think. That is the overall accomplishment you have done is very wonderful. You are one of the best. One of the best we are aspiring for and looking for the treatment of the future generations. And a beautiful discussion and elusive discussion. Thanks a lot, Dr. Praful.
Thank you, sir.
And I will ask Dr. Sachin to please felicitate the faculty. Please come on that side. इधर से आ सकते हैं. या उधर से please. Thank you. नहीं नहीं कुछ नहीं है तो आ जाइए please उधर felicitation. Sir, Dr. Harish Gupta sir, please for felicitation please. Please आ जाइए. क्या था भैया? And meanwhile, I will go with the next topic, almost not the last, but almost the last, and this is one of the best which we have for 10 years. We are continuing with this topic and gaining a lot. The end is all about this starting, and we have Dr. Riyush and Anu Tikkuji who mesmerize us, and every year she gives a talk, she gives a different talk, and the thing is that is so beautiful. We are always, and the topic for today talk is science of self-realization. So everything comes and goes. So it is a stage, they used to say, but the science of self-realization. So Anuji will enlighten us on this. Please, please.
मुझे ना माइक चाहिए होगी मैं तो मूव करूँगा हाँ मैं कीप ऑन मूविंग
So Anuji is associated with ISKCON as a preacher. She may introduce herself. That would be better for me because she is very good in orations and yes. The first slide will be the mind-body connection, and we will start with that. So and ma'am, Narottam ma'am, please for chairing the session, please. Dr. Yuvraj Sharma sir, sir please. Dr. Riyush sir, Dr. Riyush please. आइए सर डॉक्टर युवराज डॉक्टर रीयूष मुझे बहुत अच्छे लगेंगे बहुत दिनों बाद आइए आइए डॉक्टर ग्लैडविन आइए प्लीज So Dr. Riyush is one of the friend, and I started the practice with him in 2010 in that part. And sir has been very humble to all of us, a very good, even a very good doctor. At that time he was practicing actively, and in between till these 4 or 5 years he is a very good preacher, and they are associated with ISKCON. And thanks a lot for the last 10 years straight, he has arranged this thing for us, the mind-body connection and this topic which are always relevant and will remain relevant, science of self-realization. So over to you, please.
Thank you so much, Dr. Pawan. And we are very, very thankful to him. He gives us an opportunity to have this session at the end or at the beginning, but he always gives us a time so that, we can speak about certain things which we, in the common, life, we keep on neglecting such things. But those are very important parameters which we should take account of. So thank you so much, Dr. Pawan Sharma, for giving us this opportunity again today. Now, before we start this topic, I would like you to please, what we are going to discuss, this is basically a very deep topic and thought-provoking topic. So you all are, I know, must be very tired because it's almost the end of the session. But please spare your half an hour and we will be telling you certain things which we usually skip out from our daily schedule. This is not something new which we are going to tell, but because of our schedule, because of our busy pattern, we keep on neglecting these things. But let me now start with this. This is science of self-realization. So what is science of self-realization? So this is science of self-realization, and in this we are going to discuss body-mind connection. Now you must be wondering why we need to understand this body-mind connection. Are we this body, or we are mind, or we are something beyond it also? We don't know. So that's what we are going to explore today. And this is, for this you will definitely ask that are there some books, or where do we get this knowledge from? We have medical books, we have law books, we have management books. Where do we get this knowledge? Where do we study these books? Well, before studying these books, there is an more important question is that why do we need to understand this? What is the need? See, in management, there is one common funda. What they do, before launching any of the product, the need is created. No need, no customer. So they create a need. That is done by media, by raising social campaigns, awareness campaigns, and by that, the need is created in the market. Once the need is created in the market, what companies do, they come up with a product. Because by that time, they have already done their homework. And so this need, that is very important, that why do we have to have this topic, or why we are discussing on this subject. Say, for example, if we take a very small example, Indians never used to drink tea. But what Brits did, Britishers, they came up with an idea. And they told Indians that, well, you need to drink tea. You will feel fresh. You will not feel lazy. And by that, they started giving free tea to Indians. And by the time the need was created, they came up with the tea. And now we can see that tea is being sold in each and every corner of the whole world now. This is how it started. Forget tea. If we come to very simple things, say, for example, career. There are some people who come from a very wealthy background. But again, that need is created. The children, they are told that, once you have if you don't have a social status, this voice is echoing too much. Hello? Voice is echoing too much. So that need is there, that they tell them that, theek hai, you are coming from a very wealthy family, that is good, but there is something which is missing. You will not be having a social status. You will not settle properly in life because you will not have any identification. And then you will not get better proposals, marriage. You will not be able to settle in life. So you need to study. That's why so many colleges, so many institutes are coming, because that need has been created like that. Similarly, there is a need for this topic, body-mind connection. And my job is I have come here to create that need for you all. That we need to understand body-mind connection. And for that, why this need has come for us and why we are coming here for this topic, that is, first of all, the temples, they are all empty. Churches are empty. Mosques are empty. In fact, all religious places are empty. Why? Because we don't feel the need. We say, मेरी life तो चल रही है. Why should I waste my time? This is a common thing. कि मैं क्यों अपना time waste करूं? मेरी life चल रही है. I'm doing pretty well. I don't need this. So, but there is a need. और वो need क्या है? That need is what we are going to discuss today. So need is the first and foremost is, till today we don't know who am I. Say for example, if I ask you, who are you? Your answer will be, I'm Dr. So-and-so. What's your profile? I work with Max. I'm a cardiologist. That will be your, and at the most you will say, I'm an Indian, I stay here, blah, blah, blah. So that's your identity. That's what you say, who am I? Now, on the contrary, if I ask somebody, who are you? And he says, I don't know. If I ask him, what's your profile? He says, I don't know. Where from you have come? I don't know. So what we will call such person? We'll say he is mentally disturbed, isn't it? Because he doesn't know anything about himself. So who am I? This is most important thing which we are till date not aware. And Bhagavad Gita starts from this only. In fact, the scriptures, they start from this. That is, Atatho Brahma Jigyasa. This is the first sutra in Vedanta. Atatho Brahma Jigyasa. Who am I? We need to inquire, who am I? Now, again, you must have heard this term, identity crisis. So, identity crisis is identity crisis, this is a very big term in modern psychology. There are identity crises at every level. There is a gender identity crisis, sexuality. And because of that, in Swiss countries, especially that Nordic belt, now what they are doing, they are making children to wear frocks and knickers alternatively for them to decide whether he is a boy or a girl. So this problem is, a common problem which has started already in Europe and other countries. Nordic belt and all, they are having this problem. So that is gender or sexuality. Then again, a crisis, this identity crisis, that can come at a social level. Now at social level, what happens? See, the poor people, they don't have their identity. Because they feel that absence of what? Because they are not, well settled, they don't have a social status, they don't have a social symbol, so they feel that. So they have that identity crisis. Then, if we come to these orphans, they have identity crisis. Why? Because they feel that they are not clear about their parentage, definitely. So at social level, they feel this. Then, after social level, there is one more level, that is mental level. If you don't do anything in the life, what will happen? We'll say, मैंने तो कुछ किया नहीं, I'm nothing. So because of that nothingness, again we feel that identity crisis. And last, which is very important, that is at spiritual level. At spiritual level, we don't know who we are. Now, if we know who we are, and if we don't know who we are, how it's going to make difference? That we will understand. See, if I ask you all, are you happy? What will be your answer? Are you happy? Yes. Okay. So you are happy. Yes. Are you satisfied? Are you peaceful? You are not. You are happy, but you are not peaceful. You are not satisfied. So that means you don't have a real happiness. You don't have a real happiness. Now you must be thinking, what is this term I have coined? Real happiness. Happiness is happiness, so what is this real happiness? Well, real happiness means our happiness that is dependent on external objects. On iPhone, my friends, my family, my relatives, my society. If any of these external object is missing, what will happen? We'll become sad. Because we are not really happy. That real happiness is not there. So that's why we feel, because we have become slaves of these external objects. We have become slaves. So this is not the real happiness. Real happiness is when we are not slaves of external objects, we are independent of external objects, and we are internally happy and peaceful. That is the real happiness. But that comes within. That's why, there is a difference. If we are made to sit in one room for maybe few hours, we will not be comfortable. But a saint, he can sit in one room for hours together without getting disturbed because he is satisfied within. That within he is satisfied and peaceful, so he doesn't require anything extra. This is the difference. So we are not really happy. We don't have real happiness. We are happy, and our happiness is dependent on external objects. Okay, you all agree with me? This is the scenario. This is what is happening with us. We are not really happy because we are not peaceful and satisfied. And even for material success, it's not for only saints. Even for material success, if we want to be materially successful also, we have to have this peace of mind. We should be satisfied. We should be satisfied. What we have, that only we can give to others. What we don't have, we cannot give it to others. So we have to be peaceful and satisfied within. And this, to be satisfied and to be happy, to have that real happiness, this again comes from where? It again comes from Bhagavad Gita. Bhagavad Gita is basically a law book. Bhagavad Gita is the only book which teaches us how to think, how to talk, what kind of speech we should have. We should have respect for others. All these things are coming from Bhagavad Gita. There is no school, there is no college which teaches us, but it is Bhagavad Gita. That's why Bhagavad Gita is a life manual. Please mind it, Bhagavad Gita is not a religious book. Till today, मैंने उसमें कभी पढ़ा नहीं कि भगवद गीता हमें सिखा रही है घंटी कैसे बजाना है. I have never read in any of the chapters in Bhagavad Gita. It's a science book, but the thing is, we need to understand it from that perspective. It's a science book, and it's Bhagavad Gita which tells us how to think, how to talk, how to speak, how to give respect to others, which nobody is teaching us. But it's Bhagavad Gita which tells us all these things. So what exactly happens when we know how to talk, how to think properly, how to behave properly, how to give respects to others? What happens with that? That is what makes us a human. We claim to be humans, but are we really humans? Actually, it's the other way around. We are worse than animals. We are not even humans. And human means manushya. Manushya means man plus ish. One who has controlled his mind, he is manushya, he is human. Now see for yourself, where do we stand? This is the definition of a human. Human means manushya, man plus ish, one who has controlled his mind. If we have not controlled our mind, then we are as good as animals. So this thinking process, this is very important, because what happens when we are thinking properly with good thoughts, what will happen? It will make our behavior. Our behavior is going to make our character. And our character is going to make our personality. And it is the personality with which people recognize us in the society. So where from it started? It started from that thought. It started from that thought. So that's very important. This makes our whole life, and this makes us human. And then this identification is what we carry with us. That this is my identification. That's it. But now again coming back to the subject, now we need to understand, okay, this is what is the background, why we are here, why we want to be happy, what is real happiness. So after having this as an introduction, now we will come to the main topic, that is how we can be happy. For that, what we need to know, that is first of all, we need to understand that we are not this body. We are not this body. Now what is the proof? You will say, what is the proof that we are not this body? ये body तो है, और क्या है? But what is the proof that we are not this body? Well, we are not this body. One is called a simple, which is common sense. By common sense, we can understand we are not this body. How? This body has been growing. Few years back, we were child, we became youth, then we became adult, and after this, we'll become old, we will become diseased, and finally, we are going to die. So this cycle of birth and death, it will continue. What is changing? The body is changing. But something is there which is not changing. And what is that something which is not changing? That is I. That I-ness is not changing. But body keeps on changing. See, if we see our pictures of our childhood, we will not be able to recognize ourselves. But that I-ness is not going. That I-ness is still there. But the body is changing. And this concept is, again, it comes from Bhagavad Gita. And Bhagavad Gita chapter 2, Krishna says, Dehi nasmi yatha dehi kumar yovnam jara, that this body keeps on changing. So don't spend too much of time on this body. Yeah, bare minimum maintenance and other things to keep on going. But don't spend your complete energy on this body. This body is going to perish, it will die. It will die. Then second thing is, what is the proof that we are not this body? That is linguistic way. See, language. If my hand is paining, what I'll say? I'll say, doctor, my hand is paining. My foot is paining. I will never say my eye hand paining. Eye foot paining. I'll never say that. I'll say my. So that means there is something. See, this language, that language is very important aspect of a society, of a civilization. Because language, it is coming from where? It is coming from your personality. Personality comes from character. Character comes from thinking. So this whole loop, this whole chain is there. So language defines the culture. Language defines what kind of person he is. If he is, using a bad language, slang words, so we immediately say he's a third-class person. But if somebody he has this understanding, he will use good language, so he is called gentleman. Then next proof is sleep. See, every day we are sleeping from 6 to 8 hours. Body is completely disconnected, but morning we get up again. Then who is this? This is me, I. 6 to 8 hours, complete disconnect. Body is lying on the bed or floor or wheresoever. It's completely disconnected. But 6 to 8 hours, we are again coming back. This is I. That I-ness remains there. Well, these are very common and, logical proofs. But now if we come to the scientific background of this, I'll explain you that also. There was this mathematician or a philosopher, René Descartes. René Descartes was, when there was World War II going on, this René Descartes, as a philosopher, as a mathematician, what he saw, that time people were forced to join the army because World War II was going on. And what he saw, that people were supposed to join the army and then they were killed and massacred like anything and bodies were lying. That made him to think. And that brought a revolution, very big revolution in philosophical cycles. He wrote a book that is called Meditation. In that book, what he said and what he wrote and what he felt, he said, well, one thing is there. Understand, we are not this body. Okay. So who are we then? He said, well, we can doubt on everything. We can doubt the universe is not existing. The sun is not existing. Moon is not existing. Even we don't have this body is not ours. But something is there. What is that something? That something is maybe we are thoughts. Because we are thinking. So maybe we are thoughts. As simple as that. So in this book, Meditation, he came up with one quote which is quoted everywhere. I think, therefore I am. And this is called cognito ergo sum. You can Google it down. Cognito ergo sum. So this brought a big revolution in philosophers. Yes, what he is saying, that makes sense. But immediately scientific community came up with something else. What did they say? Well, you all are all aware because you are from medical field. So this is organ transplant. Organ transplant for heart transplant, first heart transplant was done in 67, 3rd December 1967 by Dr. William Bernard. Before that, no heart transplant was done. So this was the first heart transplant which was done. And what he did when the heart was transplanted and patient came back to his senses and he was asked, who are you? He could say he was the same person. He was the same person. So that means that we are not this heart because that person is the same person. He is fully aware who he is. After surgery also, after transplant, nothing happened. The person remained the same. So this brought again a big revolution. Then there is this brain transplant. Brain transplant, Dr. Bruce Williams, he and his team, they are conducting a research and they are very positive that by 2030, we will be able to do this brain transplant as well. Then comes the head transplant. Head transplant, that was also done in 1907. And this Charles Guthrie, he did a head transplant for a dog. And again, the research is going on, but for head transplant, there are certain other issues also, so it's not that simple. But for us, we know that this is also not very difficult. Reason being, Ganesh ji had a head transplant. Daksh Prajapati, he had head transplant. Goat's head was transplanted. So that means this head transplant, it is not new for us. It has been there for ages and for centuries together. But scientific community, they feel that this is something which we are going to work on. But these things have already been done in ancient times. We had surgeons, very good surgeons from time to time. Now coming to certain cases of brain. See, when you take the EEG of a brain of a normal person, what happens in the normal brain if you take EEG? There are 4 stages. Stage 1, stage 2, stage 3, and stage 4. So this is when the person, you have the waves, that is in beta stage, when the person is awake. Then next stage is alpha stage, where the person is listening to music or doing some activity. Then is theta, where person is about to sleep. And the last is delta, where the person is fully under his sleep condition. But now, if you take coma patients, when we talk about coma patients, what happens to the coma patients? Coma patients, they are brain dead. They are brain dead. But what's happening? Once they come back, they know who they are. Or even for that matter, patients who are in vegetative state. These patients, they have the hearing power. They can hear. And there is one, Dr. Michael Egnar. Dr. Michael Egnar, he's a neurosurgeon, and he has done so many studies, and he has found that there are certain children who have split brain, but they are functioning properly. Even they have seen that there are patients who don't have 99% brain, but still that person is functioning. He is having his normal activities. He is doing his day-to-day activities. So what does this conclude? This means that we are not even brain. And not only this, there is one very famous case for which scientists are still confused how it happened and why it happened. That is Pam Reynolds. So this Pam Reynolds, she was a musician and she met with a terrible accident. And after her accident, she was brain dead. She was not having any activity. She was rushed to the hospital and her surgery was performed. And it was a very complicated surgery. But once the surgery was done and she came back to her senses, she could tell each and everything to the doctor. how the surgery was done, what all things were happening on her. She could reveal each and every detail. And scientists are still wondering. You can Google it down, Pram Reynolds. It's a very, very famous case because scientists are still wondering that how it is possible. And it's not only Pam Reynolds, there is Dr. Stevenson. Dr. Stevenson has done almost 2,000 cases, and in all 2,000 cases, what he has found that NDs, near-death experience, he has seen that people, they report NDs, they leave their body, and once they come back to the body, they are frustrated because they feel, when we left the body, we were feeling very happy because it's all light there, it's good music, soothing everything. But once we come back to this body, we feel very suffocated because it's all dark inside. So these are the common observations of patients who have NDs. And there is not a one case or two cases. There are so many cases of NDs. Now, after this Pam Reynolds case, we are now clear about heart, about brain, about head, that we are not thoughts, we are not. So finally, we have come to this conclusion that we are not this body. Then who are we? This is again, a question remains there. Now, before exploring who are we, let's take it other way around. Who we are not. And this is called, in Sanskrit, niti. And in psychology, we call it selection or exempt. That is who we are not. Now, who we are not, that we have already discussed, that we are not this body, we are not thoughts, we are not brain, heart, we are not this. So we are something above. And what is that something which we are and which we are not? So what we are not? Now we have come to that we are not body. Now the next part is that we are we mind? And for all the spiritualists, what they are doing? They are trying to control mind. And to control mind, there are various processes. Say, for example, some people, they do meditation. Some people, they do Kundali Jagran. Some, they go for Dhyan Yoga. Some go for Raj Yoga. We in ISKCON, we do Japa, mantra meditation. We chant the names of this Hare Krishna. We chant Hare Krishna mantra. And the purpose of doing all this is to control the brain. To control the mind, sorry. To control the mind, we are doing these practices. And if we are out of control, you know what's going to happen? There will be havoc in the society if our mind is not controlled. Mind control is very important for students, for teachers, for leaders, for community heads. This mind control is very important. And this mind control is which we are doing by these practices. That is the practice. Because ultimately, mind control, in mind control, there is one specific thing. It's only the humans who have given a unique ability to control. Animals, they cannot control their mind. But we as humans, we have the power to control mind. And to control the power of mind, it's very important as it's a unique gift. This gift can, bring us up, and the same gift can bring us down. How that is possible? Because we have this controlling capacity. We can control our desires. We can control our hunger. We can control our thirst. We can control everything. We have that power. Animals, they cannot do this. They don't have the controlling capacity. So the culture is driven by control. If there is no control, there will be havoc. See, we all are sitting here in this beautiful room. Why? Because of that control thing. Otherwise, maybe some of you are not interested, but you cannot leave because there are etiquettes. But if animals are here, they will not take 1 second. They cannot sit for 30 minutes. They will leave within 1 minute. Because there is no control. They cannot control they work on reflexes. But we have the ability to control. So we need to control our mind. Again, this mind control, it comes from Bhagavad Gita. Bhagavad Gita, Krishna says that mind is our best friend and mind is our best enemy. It's up to us how do we use it. So now, coming to the final, that who we are, the question still remains. The question remains that are we then this mind? Well, we are not mind. Why we are not mind? Because mind can be controlled. So we are not mind. So who is controlling mind? That is what we call Atma. Some call it soul. Some call it chi energy. And scientists, they have come up with the term consciousness. So there is a big field that is quantum physics. I'm not going into that details, but there's a field, quantum physics. Scientists are working on it. What is this consciousness? Where does it reside? Is it outside? Is it inside? But there is something that all these scientists have come to this conclusion. Spiritualists were saying from time to time, well, we are not this body, we are not this mind, we are not this, but nobody used to take them seriously. But now it's coming from scientific community and such a research is going in quantum physics. So people are now started thinking, yes, there is something that is Atma, that's soul or consciousness, what scientists call it. Now what we are supposed to do? We are supposed to break what? That connection, what we started with, the connection, mind-body connection. We have to break that connection. Once we break the connection, body-mind connection is broken by doing these meditative processes, what will happen? The soul, which is, trapped in this body, it will get liberated. Once the soul gets liberated, what we will have? We will get that real happiness. Unless and until soul is trapped in this body, we are not going to get real happiness. Because this body is going to die. There are so many things. Body gets diseased. So many things happen to the body. So soul is not comfortable. Once the soul gets liberated, that is done only when body-mind connection is broken. Soul will get liberated. Soul gets liberated, what will happen to us? We will feel eternally happy, real happiness. We will be peaceful. We will be satisfied. What we have, that we can give to others. As simple as that. So once we have this, we can tell others. See, we are also from scientific background. I'm myself a senior research scientist, and Dr. Riyush, he himself is a doctor. We are from this medical field itself. But we have studied these books and we have come to this conclusion, yes, this is something beyond this, material thing what we are taking up. It is something beyond this, and what is that? That is this spirituality. Spirit, from spirit comes spirituality. So it will not take anybody 10 to 15 minutes daily. No doubt we can say, mera schedule tight hai, ye hai, wo hai. But 10 to 15 minutes we can take from our schedule and we can do some meditation. We can do some meditation. We can read Bhagavad Gita. Because this is the ultimate benefit. Because by this only we are going to break this body-mind connection and the soul will be liberated. And ultimately the purpose of life is what? Ultimately the purpose of life is that we should be peaceful and satisfied. That's it. So that we will get only once we break that connection. So it's my humble request. Please you all think over it. Give 10 to 15 minutes every day. We have some Bhagavad Gita and some books. If you can have a look and you can take those books and get the eternal benefit for your life. So by that, what will happen? Ultimately, the soul will be happy when it goes out from the body and the mind. Thank you so much. I don't know whether it makes any sense to you all, but if you really think into it and give it a thought for 5 to 10 minutes, you will understand that everybody of us wants to be permanently happy and satisfied. So please do give it a try. That's my request to you all. Thank you so very much for giving your time. Thank you.
Thanks a lot. Thanks a lot. And any questions or any suggestions, any remarks? Dr. Riyush want to say something, I think.
So in Bhagavad Gita, Lord Krishna says, Janam Mrityu Jara Vyadhi Dukha Doshanudarshanam. He says to Arjuna, Arjuna, just analyze this material world. There is birth, there is death, there is old age and there is disease. So It's a dukha doshanu darshanam. Please analyze, these are the dukkhas, these are the problems of real problems of our lives. Birth, death, old age and disease. How to get out of the cycle of birth, death, old age and disease, that is the purpose. Krishna says, I am giving you the solution, Arjuna. Take this solution from me. So this science, spiritual science, we are busy in solving our temporary problems. But the real problems are birth, death, old age and disease. We are, as Madam said, we are the spirit souls. We are beyond this body. We are not this body. We are not this mind. We are not this false ego. We are beyond that. And that is the soul, which is so atomic, which is residing in our heart. And which is from there, the consciousness is flowing through our body. That consciousness, like sun is at one place and the sunlight is going in all the solar system. Similarly, the soul is there. It's very atomic, very small. Anu. Esha hi anu atma, Upanishad says. And the soul, and from that is flowing the consciousness, the life-giving force. The life-giving force. That you have to go to the depth of our existence actually. Our existence is because of the soul. You cannot, a dead person, you cannot put some chemicals into that body and then his consciousness will not come back. Because the soul is not originating from any matter. Soul is from the spirit soul. That consciousness, the consciousness is not originating from any matter. It is originating from the soul, which is a spiritual spark, a living spark, which is there in your body. And which is transmigrating from one body to another. That is the biggest problem we have. So we are in anxiety, we are in stress. Why? Because our existence is permanent, we are soul, but we are misidentifying ourselves with this body and mind. So we think when something happens to the body or mind, we think it is happening to us. And we get affected, we are in so much anxiety, stress. But once we recognize, that is what Arjuna said, I will not fight. Because he's saying, he's my grandfather, he's my guru, they are my relatives, how can I kill them? This is the bodily concept of life Arjuna was in. And Lord Krishna first, in the very second chapter, he says, come to the soul. He says, Ajo nitya shashvato yam purano na hannate hanyamane sharire. Arjuna, you are not this body, you are the soul. First, the very first chapter, the first lesson, he takes Arjuna to that platform of soul. And then another things happen, So first, we should have this understanding of soul. And that is a spiritual science. We have the material science and then the spiritual science. Material science deals with the body, with the diseases, with the old age, whatever sciences. That is called aparavidya in Upanishads. Material science. And the Paravidya, which is spiritual science, which is not taught in any schools, not in your colleges, not even in your medical science. It is beyond this body, beyond this mind. That is the Paravidya, the spiritual science, the science of the soul. So with this, I will not say much.
Thanks a lot. Thanks a lot. You have said so much. Sir, want to ask something? Yes.
बहुत अच्छा लगा आपने हम लोग गीता को अपने देवताओं को पूजते हैं लेकिन उनके जो कई बातें को उनको मानते नहीं हैं, समझते नहीं हैं। वैल्यू बेस्ड एजुकेशन हम समझते नहीं हैं। मन तो ज्योत स्वरूप है, अपना मूल पहचान। एक पिता एक किसके हम बारक, हम सब भाई हैं, हम सब वो सोल जो आपने बताई है वो, और मन को शांत करने गुरु नानक ने जपजी साहब में कहा मन जीते जग जीत। अपने को मन को जीत लिया तो जग को जीत लिया, जो आपने कहा है सारा। और अगर हम बच्चा पैदा होता है माता के ओम से स्पर्म से, तो उसमें कौन वो आत्मा वो सांस कौन देता है? वो सांस जो है वो ऑलमाइटी भगवान देता है। हर एक सांस के साथ हमने उनको जपना है। जो गुरु नानक ने कहा, जो उसने कहा कि गॉड की गॉड क्या है? एक ओंकार सतनाम कर्ता पुरख निर्भव निर्वैर अकाल मूर्त अजूनी सहबन गुरु प्रसाद। गुरु के प्रसाद से आप एक ओंकार को आप समझ सकते हैं और अपने मन से उसको कैसे समझना है, उसको कैसे दरबार देखना है। अमृत वेला सच नाम वड्याई विचार। ब्रह्म मुहूर्त अर्ली मॉर्निंग में बैठ के आप उसकी वड्याई करो, उसकी सब दुनिया में क्या बनाया है, आपको क्या दिया है, खाने को दिया है, सब कुछ दिया है, बच्चे दिए हैं। बच्चों को सबको समझो, लेकिन अपने आप को थोड़ा सा सेपरेट करके रखो। इसमें सत्य, संतोष, दया, धर्म और धीरज, इनको अपने अंदर बसाओ और काम, क्रोध, लोभ, मोह, अहंकार को बाहर निकालो। ये काम, क्रोध, लोभ, मोह, अहंकार चाहिए दुनिया में विचरने के लिए, लेकिन अगर आप हर एक सांस के साथ अपने धर्म के मुताबिक हरे कृष्णा हरे रामा वाहिगुरु अल्लाह बोलते रहोगे, जो सांस बड़ा कीमती है वो इम्पोर्टेंट है। मेडिटेशन बहुत ज़रूरी है, लेकिन 24 घंटे हर एक सांस के साथ तो आदमी है एकदमी, एक हर दम जो है बड़ा प्रेशियस है। उसके साथ आप हरे रामा हरे कृष्णा ओम नमो शिवाय वाहिगुरु ये बोलते रहो। वाहिगुरु जी का खालसा, वाहिगुरु जी की फतेह।
Thank you. Thanks a lot. Thanks a lot, Anuji and Dr. Rayush for this session. And we are obliged again. I am obliged that it is for 10 years, and we all wait for this session always. So for felicitating, basically, I want that please come on that side. So yes, Dr. Amitesh.
Sir, I had just one question.
Dr. Rayush may answer.
With the speaker. Ma'am, we are talking about Gita. You are quoting Sanskrit scriptures. You are telling about the shloks in Gita. But whenever you talk about the Hindi words, why you need to have a Western nuances of adding an A as a suffix in all this? Is it dharma or is it dharma? Is it Arjuna or it is Arjuna? It is japa or it is japa? Well, why that Western nuance has to be there when you are quoting it in Hindi, but you want to pronounce it in Sanskrit in a legible way? So I failed to understand why you used to the Western pronunciation in the teaching when you are talking to the Indian audience.
Actually, the word A, it naturally comes after every word. A is there in every word. So it is like you say dharma. Even if you say dharma, then dharma and dharma is same. Like if we say Hare Krishna, so we don't say Hare Krishna, we say Hare Krishna. Because when we say Krishna, then it is a striling. But when we say Krishna, it is a purling. So there's so many answers to these A and A. But it says that the whole world is created from this word A, Om. When you chant Om also has A in it. A, U, A-U-M, A-U-A. So it starts from A. So the whole world is created from a. So when you add a after every word, then it is a complete, it becomes the complete word actually. Otherwise it will remain incomplete. Hare Krishna. Yeah. Okay, but I am saying yeah, yeah. See, yeah, actually in Sanskrit, is, as I said, is a purling shabd. And is a striling and a is the purling shabd. Matlab, masculine and feminine. It can be both, but the pronunciation is like that. Like is added, even in Sanskrit. हाँ तो कृष्ण ठीक है उसमें भी उसमें भी आएगा कृष्ण भी बोलेंगे उसमें भी आएगा आ नहीं आएगा नहीं आएगा
Let me say something. There are few words which can never be translated in English. Like they say Saul. Saul का मुझे नहीं पता, Saul कोई स्पेशल चीज है, कोई स्पेस है, कोई जगह है, क्या है. आत्मा का मतलब होता है सेल्फ, परमात्मा का मतलब एब्सोल्यूट सेल्फ. सेल्फ कैन नॉट बी ट्रांसलेटेड एज साउल. तो इसीलिए भगवत गीता में सेल्फ कहा गया है, जहाँ भी सेल्फ रियलाइजेशन है ना, साउल रियलाइजेशन नहीं. तो बहुत सारे वर्ड्स भगवत गीता में ऐसे हैं जिनको धर्मा भी जैसे है, धर्मा इट कैन नॉट बी ट्रांसलेटेड रिलीजन. तो सो मेनी वर्ड्स कैन नॉट बी ट्रांसलेटेड एट ऑल इन एनी अदर लैंग्वेज एक्सेप्ट भगवत गीता itself.
Except Sanskrit. Actually all the languages are they have originated from Sanskrit only. All Russian, Japanese, Spanish, all languages they have been originated from Sanskrit language. It's the original language actually. So I will tell you the answer. Maybe I am not able to satisfy you, but I will.
मैं एक सेंटेंस और बोलना चाहूँगा. वो एटॉमिक बम का जो आविष्कारक था, क्या नाम था उसका, जिसकी मूवी भी आई अभी. He went to study Sanskrit to understand Bhagavad Gita 100 years back. Oppenheimer.
Yes.
चूंकि he could not relate it in English in his own language, so he had to learn Sanskrit to understand Bhagavad Gita. What exactly is its spirit?
So thanks a lot, and it was a great discussion. Thanks a lot. So we are on the fag end basically. Dr. Amitesh, could you come also for felicitation please? Yes.
Okay, thank you.
So एक बार बस पीछे चला दो, फिर मैं वेलकम एड्रेस. We'll be going through in 2 minutes only. Please, next. So this is IVUS or FFR, or these are some of the angioplasties. This is basically the IVUS which has come. We are able to do the stenting with the help of inside seeing the arteries. This is called as the IVUS. This is the temporary heart support, which is usually sometime required for doing in cardiogenic shock or BP is less. So these are new things where the heart can be pumped with the impeller support. And this is one of the procedures. Pacemaker is used to say it was a large pacemaker which was installed here, but leadless pacemaker has come, which are the size of, although there are specific indications for these leadless pacemakers, they are size of a vitamin D capsule, but they are done in specific conditions only, not in every cases. So, but it can be done if patient having recent infections again and again because of some pacemakers, the larger ones. Then the smallest one, this is the pacemaker, which is just like a capsule in the heart. We have done some time back. Then the valve now can be replaced with the non-valvular treatment also without surgical. You can do via the thigh, this femoral artery only. The valve can be replaced. This is called as the tower. So this is one of the case we have done. So here the valve are replaced. This is the valve which can be put now. It is not required that you have to do the open heart surgery. You can do it from the femoral artery only. So
These are some of the recent advances. I went through it in a quick because you all have been very patient with all of us. So thanks a lot. So we will almost everybody is tired now. So I am thankful to all of you and just concluding this session. So thanks a lot to everyone for coming, for joining. This was our 10th effort, and I am thankful the persons over here. Dr. Prakash Gera sir usually comes always with all the commitments. Everybody which has given time, we are again thankful from the bottom of our heart for the time you all has given to us down the years, and we are hopeful that we will, if Almighty we will be able to do again also. But thanks a lot to everyone. Thanks a lot to Dr. Sachin also, Dr. Namit, our team, and unsung heroes which are here. So thanks a lot. Thank you. Dhanyavad. Thank you. You can take. तो पिताजी हैं, मेरे पापा बैठे हैं, सब उनकी वजह से है. तो सब ईश्वर की और पेरेंट्स की वजह से होता है वो. ये तो सब पार्ट है. ठीक है. So nice of you. So nice. Basically, some of them who has not got the memento. So if anybody has not got the memento, please come on that side. We want that everybody should go with a memento of appreciation, please. चाय है पीछे रोके. We can take a tea break also. Sir, thanks a lot. Sir.